మీ పేజ్లో ఉంటాయి సార్, మీ పేజ్లో డైరెక్ట్ వచ్చేస్తుంది
Hmm?
మీ యూట్యూబ్ పేజ్లో డైరెక్ట్ వచ్చేస్తుంది.
దీంట్లో ఉంటుందా?
మీ యూట్యూబ్ ఇది
ఏది ఇదే? దీనికి కొట్టి దాన్ని
క్లిక్ చేసేస్తే ఓపెన్ అయితే షేర్ కొట్టేయండి. షేర్ ఇది దాంట్లో టాక్స్ నిన్న బాగానే ఉన్నారు సార్, 1200 మంది ఉన్నారు.
నిన్న
వ్యూస్ 200 వ్యూస్ వచ్చి
1200
వేరే వేరే దాంట్లో ఓపెన్ చేస్తుంది సార్, 200 వచ్చింది నిన్న. అది మీరు దాంట్లో పెట్టండి సార్, ఎవరు రాని వాళ్ళు చాట్ చేసి కొందరు చేస్తున్నారు చాట్.
నిన్న అడిగితే
చాట్ చూసేసుకొని లేకపోతే నేను అక్కడ ఓపెన్ చేసి క్వశ్చన్ వస్తుంది
అదే బెటర్.
అది చేస్తా. ఇంట్లో కూడా పెడతా. నాగరాజ్ అండ కూడా మనకు ఓపెన్ చేసి పెట్టు. చార్ట్ ఏదైనా వచ్చింది అని క్వశ్చన్ సార్కి చెప్పేస్తే సార్, ఎందుకంటే సార్ ఈ క్వశ్చన్ రాగానే మీకు చెప్తాను, నాకు చూసేసుకొని.
స్టార్ట్ చేసేద్దాము.
రెడీ సార్ మొత్తం.
ఓకే.
ఫస్ట్ ఇదే సార్.
Good morning, everyone. Welcome to Spinoscope 2025 Day 2. Because of our faculty missing their flights yesterday, so we have to reschedule the talks. And Dr. Ajay Krishnan is a senior spine surgeon from Ahmedabad. Couldn't make it because of the flight cancellation. So he has sent his talk online. So we'll be starting with his talk today. So today will be more focusing on spinal tumors. So endoscopic monoportal surgeries on spine tumors. So we will be showing two surgeries today. One small tumor and one large tumor. So the small tumor was few millimeters and the large tumor was 6 centimeters. We could remove entirely with monoportal, and we also show you the suturing techniques, how to do endosuturing and how to apply endo clips today. Then also we'll be showing the different fusion techniques which are practiced nowadays, and also thoracic ossified ligamentum flavum surgery, how to remove en block ossification through monoportal techniques. These are the surgeries today. So we'll start with Ajay Krishnan talk from Ahmedabad. Volume ichera.
Now, the pathophysiology of the lateral recess stenosis, you have to understand the anatomy itself. It is bounded anteriorly by the vertebral body, posterior-superior aspect of the inferior vertebral body with the disc there. Posteriorly, it's the superior articular process, or I would add the lateralmost part of the inferior articular process as well. And laterally is the pedicle. And anything narrowing that happens would lead to a stenosis. So that could be a static component as well as dynamic component. This seminal article is not to be forgotten by Manohar Punjabi and Said Usman. They have compared the transforaminal way of addressing the canal, at the same time the intralaminar way, and it has clearly shown up that more space opens up in transforaminal surgery without adding to any instability in flexion and rotation. So that was the conclusion of the study. And we ourselves, as we're working and evolving in our transformational journey, found out that By transforaminal access, you can address almost all the ventral pathologies to the dura. At the same time, on the same side, you can address everything what is arising from the facet. And just see on these images on the left and the rightmost side, there you can see in a listhesis also, you can remove the posterior corner of the vertebral body and the disc. At the same time, you can remove the ligamentum flavum posteriorly, and you can make a cord free in a stable listhesis. This we are able to do because we are exactly sitting there. We are sitting there in the foramen, and we are able to address both the ventral and the dorsal pathology in a lateral canal stenosis. We know the clear disadvantages of an open surgery and microlumbar decompressions, but at the same time, evolving interlaminar endoscopy and the UBE have significantly contributed, but general anesthesia requirement always remains there. And the evolution of the minimally invasive spine surgery techniques have been with in 1990s the early endoscopy, in 2000 the technical refinements, in 2010 the laser integration, and 2020 there are more mechanical tools which have come there. And this image, which has become famous over the years, in the last 5 years, specifically, you can see the screws which is there. So it is the Campbell's triangle. Everybody is approaching everything through the Campbell's to fuse the spine. And we all know to reach to this Campbell's triangle, you can come at an angle of say 0 to 20 degree also, and you can approach at 50 degree also. So the concept, what is changing for the lateral recess stenosis is that you have to come specifically at an angle which is more steeper, so that you address the facet first, that is the bony Campbell's triangle, to have a safe margin there and create a space for the neural Campbell's triangle. The patient selection would always be anything which, even though a central stenosis or bilateral stenosis, has to be unilaterally symptomatic. The preoperative assessment is with MRI analysis, CT analysis, and even trajectory stimulation you can do. Local anesthesia remains the mainstay with infiltration and continuous communication and sedation. Step-by-step surgical approach is always the same way we approach, that is positioning, fluoroscopic localization, needle placement, sequential dilation, putting the endoscope there under gravitational irrigation. Now we may come and think that what we want to do is an inside out approach or an outside in approach. As a transforaminal surgeon, you have to keep on thinking what works better. And essentially, the most important thing what needs to be done is a foraminoplasty. I have stopped doing blind foraminoplasty, and I am a proponent of visualized bird foraminoplasty. And visualized bird foraminoplasty gives you a complete opening up of the area of your interest. And the decompression sequence is first the soft tissue clearance of the facet. That is what is done. Then you make use of straight burr to burr the facet. Then you go on further and enter into the disc if needed to remove the discal part, the shoulder osteophyte, the spur, and the annuloplasty is done. Then you again withdraw out and you see the ligamentum flavum curtain there, and that is to be removed by mechanical instruments or laser. And then is the final step of verification of the decompression steps. So this is a straight burr which you use to burr the facet, and as you burr the facet, you know that you don't have much of mobility once you have landed on the facet. So you are using a straight burr and you are coming front and back. At the same time, if you want to do more, then you have to move the scope and you have to do the foraminoplasty, as you will have more wider arc of movement. And laser is the utility tool in this because it adds more precision, more specific removal, and at the same time less bleeding and expedites the thing. And the settings which you use is 15 to 30 watts, which is used, the frequency of 5 to 10 and 1.52 joules. I have the Conta laser which is with me. At the same time, this articulated burr is the single instrument which has helped me to go on to the next level of the lateral recess decompression more easily. And this all is leading to nothing but an expanded dynamic foraminoplasty. What happens is with the foraminoplasty, there is horizontalization of the endoscope, medialization of the endoscope. You can do rostralization or caudalization, and this helps in significant mobility, unlike the usual approach wherein the scope gets fixed. So it's a joystick, and with articulated instruments, it becomes significantly good. Now, this is a video which shows after the foraminoplasty bony part with a straight drill and then going ventrally into the disc, doing the ventral decompression part and removing the shoulder osteophytes. Then you come out again and then you start ablating the ligamentum flavum curtain, and this is a process which takes few minutes, and you are able to decompress it significantly. You can see the traversing nerve root there. You can use Carrison more to remove it whenever it is not clearly differentiable from the lateral recess. Then you can use the articulated burr again at the facetopedicular region. You can use hooks to go more dorsal and remove the ligamentum flavum curtain. You can tear them apart and then again use the laser to decompress it completely. So this is the lateral recess which you end up decompressing. Hello everyone. Transforaminally, you can add the
వీడియో స్ట్రక్ అయింది. జనాలు వస్తుంటే మాట్లాడి కావాలి స్టార్ట్. So there is some technical glitch with this.
with the MR myelogram complete. And we have already defined the endpoints of decompression for lumbar transforaminal endoscopic surgery. And that is clear endpoints of decompression there. Complications are nominal or nil. Bleeding management can be needed or inadequate visualization, which needs some amount of fluid needs to be pushed in. That is the only complication which can create a small problem while in the surgery. Dural tears, nerve root irritations, hardly. Fluid exudation is a problem which can occur in some patients, like this patient. And there in the postoperative MRI, you can see the transudate fluid there. And this is the clinical picture of the patient. And you can see the significant amount of fluid which is there. But this all vanished into us without any afterward. Postoperative recovery is the same as in standard all cases, wherein immediate recovery is usual norm, and the follow-ups are in 1 to 2 weeks they are resuming their job. To take you through a few cases, this is case 1, a patient, a female, 4-5 stenosis there, and this is the post-operative decompression what you have achieved there. You are able to see on the right side lower image the lateral recess completely free of there. Same patient, if you like to see the parasagittal images on the left upper corner, what you see is the stenosed lateral recess, and on the right lowermost corner, what you see is the decompressed lateral stenosis. If you go more into the imaging of this patient, you can see the images what you have obtained, and to have more walkthrough, you can have the more fancy images like the CT and MR fusion with the MR myelogram completely clear there. For if you want to have measurements, so this is the CT post-operative, and this is the measurement of the opened canal, which shows up a wider canal, and at the same time you can see the lateral recess angle which has opened up. Another case, a male patient, an alpha S1 stenosis there, and he has been operated same way, and you can see the very well mobilized root there with the foraminoplasty and the ventral and dorsal decompression. You can have the post-operative image with the fusion MRI CT there and the actual MRI, which shows the complete decompression, cuts at multiple levels of the lateral recess showing a complete decompression. The myelogram completely opened up, and the measurements of the CT would show a 9.42 of lateral recess as compared to the opposite side, which was non-symptomatic, of 2.14. The same time, you see the angle of the lateral recess, which is 50° opened up, and it is just 13° on the opposite side. So this is nothing new. It is being practiced by many over the world, and these are few of the papers with good outcomes mentioned in the literature as Zenzo. My friend Koichi Sairo has already published and is very much vocal about full ventral facetectomy also, wherein you remove the entirety of the facet without jeopardizing the stability. But of course, these are the elderly group of patients which they are handling. And coming now to central stenosis, we have been talking about central stenosis and the decompression of the over the top decompression also in the posterior surgeries. But we have realized in our uh, uh, understanding of the pathoanatomy that once you have decompressed the ipsilateral lateral recess and the stenosis, usually there is a shift of the cord, And until unless there is a subarticular or a bony stenosis there, usually enough amount of space is getting created for the opposite side also. And this is what the transforaminal endoscopic decompression for the central stenosis by unilateral decompression also is achievable. And there is octogenarian patients who are getting immensely benefited by lateral rectus decompression. And this is the image which we are talking about, and we could address the facetal part of the decompression. We can complete the pedicular and the retrocorporeal decompression, and what we achieve here is a 270 decompression of the root. And that's why we were labeling it tangentially as 270-degree decompression of the lateral recess. Thank you so much. Thank you so much. I'm very sorry to be not being able to be there in the superb conference and the efforts all put by Mahesha and Sukumar and all the colleagues. Thank you.
Thank you, Ajay. Thank you. So we'll move on to the much awaited talk by Professor Martin Komm from St. Anna Hospital, Herne, Germany. So he needs no introduction. He has trained thousands of uh, spine surgeons, including me. So I was there. I visited him in 2019. So we all learned the art and techniques of posterior approaches of spine. So he will be talking on full endoscopic spine surgery, evolution and revolution. Welcome, Professor, to India. So I know it was a lot of pain to reach Hyderabad yesterday. So thank you very much for accepting our invitation.
Yeah, thank you very much for the kind introduction. Well, I will give you an overview about the evolution of endoscopic spine surgery, and it's also an overview about our own evolution. So when we, so it's not really working. Well, no. Yeah, but normally this is not a problem. So sorry for these technical obstacles. Well, there was a big change in spine surgery in the last decades. By introduction of the microscope, it was proven that we can overgo the problems of conventional operations, and it was proven that minimally invasive techniques can reduce the traumatization of the tissues. We started in 1999 with endoscopic surgery, first using the epiduroscope, and then there were some guys throughout the world working with lens optic systems with a transframal posterolateral approach. We rapidly saw that we have limitations for the optical quality, and especially using lens optic systems to reach the ventral epidural space. We are orthopedic surgeons. That means we wanted to transfer at that time all the advantages that we knew from arthroscopy to the spine. That means working under continuous irrigation and working with rod lens optics. So when we define evolution as a process of developing by gradual changes, the question is what happened afterwards. I've been first time in India in 2002 in Patna for the orthopedic annual conference. When you look at the topics of my talks, you find that the topic is quite actual, and it was 23 years ago. We implemented the term full endoscopic in 2005 in the literature, meaning we are not working through a tubular retractor, but everything is included in the endoscope. So the technical work was done by RevoSpine. We know the complete portfolio which is available at the market now to address all parts of the spine. Our work was to develop the approaches from the lumbar, following the cervical, and then the thoracic spine. So starting with the lumbar spine, first of all, we were dealing with radicular symptoms caused by herniations, later with stenosis. Nowadays, we are not only talking about a transframal approach, we are talking about a foraminal approach, which includes 3 different approaches: transframal, intra, and extraframal, always depending where's my starting point, which kind of structures do I visualize, and what can I achieve during my decompression. So the most important thing, what we changed at the beginning after we visited those people working with the posterolateral approach, not able to focus and to visualize the structures of the ventral epidural space, was to change this approach to the lateral aspect, because the facet is a kind of fulcrum. It pushes your endoscope and the instruments to the anterior and lateral area. That means your working area is not in the disc, but it's in the disc, but not in the ventral epidural space. So we are not longer measuring centimeters from the midline, but we have anatomical landmarks like the posterior line of the facets in the lower lumbar levels in the lateral C-arm position, where we start with our decompression. So example for that, normal transframal approach. That means we are passing the exiting nerve root and the whole neuroforamen without visualization. So these horizontal structures is the posterior ligament and the annulus. Then we see the herniated material here, epidural fat. We see no free floating of the structures. This is always the sign for decompression, for sufficient decompression after remove the herniation. And after the removal of the herniation, we see here already the free floating structures. So we see here the elongated ligament, posterior ligament, and you see already the floating of the structures. That's the entry to the epidural space. So you don't need in every case to directly visualize the dura. In this case, we do this just for demonstration, because sometimes you have adhesions here in the interior surface of the dura. And then you see here the dura, see the elongated ligament, see the entrance to the disc space. So typical transframal approach in an area where we expect defect in the annulus made by nature. About 15% of the herniations are located in the intra-extraforaminal area. Conventional technique is a paramedian approach. There are always people talking about the safe zone, Kanban triangle, where you can work safely in. But when you have a foraminal herniation or a foraminal stenosis and you're not able to identify the nerve root, you can identify it clearly at the opposite side, but not on your ipsilateral side. Then when you're then doing a trans or intraforaminal approach, we are not visualizing the exiting nerve root, you have a higher risk to damage the exiting nerve root. So in these cases, you do an extraforaminal approach. That means you're starting outside of the neuroforamen at the junction of the pedicle and the ascending facet. And then under complete visualization, you pass the exiting nerve root and do it under complete visualization. Example for that, alpha 5 on the left side. That means here's the pedicle. And then you start to work on preparing the structures, ascending facet. Here we find the disc space. Left side is cranial, right side is caudal. Then we prepare more and more the foramen, go to the cranial aspect. In this case, we have this intra-extraforaminal herniation located in this area, resection of the herniated material. And then we have the L5, the L4 nerve root here. And with the lateral approach, you can easily go below the neurostructures with your instruments. When you use an posterolateral approach and you mobilize the structures to the cranial aspect, you have a higher risk to squeeze the L4 nerve root or the exiting nerve root towards the cranial pedicle, entry to the spinal canal, dura here, vertebral body on the right side, we see caudally the disc space. So when we are working in this area, again, the question is, why are we doing a lateral approach? Well, we can work underneath the neurostructure without squeezing it. Another example, L3-4, the left side. So we're here again in the foramen. That's a disc here. Here starts the ascending facet. That means on the right side is caudal, left side is cranial. Disc space, and then again we are just rotating to the cranial aspect with the cannula, rotating with the optic to the cranial aspect. Here starts the L3 nerve root. Here's the entry to the spinal canal, and then again step by step we prepare the structures. So again here we are cranial of the disc level, taking out the herniated material, and especially those herniations which go far to the cranial aspect, but which are located lateral in the spinal canal, can be addressed with that approach very easy. Extraforaminal L5S1 can be a challenge because we have very near anatomical situation here. Sometimes you need a relatively vertical approach. Example for that, it's on the right side. That means the left side is caudal, right side is cranial. First of all, we prepare here the lateral margin of the facet, and then we find the neurostructure. It's the L5 nerve root, which is here, and you see how less space we have. And when we always are talking about transforaminal operations at the level L5S1, you can imagine how how much space you really have to place your instruments in a neuroforamen like that. So preparation here, the L5 nerve root is mobilized to the cranial aspect. We have the disc space and the herniation directly in front of us, taking out the herniation and then checking the decompressed area. Again, using the cannula as our second instrument, so we have the neurostructure now cranially of us, can work in the disc. And then when we rotate back the cannula, we see here the situation, L5 nerve root, cranial, caudally, disc space. So when we started with this technique, foraminally, we rapidly saw that we have limitations. Limitations concerning the problem of the exiting nerve root, limitations concerning the iliac crest. It was not our solution to drill a hole into the ilium to do a transiliac approach. Limitations for mobility, and limitations to resect heart structures beside the disc space, and no possibility to decompress directly posteriorly. That was the reason to choose another option, and we just went with the endoscope in the same way what we did already all the years before. That means coming from posterior, and the interlaminar approach was born. So you all know that we are always starting to open the flavum ligament as medial as possible. And then we are opening it to the lateral aspect until we find the medial margin of the ascending facet. And good advice is always to resect this part of flavum ligament that later on, if you need that space for recurrences or whatever, that you have a clear bony margin there. Then in this case, cranial migrative fragment. So we rotate the cannula to the cranial aspect, medialize the neurostructures here. And then we have the herniation directly in front of us. We just can resect it. And then we see the decompressed neurostructures. And you see we are working like a joystick technique by rotation of the cannula, mobilization of the cannula, and mobilization of the and rotation of the endoscope. Here we can look into the neuroforamen. Here to the cranial aspect, we find the beginning and axilla of the L4 nerve root. When we rotate the cannula back, we see the traversing L5 nerve root, defect in the flavum ligament. The next step was bone resection, because bone resection meant we were able to open the interlaminar window in more cranial levels. You know, the interlaminar window is getting smaller and smaller. So in this case, caudally migrated fragment L3-4. After resection of bone, the steps are the same as you've seen before. But you need more space here in the lateral part of the spinal canal, because the dural sac is much more nearer to the bony margin than at L5S1. So use the dissector to medialize the structures, push in the cannula, rotate the cannula, in this case to the caudal aspect, rotate the endoscope, and then you have the herniated material directly in front of us. So taking out the sequester here, and then we see here the empty bed where the sequester has been in this space, and the situation after taking out the sequester. What's with the mobility for the interlaminar approach? Due to the fact that we can resect bone in a sufficient way, we found that there is almost no restriction for decompression with this approach. And we have in our daily practice about 35%, which is done in a foraminal technique. And we think it's still the approach of first choice, because it's the least traumatic approach to the lumbar spine, as we think. But most of the approaches are done with the interlaminar technique, where you have an extended spectrum. The next step, after being able to resect bone in a sufficient way, was spinal stenosis. So we divided into a central and a lateral one. You all know that. And also there was a big change in the last decades from aggressive laminectomy to more selective techniques like undercutting techniques. And again, we have those two approaches, and used those two approaches. Foraminal approach for recess stenosis. First of all, you have to use your approach as lateral as possible due to the iliac crest, and due to the fact when you're using a postural lateral approach, you're resecting a lot of bone of the facet. Even here, using a lateral approach, we had resected a little bit of the part of the joint. And it is difficult to decompress anteriorly, and you have limited mobility. And normally, for recess stenosis, you have to resect bone from the tip of the SAP to half of the caudal pedicle. And you have to look at the pictures preoperatively. It is not enough to resect bone just from this space. You have to resect more bone in most of the cases. But you have indications for foraminal approaches. Intra or extraforaminal located pathologies, for example. Intraforaminal in the cranial part of the foramen, you have the tip of the SAP, which makes an SAP impingement here. In retroflexion, the patient gets radicular pain, so you have the possibility to resect the tip of the SAP, or in the course of the axial nerve root, due to cysts or due to osteophytes which are located there. That's an indication for foraminal approach in stenosis. Normally, we use the interlaminar technique. When you have a recess or central stenosis with ipsilateral radicular problems, you use an ipsilateral decompression, always starting at the tip of the descending facet, resecting the medial margin of the descending facet, cranial lamina, then thin the bone of the medial margin of the ascending facet and caudal lamina, resecting the flavum ligament completely, and the decompression is done. Example for that, L4-5 on the left side. So first thing what we are doing is to decompress the bony structures. Then we open the spinal canal. There's a difference here to resect the flavum ligament because we are not only resecting it like a line, what we're doing in for a disconation, but we're resecting it completely from medial to lateral and cranial to caudal. Then we find the lateral margin of the neurostructure. You see the thin bone here, which is now resected with a punch. In junction to the caudal lamina, very important to resect enough bone here, always according to the preoperative finding in the MRI. So you have to define in the preoperative MRI, how much do I have to decompress? And then later you have to check if your decompression is really enough. Otherwise, you have to decompress more cranial and caudally. You see, there's no free floating of the structures right now, because in most of the cases, you have an additional anterior compression. So only decompressing laterally and posteriorly is mostly not enough. So you have to check, is there an anterior compression, either by bulged annulus or osteophytes, and then we have to resect that. You're doing this by rotation of the cannula, resecting the structures 360 degrees. Of course, this space is open then, but you see now free floating of the neurostructures, complete other situation like before. So next topic was central stenosis. That meant we had to resect a lot of bone posteriorly. And so we could combine our ipsilateral decompression in cases of central stenosis with an over-the-top decompression, and that is for bilateral symptoms of claudication. And yeah, the technical development allowed us by introduction of the stenosis system to do that in a time-sparing manner. So we are having a bigger scope with bigger intraendoscopic working channel. So the instruments, burrs to be introduced are much bigger, and that allows you to decompress the situation faster. So first we are doing our ipsilateral decompression. What we already knew from recess decompression. So we see our ipsilateral decompressed side, and then we are going to the opposite side, resecting the flavum ligament to the opposite side, resecting bone to the opposite side if that is necessary. And then we see here the opposite facet. What is important that you always look that your working cannula is not squeezing the dural sac while going to the opposite side. And then we see the decompressed lateral recess of a decompression. So we have an algorithm for lumbar stenosis. So for lateral stenosis, we have rare cases of foraminal stenosis or Z-joint cysts, which can be decompressed mainly with an extraforaminal approach. But for most of the case of lateral stenosis, in all cases of central stenosis, we use the interlaminar approach. So for a recess or central stenosis with unilateral symptoms, we use an ipsilateral approach with an unilateral decompression. For all central stenosis with bilateral symptoms or claudication, we use an ipsilateral approach with an over-the-top decompression. But whenever we have a stenosis with an anterior compression on both sides, you cannot do an over-the-top decompression because you cannot address the contralateral anterior compression. That means in this case, you make a median skin incision and do a bilateral decompression on both sides, of course. Next topic was cervical spine. Again, mostly starting with radicular symptoms caused by disconation or stenosis. You know, when we are facing the cervical spine, we have to create our approach to get to the spine. Until now, the ACDF is a standard procedure for a cervical disconation, but we all know it's a quite small pathology for, and we are doing quite large procedures, which also can lead to problems. But there are alternatives from the anterior and the posterior aspect. Also here we have a tendency for minimal invasive techniques. So we have the full endoscopic technique either from the anterior aspect or the posterior aspect. Let's have first a closer look to the anterior approach. We performed it as a transdiscal contralateral approach. Mandatory for that is you have to palpate the anterior vertebral bodies, and that can be restricted in lower levels of prominent muscles or pre-operations. An indication for an anterior approach were radicular symptoms caused by soft disconations located on this level, and the problems where the palpation of the anterior spine is mandatory. We have a restricted mobility when we're inside the disc space, and it's a transdiscal procedure without fusion. An example for that, C65 on the right side. That means left side is caudal, right side is cranial, 12 o'clock is lateral, 6 o'clock is medial. So due to the shape of the vertebral bodies, you know that from open surgery, you have to resect bone in a lot of cases to get access to the posterior structures. By the way, now we are not using this anterior approach anymore, but there are still some surgeons throughout the world who are using this approach. That's the posterior ligament here. Now we find the defect where the herniation went through, and then you can take out the herniated material with your normal instruments. Of course, you're limited for the mobility. That's one problem here. You can use some deflectable probes to take out some pieces that are going to the cranial caudal aspect. That's the dura here of the cervical myelin. And here lateral, you can palpate the neuroforamen. But our approach, what we regularly use as a posterior approach indication are radicular symptoms caused by soft disconations or stenosis, localized mediolateral or lateral, concerning an anterior pathology, and each localization of a posterior pathology. C5, C6 on the right side is cranial, left side is caudal, 6 o'clock is lateral, that's the joint here. We are always starting with the cranial lamina, resecting bone here, and then with the caudal lamina, and then it's like when we widen the window, it is like opening the flavum ligament at the lumbar spine from medial to lateral. So we open the flavum ligament. That's the venous complex around the dura. Next anatomical structure is the lateral margin of the dura of the cervical myelin. That's the cervical nerve here. In this case, we have a herniation located in the axilla. And in this case, we even can go into the disc space. This is normally not possible in most of the cases. The neurostructure is lying directly over the disc space. But when you do your bone resection, you always should do enough bone resection that you can see both sides of the nerve. So we are here in the axilla portion. Now we are checking the shoulder portion of the nerve for missing pieces. Of course, it is allowed to mobilize the cervical nerve, but not the cervical myelin, of course. But gaining more experience for these approaches, we had some more wider spectrum of indications. So we can operate localized abscesses, Z-joint cysts, stenosis from the posterior aspect, especially the atlantoaxial area is very interesting, resecting the C1 arc from posterior or doing a ventral decompression. For example, when you have a fixed and decompressed situation from the posterior aspect, and you have another problem, an additional problem from anterior, either abscess or pannus tissue, we can use this approach. So we are doing a mini open approach at C45 or C56, then going with the endoscope to this area. This is C1 arc. So we don't have to resect the C1 arc. We don't have to do a transnasal, transoral procedure, odontoid process, and then we start to resect the bone. You see here the resection of the bone. This is everything is only access work to get to the pathology. So resection of the bone here, and then we face the soft tissue, which is in front of us, and yeah, makes the problem. So resecting here the odontoid process, and then we see the soft tissue which has to be resected, and then step by step we decompress the neurostructures. So here getting access to the epidural space, and then using the punch we resect the soft tissue. So we're working together with the biggest rheumatic clinic in Germany. Normally, you know, when you have a problem like that, it is enough to decompress and fix it from the posterior aspect. But this patient, for example, had an acute tetraplegia, so it was not enough to do it only from posterior. That's the situation now after decompression. You see the C1 arc, we see the decompressed neurostructures, and yeah, there's a special situation. After gaining experience, of course, with the cervical spine, we started with the thoracic spine. I don't want to talk too much about that because later on I will have a separate lecture about that. But we know we have different pathologies at the thoracic spine, which lead us to an operative procedure. We have three approaches: interlaminar, extraframal, and transthoracic. Most important thing, we have to define our approach to avoid a manipulation of the myelin. And the interlaminar approach is very near to that, what we know from the lumbar spine, but we have an individual range for that. And extraframal approach, also an individual range from lateral to medial. And for special cases, we have a transthoracic retropleural approach. And the indication criteria is for posterior pathology like OFL, sagittal cyst, or posterior sequestered soft clination. We can use an interlaminar approach. The most frequent one is the extraframal approach for softer calcified intra or anterior pathologies, and rare cases for a transthoracic approach. So at the end, of course, more than 25 years of development means at the beginning we were at a lot of conferences where people said, well, what are your advantages? Concerning the criteria of EBM, we achieved the same pain reduction like in standard procedures, but we could show we have all the advantages of a real minimally invasive technique concerning the patient, the economy, and the surgeon. Nowadays, you know, it is not anymore a peripheral matter. When you see how many papers are published nowadays in endoscopic surgery, you cannot compare that with the situation 15 years ago. So why should I offer my patients an endoscopic technique? Well, first of all, I can promise the patient a good clinical result. We have a fast operation and setup time. We have technical improvements. That means bleeding, obesity, visualization is better than in conventional operation. We have a reduced complication rate, facilitated revisions are possible, and a reduced traumatization of the soft tissues, and we have a high patient acceptance. So as a conclusion, we modified our philosophy. That means our first question when a patient appears in our hospital is a pure and selective decompression sufficient for this patient? And the second question is this decompression full endoscopically possible? So we have more and more selective procedures with decompression without implants than before, and we have a high patient acceptance and demand for that. What's the future of endoscopy? Well, first of all, we will find more technical developments like modified endoscopes, chip on the tip technique, LED, wireless, new instruments, bone resection, robotic, and navigation. We'll have further distributions in decompressions, not only in herniation and stenosis, but also in tumor phototherapy, assisted fusion. You know, in the last years, there's a lot of development in this field. And we have a further establishment in spine surgery. That means we are seeing nowadays increasing numbers of surgeons using these full endoscopic techniques in their daily practice with an increasing scientific work. And nowadays, the young surgeons are growing up with these techniques and are educated every day and using them in their daily practice. So when we define a medical revolution, we have the criteria: transformative changes, rapid progress, broad impacts, and social benefits. We all achieved that by introduction of the full endoscopic techniques in the last 25 years. But we need open surgery. We will need it in the future too, not only to get along with complications that may occur during endoscopic or minimally invasive techniques, but also to offer our patients the right treatment for their pathology, because not every treatment nowadays is fitting to an endoscopic procedure. Thank you very much.
Any questions? Yeah, Dr. Rakesh.
Excellent talk, and whole generation has learned a lot from your institute. Congratulations for that. So what do you see UBE coming up in a big way now, especially in Korea and India? So monoportal versus biportal. What do you see? When we future surgeons would have to learn both, or can stick to one and that should be sufficient? What do you think?
Well, first of all, of course, new developments, I think, are always positive impact. Also, the bilateral or the bipodal or multipodal decompression has, of course, on the first view, advantages like using the well-known instruments. The question of costs is always different in every country, of course. But I think there are still things to learn and there are things to discuss about, especially when we're talking about bipolar techniques. For example, what is right now a topic is fluid management for not only for unipodal techniques, because we have different types of tactical solution for endoscope and cannula. And the most important thing when you're talking about fluid management inside the spinal canal is that you don't have an inflow of irrigation into the spinal canal, preventing complication for that. But fluid management means also fluid outside of the spinal canal. You saw the pictures of the colleague before, showing all the irrigation going into the psoas and retroperitoneal area. And when I'm using a bipodal technique, I'm just working transmuscular, trans tissue in several ways with big instruments. So I destroy parts of this soft tissue, but my irrigation goes in every time. And so that will be also a question, what happens with the inflow of irrigation in these soft tissue? Yeah, does it has an effect or is it effectless? We don't know. But we always have to consider, for me, it is a step backwards because we are using the unipodal technique now for 25 years. But of course, it is standing somewhere between an conventional operation and a unipodal operation. So everyone who likes to start with this operation because he feels comfortable to that, I think this is a good thing to start with, to see the advantages, especially for visualization for an endoscopic procedure. But then after gaining experience for that and saying, well, this is a really good thing, you can minimize the trauma and go to a unipodal operation. So
Yeah, that's a good way to put it.
Yeah.
So it's between microscopic and uniportal. So biportal is in between. So any more questions? So no questions are there. We can, yeah.
yeah, we are not doing the anterior approach anymore. The central cervical disc herniation normally is not related to a radicular problem, is related to central nerve systems problem like myelopathy or whatever. Of course, you could address that with an anterior approach, but the anterior approach has limitations, especially you have to palpate the vertebral bodies clearly. If that is not possible, you may have complications due to your access by hurting the carotid artery or the esophagus. And there were cases of that. We are our hospital doing a lot of interventional pain therapy. So we were used to put in needles from anterior into the disc. But everyone who is not used to that may have complications. And the next thing is you are absolutely limited for mobilization. And for example, when you have a situation like that, median herniation, the first tip I can give you is always collect as much information as you have. Don't trust the MRI. Do a CT scan, because in most of the cases you have calcification, and then you will have mechanical problems to resect it with an endoscope. So a median herniation causing myelopathy is for me an indication for an open procedure right now.
Yeah, so thank you very much, Professor, for the insights. Overall overview how the endoscopy has evolved over last 20 years. So we'll, Naresh, ready? So the next talk is by Professor Max from Taiwan. He's in Taiwan Medical University. Is a professor and head of spine surgery in Taiwan Medical University. He will be talking on role of AI in full endoscopic spine surgery. It's a very interesting topic. We were supposed to present this topic in Brazil, myself and Naresh, but we couldn't go there. So he's presenting today AI in endoscopy. Over to Professor Max. Good morning, Max. Yeah, good morning, Max. How are you? This is Sukumar.
Yes, thank you, Dr. Skuma. I can share the slide with the yes.
So good
Yes,
morning. So yeah, you can start your talk, Max.
yes. Please allow me to share my slide. Yes, please allow me to share my slide. Okay, now it's okay. Let me share my slide. Thank you so much for the invitation. I'm very happy to have the chance to talk again this year. Last year I was in person, but this time sorry, have to present online. So please see my slide. Okay, so my topic is AI for innovation in endoscopic spine surgery. So this is my disclosure. I only have two startups. One is related to the endoscope. And you can see last year's endoscope, I really want to go in person thanks to the organizers. The Suprema and organizers in person. And window of innovation is a very fast growing AI among them is very popular. And we use that during several types of surgical planning or for facilitating our surgeries. Endoscope now is also a very big hit. Everybody learn from myself. I learned from Dr. Kemp. Sorry, there's some echo. Okay, wait a second. There's an echo because of the Zoom. Let me close this. Okay. All right. So the endoscopic system now have powerful tools and also a lot of new innovation like the camera system or the infrared of or head-mount displays. So now this now greatly extend the indication from the previous decompression, now fusion, and also complex surgery. And now we are looking for autonomous surgery, and even in the future can have a regenerative medicine or spinal cord column replacement, or because of the previous work like Dr. Kamp or Dr. Uten. And AI-related publication in spine field is rapidly growing. And you can see over 200 papers each year is generated. And there's several countries that are actively putting efforts in this, like the United States or Canada or China or India or Australia and Europe. And I think this means it's also similar to endoscope. Everybody want to use it in spine surgery. And now most of the application, they are related to diagnostics. So it's already many studies showing over 90% of accuracy for the image detection. And sometimes we can see pathology that human eyes can miss. And for the outcome prediction, now also we have a very good AI algorithm in some like for the surgical planning that can predict the complication earlier and also can see the long-term outcome. About the surgical assistants now can use this for, during the operation. So this can facilitate doctors and tell the patient better information. And so you can see there's over 95% of diagnostic accuracy of regarding to like cyst lesion, also the approach for the uh, uh, surgery, and also the measurement can be easier, and also the risk assessment can be faster, and intraoperative enhancement also been have been proposed and applied, like Apple Vision Pro, like Dr. Don Park is also presented cases like using Apple Vision Pro in endoscopic spine surgery. Later, I show some video from him and can facilitate surgery. And the radiation reduction by the navigation the robot now can also use in endoscope because that can facilitate the cage insertion and also avoid the misdirection. And postoperative optimization, like wearable technology, now we all have a smart watch, and also the wearable brace or corset now can help, and also NLP can help to detect the early readmission, and also then can help to generate surgical report in some area, like now most popular is in general surgery. They can have some NLP analysis, and so this many big companies like Medtronic or Global, they are want to use the AI to be their uh, important next step for to give other competitors their strengths. So I think AI for total spine treatment now involved with an endoscope, we can do diagnosis earlier and help with lesion that we cannot see in previous signal, like Dr. Comment just mentioned about the calcified lesion. And also decision making can also be facilitated by AI because like this year, I always have the study showing Gene AI can help. And also the treatment systems, like the previous navigation now can combine with AI, and 3D printing implant also helpful, and post-operative care. And so now the era comes not just about machine learning or natural language processing. Gene AI now become very popular. There are so many companies having the Gene AI. Next step will definitely be agentic AI and physical AI. I believe in the future, there will be the hot topic again. So generative AI is no longer a proof of concept. It's entering this field. And it can help to analyze the data and not just about the segmentation, but also providing decision making. So as I mentioned, that AOS this year have that paper showing they use 10 patients, and they all have orthopedic trauma, and use the ChatGPT to generate their surgical planning, and then they can get their surgical planning report and compare with experts in this field. They found the result they are similar, and they are safe, clinical reasonable, and aligned with the clinical outcomes. So it's already shown that it's a very promising way to use AI for the surgical planning. And also besides this, some company already use the AI in the detection of the lesion in the gastroenterology field, and can reduce the time and also can avoid missing lesions. So it's actually now their AI platform can provide better lesion detection and can also facilitate workflow. And I think that generative AI is definitely changing this field also. So let me separate the AI care for the spine care into several parts. First start, I think, will be the machine learning and lesion detection and also the natural language processing. So now we can select the patient's data and connect our database with AI and help to detect what's the best solution for the patient. So like the previous study showing it can improve the surgical referral in spinal lesion condition and can enhance the time to avoid the misdiagnosis or delayed diagnosis. And so the company, some startup like this, can provide an online platform to have a triage for the patient. And they found that AI have a better triage decision for clinical convenience. So already showing the AI also can help to predict complication. So this work that's showing it reports almost 74% accuracy to detect the problem after the surgery and also the readmission. And about the image detection, the MRI or X-ray or CT scan, or even some more complicated images, they also show a very high accuracy to detect lesion without missing. And so, like the X-ray, you can make it easier to detect fracture coming from this. And also the alignment can be predicted earlier, better. And also planning the surgical implant. This is our study. If you put a traditional implant, that you might result in a kyphotic position. But with the AI prediction, you can make an implant in a better shape and a better footprint, so they can allow to have a better alignment. And so also for the patient-specific rod and also implants, I think this already there in the market. And also the AI can help in endoscope to predict patient's outcome as well. So this is a study done in 2020. So they compared the radiologists and also the AI for the predicting the outcome. So you can see in 65 patients, they predict their outcome and found the computer, AI, and the radiologist, they can have a similar predict accuracy, almost the same like 86%. And so that means in the future that maybe that AI can help us to do planning before the surgery and tell the patient. And also that the other study in 2022 showing this is come from Taiwan, Dr. Chen. He used AI to learn the approach because usually they have we need to decide the transfemoral interlaminar approach. And that study found the predicted value is about 85% to 89%. So that AI can also help to select the surgical approach. And also that I think this is from this year, there's already AI-enabled planning software can help to plan the patient-specific device. So you can see by input their image, they can generate the implant and also can direct implant to the patient with a better alignment. So this I think that in the future, this type of technology will combine with other technology as well. Like this is a paper this from gastroenterology. They said they found they have a prediction system. They can use the health record and combine with other sensor, and they can have a high detection rate for the adverse event, about 82 to 94%. And they they can use the data further to use in robotic endoscopic procedures to facilitate the surgery. So in the future, the case scenario like this, with a lumbar spine problem, then we'll input the patient's data, and the AI give you collect all the and generate a single summary to tell you what the risk factors and provide the patient and doctors information about what the planning and also what the risk and give you the best evidence and then provide that the surgeon do the decision together with the patient to have a shared decision making. So this can further the patient outcome and also can avoid patient and doctor relationship problems. So that's next we'll move to robotic surgery. So robotic surgery in this field is so very growing. When it combined with the hand-mounted device or navigation system, it can help to do education and also the real surgery. So the device now is already like is that assisting doctors to do the instrumentation and also the cage insertion, and some handheld robot also on the market can help to provide similar accuracy. So robotic assisted spine surgery provide very fast learning curve and high accuracy. So can reduce that endoscopic learning curve. So that robotic endoscope has been used in the spine field. So you can see this paper, they have already 18 patients and they underwent one level fusion with the robotic surgery. And the length of stay was 1 day only. So that can provide a very good screw accuracy and a cage insertion with the robotic endoscopic system. So I think in the future, in the other field, they have even different type of robots maybe used in field, like this multi from the single port, so they can do suture. So like the typical cases, like tumor removal or need to remove the intramedullary tumor, can consider in the future that maybe in this for the spine field. Similar design that using micro robots, you can use a very tiny arm to control. So maybe in the future, the bipolar surgery can be like this, that only one port, but have two arms in endoscope to practice and do even more delicate procedure. So I think the robot is a very promising part. And about the virtual reality and augmented reality, it's already been used to provide a good medical education, simulation, intraoperative guidance, and rehabilitation. Not just simulation, I mean, some company already use that in the endoscope. So for the education wise, I think this is good for a beginner. They can reduce their time to can avoid the cadaver workshop a little bit, but usually it's before cadaver workshop they can use this to simulate the procedure. So there are already papers showing very good education uh, feasibility to provide better a better learning curve. And about the augmented reality, also similar, can provide a very good user-friendly way to let the doctor to see the image and and with the same surgical field without turning their head or having more uh, weight on their head. But now I think still there is a problem with the goggle about the weight and also the uh, information provided. So, but now, like Dr. Park, he just used this with the Apple Vision Pro to facilitate his endoscopic surgery. And this year, we actually have a workshop in Taiwan using his system, and it showed very good visualization and very clear view, and can provide also that the others to see the same image. So I think this is a very stunning effect that he demoed that with Visual Edge, the Apple Vision Pro, and the same technology being used in endoscopic transforaminal lumbar interbody fusion combined with the navigation. So I think this will probably in the future every endoscopic surgeon will have that, and and also it can provide a better workflow because the other staff can also use similar way and can do a better preparation and can facilitate the instrument preparation, and so they can improve the work. And about the intraoperative navigation, the AI also can use to identify the ultrasound image. So this can also further help with some endoscopic procedure that if we need the ultrasound to facilitate that. So during the initial needling, like previous Dr. Thompson mentioned, the anterior cervical endoscopy, if we use ultrasound to combine and with AI to detect the uh, esophagus or carotid artery, they can avoid the complication. So I think that's also on the way. So AI for the computer enhancement during the endoscopic surgery has been also proposed already. So also can facilitate with the blood vision barrier. So can combine with the IR camera to see through the blood and also use AI to detect the lesion. Also that instrument. So this is paper from 2021 with a bipolar surgery that the doctor showed. He had a study comparing different type of AI model, showing the feasibility to do that AI detection intraoperatively, and also that then that Dr. Kim in 2024 they developed an AI detection model for detecting the tissue, identify the tissue for the endoscope, reach that precision rate of 81%. So in the future, that a doctor can use this to better recognize the tissue. And also there is a open, there is now a open source data set for that endoscopic surgery to detect some complex difficult scenario like a bleeding or bubble or very further view or some situation that can train the endoscopic AI. So now actually this field is rapidly growing, but of course there are some challenges like AI have or the problem with transparency is usually the result like a come from a black box, and also that uh, consent about who's not responsible for the bad result. Usually it's still the doctors and the liability now still need to have a better regulation to define who's gonna answer the last answer. And also that the multidisciplinary is important because for not just a surgeon, but also other parts, they need to work together. So we now currently have a group to focus on this. I hope in the future, of course, some of our study comes from this already, but we hope to invite you to join this. So I think one important methodology for innovation is called biodesign that we can invite people who is interested in field, like from healthcare practitioner researcher and my AI research developer together to develop something innovative and also can really have impact to the patient. So now we have an alliance together with Naresh and Dr. Shikuma. We are following body design methodology, aiming to provide better care in spine field. And so we hope to have more people to get involved. So that's my take-home message. AI is mandatory, and AI-powered endoscope will be must-have in the I think will be soon, maybe the coming decade. But I think ethical, regulatory, and business strategy will be a challenging thing. So thank you again for inviting me. I hope everyone we can see again soon in the coming up meeting. Thank you so much.
Thank you, Max. We had hoped that you will be here, but we missed you this time. So next time, we hope you are here physically and show your more advancements. And any questions regarding AI Max? I think I can take one or two questions. Yeah. So there is a question, Max, to you.
So I would like to ask how AI will impact the surgical decision making in the future.
Yes. Yes, thank you. I think according to the paper now, actually AI will impact a lot, like especially when gene AI now is already there. So gene AI can provide similar surgical planning like the expert in some surgical type, like the orthopedic trauma. So for endoscope now, we also see similar, like the previous literature showing the predictive value is almost over 85. So in the future, the AI generated surgical planning will assist the doctor, definitely. So you can reduce your time to plan your incision or your approach, and also prepare the patient, all the things that will definitely get improved by the AI or surgical planning, and even intraoperatively. So I think it's better to start to get familiar with AI, because now in the future, the only one who can beat you is the doctor who know AI.
Thank you, Max. I think that's the answer. So thank you, Max, for the time taken. I know it's already evening, afternoon, post afternoon there. So thank you very much once again. So we'll hope you join us next time physically. Thank you, Max.
Thank you so much. Thank you for your invitation.
So we'll move on to the next talk by uh, Dirk Gothel from Germany. So all we know, most of the time questions asked, what is the best fluid mechanism? Should we use a pump, or should we use a gravity? So there are different schools of thought. So still Japanese use of a gravity mechanism. Uh, Germany been using these pumps for a very long time. And the radio frequency, also there are a lot of questions. Should we use plasma, radio frequency, bipolar? So what is that is best suited for endoscopy? So Dirk will just go through the mechanism and the concepts behind this technology, and how does it impact on our day-to-day endoscopic spine surgery. Go to Dirk.
Thank you. Thank you very much, Dr. Sukumar, for this invitation and for having the possibility to talk about the impact of RF technology and fluid management in full endoscopic spine surgery. Of course, going along with the development of endoscopic techniques towards less invasive, least invasive techniques, we got new challenges for technology that we have to implement during that surgery. And of course, we know endoscopic system is not only the endoscope and some instruments that are needed for the surgery. It's a complex surgical system consisting of video components, consisting of endoscopes. We need very special instruments which have also demanding measurements right now for stabilities. We need also drill systems and also intelligent drill systems that can work around the corner. We need RF, of course, always, as always in surgery. We need RF for doing hemostasis, but also for tissue ablation. And of course, here, when we work with fluids for visualization, we need a good fluid management. And fluid management does not only mean irrigation, it also means management of the outflow, especially when we work in areas where we have very sensitive structures, like in the spinal canal. What are the requirements for the irrigation and fluid management? Of course, during endoscopic surgery, we always want to have a clear view um, while drilling, especially while drilling, because drilling creates a lot of dust inside the water. And so we need to transport all the pieces out of the body. And this is one major requirement. And we know high flow is usually reached by increasing the outside pressure. Yeah, it's a direct relationship between the pressure and the flow when we run through a tube system. And this is, of course, can be a problem when we really would have this pressure inside the spinal canal. That means what we need is low pressure inside the spinal canal, because we do not want additional compression of the neurostructures during the surgery. What are the tools for irrigations? Of course, we have gravity just to hang up a bag over the patient to create a pressure, or we can use pumps, very specific pumps that brings the water in and probably out. So we all know the pressure is measured in millimeter mercury, and there's a direct relationship which is going proportional to the water column of the fluid bag that hang up over the patient. So we always have to consider this relationship. 1 meter water column, that means 1 meter a bag above the patient creates a pressure of 73.6 millimeter mercury, which you know that it can be dangerous for a patient already when you put that on nerve structures. According to higher levels, we get a pressure over 100 millimeter mercury. For the pumps, yeah, many surgeons are using regular arthroscopic pumps. The pump problem is when you use an arthroscopic pump is that it is pressure control. That means inside the joint, you need a fluid to pump up the joint. And when the pressure is reached, then the pump stops. But this scenario would be dangerous in the spinal canal when this happens, when you adjust 100 millimeter mercury and this pressure is getting effective inside the spinal canal, it will create problems, of course. So we did investigations. We created a model that simulates the spinal canal. So we have here measurements devices that we have on the lumbar, that's thoracic, and we have the cervical spine. And when we really push a pressure of 100 millimeter mercury to that, we saw that it's not, the spine is not an enclosed system. That means usually we get water out through the foramens, and we have a water development through the spine to the thoracic spine and the cervical spine as well. So what we saw, and when we close the system like this, that we close the outflow completely and also the working channel completely, then this pressure is getting effective here in the lumbar spine. And after a couple of seconds or minutes, you get the pressure also getting effective at the cervical, at the thoracic spine and cervical spine. What we saw here, once we released the thumb from the outflow channel, that the water can run out here, the pressure was immediately decreasing here. And this is an effect that we use during endoscopic surgery. That means when we talk about some physical fundamentals during endoscopic surgery, and when we just talk about gravity here, when we use here a closed system, that means we close all the outflow channels of the endoscopes where the water can come out, then exactly this pressure of the height of the water column is getting effective inside the spinal canal. But when we open the outflow, then this water column is the effective pressure that happens inside the spinal canal. That means this is usually 20 centimeter or 15 centimeters, and 15 centimeters means we get a pressure here inside 12 millimeter mercury. Once we close the system, we have this high pressure. So what is the idea behind that? How to avoid the increased pressure inside the spinal canal is we have to use a suitable endoscopic sleeve construction that always allows us an outflow outside of the spinal canal. And so we created a very special endoscope and sleeve system, which consists of an oval-shaped endoscope and a round-shaped outer sleeve. So we have an inflow channel like this. It's a very small inflow channel that brings the water inside. And we always have an outflow area, which is between the oval-shaped endoscope and the circular-shaped working sleeve. This outflow area cannot be blocked by any tissue. and is 5 times bigger than the inflow channel. Even when we work inside the spinal, inside the working channel with big instruments, then the water can come out here. It's a difference to other systems in the market. Other systems working with a round endoscope, round-shaped circular working sleeve, and they have usually an inflow channel and the same with the same dimension and outflow channel. When they work with an instrument here inside, then they close the outflow and the water can come out here, but very often this is blocked by the tissue that you release during drilling, during manipulations inside. So just to show this effect here, this is the effect that we want to reach. That means we want to have a continuous outflow, but when we collect material by drilling, this outflow can be blocked, and then the inflow is getting more. And when we compare the endoscope system, this small channel can be blocked very often and very fast. But when we use this oval shaped system with this huge outflow channel, this is not possible to block the outflow. And that's the reason why we use this system here, because we always have the water going in and out during the surgery, even when you use drills and other instruments for doing that. So this is one thing. What is important for keeping the pressure low inside the spinal canal. And of course, when you want to really make sure that nothing can happen, even when you close outflows and so on, then you should use a very special pump for doing that. And the spine pumps, or the pumps with the spine mode, are working differently from arthroscopic pumps. Arthroscopic pumps, as mentioned, are working pressure control. The spine pumps are working flow control. They always control the flow, the inflow and the outflow of the system, and they regulate then automatically the intraspinal pressure. Just for the example on our model, here we see we use a pump with 100 millimeter mercury here, and we reach here this 15. Now we close it with the thumb, so the system is now totally closed, and even in this scenario, we just get a pressure of 23, which is regulated by the pump now automatically. This is a very safe method with an intelligent procedure behind in the software of the pump that can regulate this. So just to conclude that, of course, we know creating an intraspinal pressure over 50 mercury can really cause neurological problems. So we have to make sure that the pressure is always lower. The pressure increase inside the spinal canal can be caused by using an insufficient endoscopic working sleeve system that guarantees always a free outflow of the irrigation during the surgery. And of course, using a pump with an intelligent software can also be a sufficient, or will be a sufficient method to avoid this increased intraspinal pressure. Now we're talking about radiofrequency, which is the second topic that where we get always a lot of questions about. Let's clarify a little bit the term RF, because RF it's a widely used topic, but RF does not mean only one frequency that we use during the surgery. It also means a bandwidth of radio frequency range that can be used for surgery. Just remind or keep in mind that your frequency that you use at home for electrical current, which is 50 or 60 hertz, is the most dangerous for the human body, because you get a muscle cramping then. And that's the reason why we use a higher frequency for surgeries or other medical applications, to avoid these muscle contractions during the surgery. What are the requirements here? Of course, we want to have a safe and efficient hemostasis close to neurostructures, and we want to reach efficient or achieve efficient tissue ablation. Important here, and if you have seen in all that lectures before, we work very close to neurostructures. And sometimes we see bleedings at neurostructures that we have to stop. And we always get the question also, can we stop it directly? Can we activate the RF directly at the dura or close to the dura? And for that, also some physical fundamentals for this electrical current and the relationship between current frequency and the electrical resistance of the tissue, because there is a different when we use different kind of tissues. We know here all the tissue which have a high water content, like a muscle tissue, and the high vascularization has a lower electrical resistance, but also tissue with a higher or with a less water content, like neural tissue, like dura, or also nerve structures, they have a high electrical resistance. There's a direct relationship between electrical resistance and the heating up, the ability to heat up a structure when electrical current runs through that structures. This is important to know. And what we see here, this is the bandwidth of radio frequency. Usually, when you work with your conventional RF or HF devices during surgery, you have a frequency, you use a frequency of 350 kilohertz. All the devices from Irby, KLS, Valley Lab, they are working with this lower frequency and the lower bandwidth of radio frequency. And you see here, when you go through that tissue, this electrical resistance has a big impact to that current flow inside this. When you go up, and that's the topic here, we are using with a very special radio frequency device 4 megahertz. This electrical resistance is going down, and this means also the heating up of this tissue and the heat transmission to surrounding tissue is getting less when you work in the higher bandwidth of radio frequency. That's the reason why we use a 4 megahertz device here. We did some investigations also here. We published a study for that by using a regular 350 kilohertz device like Irby or anything else, and our radioblader, which is using a 4 megahertz, is the blue curve. And this is here what you see, the distance from the tip of the electrode. So and this is the distance 2.5 millimeter from the tip of the electrode. And at the tip, we reach the same temperature with both systems. So this is a sufficient temperature to do a hemostasis, but also an ablation. But when we coming away from the tip, the due to the electrical resistance, this heating up of a 4 megahertz device is much less than the heating up of the tissue with a 350 kilohertz device. Just to compare it here in a distance of 2.5 millimeter, which is very close to the structures, we reached a temperature of 38 Celsius degree inside the tissue in a distance of 2.5 millimeter. With 38, you cannot destroy nerve tissue, but when you use 350 kilohertz, we already got 58, and with 58, you destroy a nerve tissue. So that's the reason why we use a 4 megahertz and why we can avoid, and why we can work closer to neural structure during that surgery. Yeah, another, of course, requirement is always we want to have a good handling. We we use the electrode as a second or as a finger, the surgeon's finger, during the surgery. Therefore, we were thinking about how we can make it easier for the surgeon to manipulate that electrode. So we created special handles for that, that allows to turn the electrode and to use it like a finger inside the spinal canal. This is very useful also to prevent dropping down of the electrode during surgery, especially when you work in the posterior cervical area, and when the electrode would drop to the cervical myelin, then we would have a huge problem. So we have this protection of the handle here. Yeah, just to conclude the topic RF surgery, to avoid thermal damages of neurostructures during the surgery, it's important to use a special electrodes, bipolar electrodes especially, and special RF devices with a higher frequency in the RF bandwidth, and RF devices generating RF frequency in the higher range, such as 4 megahertz, reduces the temperature spread to neighboring tissue. This allows RF energy to be used very close to sensitive neurostructures. Thank you very much.
Thank you. Thank you, Doc. So the question asked by the beginners is, is 1 megahertz is enough, because there are local companies with 1 megahertz machines which are smaller. They say it is easily portable. They can put it in their car and go to different hospitals for surgery. Is 1 megahertz equally effective as 4 megahertz?
I mean, 1 megahertz is better than 350 kilohertz, but not as good as 4 megahertz.
Okay, so that's a common question asked. So if you want to have more precision, less thermal damage, 4 would be ideal.
Yeah.
Okay. And second thing is the fluid we keep in pump, like say in a RevoSpine machine, we keep 100. So what is that pressure exerted at the operating site? Is it the same 100 or it is less?
When you use a vertebral system with this oval shape, and you have always the free outflow, you have round about 12 mercury during interlaminar, or 15 during interlaminar, because this is directly the height of the water column when the water runs out. And for transforaminal, you have even less, 12 millimeter mercury.
Okay.
I mean, that's also the effect, Dr. in the hospital of Dr. Comp in St. Anna. Before we developed this pump, they used the water gravity, just the gravity, and they hang up the bags very high, and we had the same effect because of this open system that we create due to our construction. They never got an overpressure inside the spinal canal. So even when you adjust 100, when you use that endoscopic system, so we always have a very low intraspinal pressure.
So what is that normal pressure you advise, say, for a discoscope and a stenoscope? If we are using a Revo pump with this intelligence mechanism, and we are using a vertebris, so what is that pressure you suggest, the average pressure for a discoscope and a stenoscope?
I mean, as mentioned, for our endoscopes, it doesn't have an effect. You can use any pressure.
So depending upon the bleeding, you can adjust more. This is a common debated topic, whether if you have this outflow mechanism, oval shape scope over circular scope, so the pressure really doesn't matter when you are using. Sometimes you can go, I go even 120, 130 sometimes because if there is any bleeding. So it doesn't find any difficulty. But friends call me and say that they had some post-op headache, which our patients will never have because we use this system and we don't have any headaches post-op. But so many friends call me and ask
Yeah.
their patients had a headache, almost more than 10%. So probably this mechanism of increasing the spinal canal pressure
Yeah.
is causing this meningism. Thank you,
it is.
for a wonderful lecture. So any questions, maybe we can continue during lunch hour. So now we'll go to the most awaited and interesting topic, the spinal tumors. I just were calling Mahesha to be here. Mahesha, you are here. So someone can call. Hmm? एक बुला लेते. So we'll start the case, today's case. The first case, it's a spinal tumor. So it's a D12, a D11, 12 intradural extramedullary tumor, elderly lady. So how endoscope can be a useful tool and avoid laminectomy and maybe fusion when we are operating a spinal tumors. So this case, Mahesha operated and we recorded it. Welcome to Spinoscope 2025. Today, we are demonstrating a case of L1 and 2 intradural extramedullary tumor. It is located at L1 and 2 space. So today, Dr. Mahesha is demonstrating how to do a tumor excision using monoportal endoscopic technique from posterior approach. So when you see the radiology here, is a T2 weighted sagittal image showing a tumor at L1, L2 intradural space, which is in between the rootlets. You can see here, well encapsulated. Whenever you see a lesion like this, always tend to see all the cut. So you have seen the sagittal here, it's spanning just at the disc space. Now you go to the axial image. In axials, always you should see which side it is coming from, whether it's in midline or to the one side, and where it is coming from, whether it is intradural or extramedullary if you are confused. You see here the spinal cord is ending at just above L1. So lucky for the patient. Then once it is ended, you see the small rootlets, and the tumor is starting almost at the upper end plate, and you can see upper end plate, that is the L1 lower end plate. Then at the disc space, you can see a tumor here on the right side. A big tumor, it's almost occupying the canal. More than 30-40% of the canal is occupied by the tumor. More onto the right side, it is extending to L2 upper end plate. So from end plate to end plate, it is spanning. Biggest the size of the tumor or the tumor is at the L1, L2 disc level. So that is what we need to see for the surgical planning. Once we see this, then can we do under endoscopy? Yes, nowadays Mahesha has developed his own technique, which he will be showing, the master will be showing how to do it, how to expose, then how to identify the tumor, then how to dissect the tumor, technical surgical techniques and steps he will be showing in detail in few minutes. So plan is go from posterior monoportal technique, do a laminectomy or laminotomy according to the need, then do excision. So we just see the contrast image. Contrast image, again, contrast image you see here, it's enhancing. Again, you should not get biased. Sometimes the cuts are not proper, or we are doing from a lesser Tesla MRI. So sometimes you have a very bad images. So always try to understand clinically and radiologically correlate and try to operate. So you can see here there is enhancing lesion here which correlates to our T2 image, and it is more to the right side. So I just pass on the mic to Mahesha. So Mahesha will see what is he planning, and is it possible today to do tumor excision using microscope, using endoscope? Definitely, Mahesha has made it possible to remove the tumor through endoscope.
Yeah.
That is the
Finger.
magic you will see today. Over to Mahesha, and welcome to Spinoscope 2025.
Thank you, Sukumar. Good morning to all. This is a small tumor, uh, which is at the level of L1 to as explained by Dr. Sukumar. This seems to be a well encapsulated tumor. Means it is probably it is arising from one of the rootlets, and I expect to see a rootlet which is attached to it, which probably will sacrifice it and take it out. Only issue here, it is a little bit too small. Normally, we operate tumors which are more than 1 centimeter or 2 centimeter in length. But anyway, so we should be able to take it out through the endoscope. So the steps are standard posterior decompression with the endoscope, with the stenoscope. We do the laminotomy of L1. Uh, we release the dura, flavum completely to expose the dura. We burr little bit of base of the spinous process so that we have enough space for our suture to pass. We don't have to go over the top to the other side, which is not required. So we go on the right side, have enough space for our dural work. So if you don't have enough space for the dural work, then it becomes later to do this work once all roots are exposed. So that's why to have good exposure initially is very important. Then we open the dura, will show how it is opened, and how we expose the tumor, how to take it out, and then we have to do the dural closure.
Yeah. So, Spinoscope is all about new technology and tools what over period we have developed. Mahisha, in this case,
No.
how different the drilling is from a normal stenosis case? You want to drill more, or you want to do complete laminectomy in such case? What is your practice?
This case, it is a standard decompression we do for stenosis. We don't have to do a complete laminectomy here because the tumor is at the disc level, so the lamina is much higher. So we do uh, drilling till we expose the cranial edge of the flavum.
Yeah.
So
So it's a standard technique where he will do drilling laminectomy till the cranial attachment of ligamentum flavum and the caudal attachment of ligamentum flavum. So here, as we saw the tumor is coming, spanning the disc space, all he has to expose the space, disc space better, and laterally it is going to the edge of superior facet. Maybe we will drill partial superior
yeah,
facet.
some facet we
Yeah.
have to drill
So
as per the standard
yeah.
decompression.
So the standard decompression as we do in this case, and sometimes if he is operating, as he said, bigger tumor, he will do
Yeah,
accordingly.
if the tumor is bigger, suppose if it is going behind the body of L1, then I will have to take out the entire hemilamina on the side of the tumor.
Okay, so standard for any, like you plan for a disc, so same way he is planning for the tumor. Then the tools which he uses, he has designed some tool so that we can
We
just
will, yeah,
we can just
yeah,
because
we
this
will
is very
show some of the
important.
tumors.
What tools he has developed and what tools he is using. So he will show few tools which he developed. He has developed a needle holder. He has developed a knot sliding tool
Grasper angles.
and some fine forceps.
Basically, we need a big scope with some small instruments. Means
Yeah.
we have to have a stenoscope, and the instruments are all small ones.
Yeah. So just
Basically, I'll show some tools. So this is a durotome. Can you show? So this is a durotome, which is basically a sharp knife.
it's a duratone, it's a knife kind of a thing where you
this
can
is-
insert.
This is the instrument for opening the dura.
Okay.
Okay. Then we have some small graspers, which basically to hold the tumor.
So he
2.5 mm
so
graspers,
2 mm,
straight
2.5
angled.
mm straight and angle grasper.
Then we have some tumor forceps also, if
So
required.
it's a same like a
This is
tube
a,
forceps,
uh,
tumor forceps,
there is a standard tumor forceps which is attached to
longer one,
a
yeah,
longer grasper.
And Mahesh,
Yeah.
show the needle holder and
And this is a standard root retractor because this will be using it to expose because once you open the dura, all the roots will be coming.
you can zoom in.
So this is the standard root retractor which we
retractor.
use for the disc. So
Okay.
this helps to expose the tumor.
Yeah.
Then we have this needle holder.
And
So this is the tip of the needle holder. This is the handle. So it is self-locking.
so you can see what we use in microsurgery, like especially in
So,
brain. We use such
so
needle
we have
holder.
done marriage of needle holder and the micro needle holder.
Yes. So the micro needle holder is the vascular surgeons and neurosurgeons that he has made it like longer handle to hold the needle. So
So
that
this holds the needle.
you can
And once we take the knot, we need to push the knot inside. So this is a knot pusher.
yeah.
So
So
basically, this is an instrument inspired by the arthroscopy. We use this in arthroscopy, but with a shorter one. But here we need longer instrument. So it has a small hole to take the needle and the suture. So once we take the knot, we push the knot inside. So everything monoportal.
So how to do it, Mahisha will show in detail while doing surgery.
Mm.
So
And we have one suture retriever in case if you have some suture which is entangled. This is again arthroscopy instrument which is designed for our purpose. So it will has a slot for holding the sutures. So
Yeah.
we can go inside, hold the suture and pull it out.
so
And the last but not the least is the cutter. This is a standard annular cutter.
yeah.
So which we use to cut the suture at the end of knotting.
So the extra tools what he has developed is the needle holder, the knot pusher, and what to say the suture retriever. These are the extra tools you need, and the other smaller profile instrument retrieving the tumor and holding the suture knot. So these are few instruments you have to add to the armamentarium to have a good outcome. So now patient is positioned, draped, and patient is under neuro monitoring. You saw the images of neuro monitoring. Patient is neuro monitoring, and patient is sedated under propofol infusion with fentanyl, SOS. So patient is not paralyzed here. Patient is only completely under IV anesthesia. So because we need to see MEPs as and when required. So patient intraoperatively, Mahesha will also probe what he means actually seeing the neuro monitoring is. Now Mahesha is starting. We
So,
start the case now.
so
Mahesha
we mark the L12 level and before itself. So normally what I do is once I do this, I just take one AP shot, confirm the level, and after that I don't need any CM. So we take a transverse incision at so we are using 5.7
yeah,
working channel endoscope.
that's it. So today Mahesha is using
So we take one AP and lateral.
so he wants to take one AP image.
So just to
Mahesha,
confirm,
how lateral you have taken
just
from
lateral
midline?
to midline.
So it's just lateral to midline. You want to take one AP shoot to see where it's just parallel lateral to the midline, and he will take lateral to just see how much he has to plan a cranial caudal. He's taking a lateral image. You can see the lateral image. Lateral image is parallel to the disc.
Okay.
Okay, Mahesha?
Okay.
Yeah. So he's
So,
convinced.
yep.
You see the AP, you see the lateral image. Both are correlating what we planned. It takes laboratory here.
So the tumor should be just in front of us. When
So
we go
all
inside.
we need to do a bit of hemilaminotomy and
Can you
biggest
read it?
Now Mahesha is working from the right side. So right side of your screen, right side of your screen is cranial. That is clock is cranial. So
So this is any standard exposure when you do a decompression.
so anyone interested to see the decompression also just follow the technique.
So
He-
basically there is muscle tissue which we clear.
He's
Then
focusing on L1 lamina and facet.
okay, monopolar. Okay. So this is the monopolar standard polar which we use. So this is very useful to clear the soft tissues very effectively.
So this is a magic wand created by Mahesha. So after this, initially I was skeptical to use this, but now I use more than Mahesha.
May not be. I don't know. But anyway, so this is very effective. Actually,
No,
we
this is very effective and very fast. With this tool, we have stopped using bipolar in the extracanalicular area because this clears the tissue very fast, faster than plasma. Though plasma is also effective in this area, but this tool, when you especially you're doing fusion, you want to clear a lot of tissue, expose the joint. This helps me.
this is because you are doing more interlaminar fusions. You may
Fusions,
be
yeah.
using more than me.
Yeah.
Because I do transcam infusion, so I don't require much of monopolar there. So this one step is very important where we expose the part.
So what he's trying to do
Stop.
is go cranially,
Stop.
and
So
expose the part.
because I want to know how much lateral I should go. So this is the part. So we should go till here to keep the stability. Press. So if you have a 4 millimeter bone that is lateral to your decompression, then the stability is not compromised. Stop. So this whole thing is the lamina. You see, within 2 minutes, our soft tissue work is over. This is the magic of monopolar. Press.
So now he's trying to expose the
This is the
laminospinous junction.
this is the midline. So we need to clear the interlaminar window. We have to expose the L2 lamina also.
So within 2-3 minutes, he has exposed the upper lamina, the lower lamina, interlaminar space.
So if you are doing a tumor, you should have a good speed because otherwise it becomes difficult because you cannot take 2 hours to expose the dura. Then you don't have much energy or time to do the dural work, which is more difficult. So we do some burring here of the lamina grasta. So all the soft tissues should be out before we start burring, and bleeding should be well controlled. What is the blood pressure?
Blood pressure is 100/60, Mahesha.
Okay. Did you add adrenaline here? So this is the part. So we start drilling now. This is the lamina.
Okay.
So basically we need.
Yeah.
Okay. So this is a cutting burr. This is a standard laminotomy which we do.
So for any stenosis, how we do? We can do either you start from the laminospinous junction or laminofacial junction. It's up to you. And here in this case, the patient is a old gentleman, is around
Old?
he's 76-year gentleman, so bone will be osteoporotic. So every time what he's trying to see is check the part, how much is going cranial. So that's what he's trying to check. So it's a good habit to develop where you are seeing the.
Did you add adrenaline?
Yeah.
Okay. So bleeding, just add some adrenaline, so it will take care of the bleeding. Because there will be some more bone oozing than usual. So simple rule is your cannula should go inside your laminotomy window.
Yeah.
So
So the cannula is 9 mm, Mahisha.
Yeah.
The cannula is 9 mm. Now it's changed to diamond bar. So this helps
So this will reduce the
control,
bleeding.
reduce the bleeding a bit.
You have
Mahisha is using a Revo drill here. He's used to his own drill, but today he's using a Revo spine drill, which I regularly use. So he's done
give me kerosene,
laminotomy various.
kerosene. Or you can continue to drill also. So just release the flavum a bit.
So I use a lot of curate here, Mahisha.
Yeah.
I'm used to the your curate.
Yeah.
That's a wonderful instrument.
Yes.
I use a curate here.
Accurate.
So,
Flavum is little bit tight.
yeah. So you can see what he's trying to do is separate the ligamentum flavum from the bone. Always try to drill the base of spinous process a bit more so that you can have a good window to the opposite side. And because we are operating a tumor here, you need to have a good bony window which doesn't make our scope see straight. So you can see the hand image of Mahesha. He is trying to drill in such a way that his uh, hand should become straight so that he is in the midline working from both sides easily. Because in tumor, you need to have a good exposure from the midline and beyond midline also to the opposite side so that there is no pressure on the root.
And also, the main important thing is there should be space for our needle.
Yeah.
And it is not only about needle. Needle is about 80 millimeters. So we need space maneuverable because when you take the knot, it moves a lot.
So Mahesha is using a Prolene 6 tapered cut needle today, which is
Give me
8 mm.
cutting.
So he's using a 15 degree scope today. So 15 degrees, it's like operating under microscope. Vision is more straighter, tissue clearer.
Slow, sir.
Feel it. And even diamond drill stops.
Okay.
When you are using more pressure, beyond one pressure, it stops.
Okay.
So that's the technology where it tries to avoid handpiece damage, drill breakage.
This is a base. Huh?
So that's the base is drilled a bit.
We need to have.
So what he's trying to do is that's the path. So we are far away from the path, so coming more cranially.
Cranially and laterally.
Here you should be careful if you because the orientation of the facet here at L12 is more sagittal. So you will injure the joint. Remove complete fascectomy might happen if you don't take care of.
So we have enough bone here, lateral. Take.
So different surgeons use different burrs.
Okay, so
you can use a protected cutting burr
you can
here.
see that the cranial attachment of the flavum is exposed.
The big advantage here is you need not to do the spinous process removal for this
So this is the
tumor.
flavum. So now my cannula is going inside, so that is good enough.
So he's using a protected canula.
Lateral limit, Mahesh, in this case?
Lateral limit, basically, so this is the path.
Yeah.
So
How much
it's
facet
curate-
you want to remove? You want to?
we have not removed much of facet, but
No, you want to remove the superior facet a bit?
no, probably not.
Oh.
Because I am not planning to expose the lateral border of the dura here.
Yeah. So you need to develop control on the instruments. Always try to visualize what you are holding and pulling out. So that habit has to be developed. Otherwise, you will injure the. You should be ambidextrous. You want to have a good endoscopic outcome. Otherwise, so what now you see his hand image bigger. You see it's almost straight now. So now initially it was a little bit oblique. Now you can see the hand image is almost vertical, and his entire cannula is going in. So it means that he has created a good space in the window.
Correct. So that means the whole cannula is going in easily.
You can see the cannula is nicely going in.
So that means we have done good enough decompression. This is a lower attachment of the flavum which I have released now.
So what he's trying to see is the lower lamina. Oh. Yeah,
Can you see the lower lamina?
Yeah.
So
that's the lower lamina and the facet head. So because your tumor is there, it will be bulky.
So can you tell me we started?
It is 19 minutes.
Okay. So that's what I said. You should finish your exposure in half an hour so that you have enough energy and time for the work. So that's why don't do this tumor size unless you have enough experience and also the instruments. So this is the midline. So
it's trying to disconnect the ligamentum flavum. The half ligamentum flavum is trying to remove.
So the whole dura should be, in front of you before you start the stop dural work. Can you see? So I have to remove the tissue around. This basically from the midline and beyond. Okay, I think that side it is good enough. Grasper. So we take this fat. Is coming in the way.
So what I was asking him is the facet is little bit getting hitched to the cannula.
So we may remove little bit more facet. So I am very conservative always because if required you can do it anytime. But you cannot go back if you remove too much. Now our cannula is free. Freely going inside.
Going inside it is straight.
Little bit play on.
Trying to a little bit remove the. He's not trying to remove the through and through bone there.
Grasper. So I think now our dural exposure is good. Cannula is free.
Any bulge of the tumor is on the right side because tumor is pushed to the right side here?
I don't see anything right now.
Okay.
So we have
better is to do
open
a
and see.
durotomy.
So the big advantage is in microscope, you need a bigger exposure. So here, because of endoscope,
100 cases of endoscopy.
small window
we
is
want
enough.
to-
We can see here he has done just a laminotomy above, laminotomy below, and a partial facetotomy or facetectomy. So ipsilateral exposure, a little bit of contralateral exposure with intact spinous process base and spinous process interspinous structures. Big advantage is that you have exposed your working area without damaging the structures. What do you say, Mahisha? So advantage over microscopy.
Definitely. As like in any other endoscopic procedure, there is no comparison between this and open surgery. You see the
Operate a
incision
tumor.
is 10
Okay.
millimeter.
What extra skills you need to develop?
I think the main difficulty you will find is initially to find out the tumor where it is.
Okay.
Because once you open, no, there is all the roots will be there. You can't see the tumor unless it is pushed posterior. The most difficult part in this surgery is finding out the tumor because it is small. If it is big, once you open the dura, the tumor will be in front of you. Here you have to search for the tumor.
Yeah.
So
So
that-
this is a common issue even when you operate under microscope. Mahesh, just show the instrument.
Yeah.
That's the
This is the dural knife.
Dural knife is developed. It's a standard disc knife we use.
So this is the midline.
Yeah.
So I'll go somewhere here.
Yeah.
And
So he's just entering where the vascularity is less. The standard what we do for a spinal tumor. The big advantage here is the magnification. We are working so close.
thank you, the other one.
Sometimes I use needle knife here.
Okay, what needle?
Needle knife, what we use for arachnoid dissection. We have.
You have a knife? Yeah, I think once this is done, this is a very good tool. So we need something sharp.
Sharp, yeah. We can make a small rent because anyway we are opening the dura. So the idea is if you know where the tumor is, better.
The problem is if the tumor is bulging, it will open easily.
There will be so many
You
doubts
need
here.
more
Can we use a
tools
cutter?
here.
Can we use
So you need more
again,
tools where
if,
it should be
root
more
tumor
sharp
has
and
pushed the root
tapered,
lines
where we
posteriorly,
can do a proper
while opening, you
durotomy.
might injure the
So
root
this,
root.
because that
So
day
always be
it
careful.
was not cutting, Mahisha used the
Take
disc
some time, open the
knife,
dura here.
Okay.
but
See here is
I use a
open
needle
the
knife
dura.
where needle is very easy to penetrate.
Cutter here or use the same
Even knife for
knife.
people have. So we will use the knife now.
Yeah. Mahesh has designed a little bit
What happens is
curved
these
knife.
instruments they get
So this
blunt
is,
after a couple of
safer
pieces,
because it cuts away.
and autoclaves also.
So just opening the durotomy, making durotomy bigger. So
So
keep
we
space
are
for all,
developing
all
some
around
scissors
the
also,
way,
which
because when
we
you are
can
closing
cut
the
through
dura,
this.
you need to have some space.
Now you have endo scissors also.
If
We
you want
can
to check
cut
the
it.
monitoring, you can check. So I think this is our opening. So we'll not open much now. Give me a root retractor.
Now in India, we have started doing this
So we can
since
see the roots now.
1 year now. So Mahesha, myself, and
Putting
Mukesh
a root
is
retractor now.
here.
Trying to
My colleague is also
identify the
doing.
root first, the tumor first. Where is the tumor? Try to. It is not yet opened the arachnoid yet. You can see the arachnoid, intact arachnoid. He is trying to see where is the tumor. At the same time, trying to dissect.
Give me dissector. So we are not yet seeing the tumor.
Yeah, arachnoid bulging out.
You are stimulating? No?
Alpha.
Huh? Yeah, you can simulate one cell.
So, you know, monitoring this
Yeah.
person is stimulating
Okay,
it.
good.
It's all okay. Can proceed.
This is always the problem, when the tumor is small, it is difficult to find out where it is.
The saline pressure was 50, and if you have done a bigger durotomy, you can use the cottonoids to keep inside. To
So when you have roots coming out, just push them inside with the patty. And also keep this thread so that you can take it out later.
So at this point of time,
Okay.
you can manage the saline and reduce the saline a bit.
So this thread
That is not
too
पूरा
long.
लंबा नहीं चाहिए. You can just keep a little bit of thread. You need not have such a big thread.
Okay. Fine.
Just to have a marker, you can have a thread.
Okay, give me this. So that is a fatty. Just to manage the roots. So just push it inside so that the roots don't come in the way.
So what he's trying to do is push the cotton patty. Standard cotton patty, we use it
Okay.
for the
Root retractor.
neurosurgery work. Now he's using a root retractor here again to find out where is the tumor. So, so
that-
that's
that
the
is
tumor.
Can you hold this?
That's the tumor.
Dissector. I get called.
That's the tumor.
So,
So,
okay. So will they again confirm that it is a tumor? Okay. Can you see?
so
Appreciate.
definitely the tumor is palpating the tumor.
Okay.
You felt the tumor.
Okay. Grasp.
So
Give me
easy
small
ways
grasp.
to,
Yeah.
ways to
Yes.
you gently pull it out
Yeah.
into the field, into the exterior.
Yeah. You have to get this delivered
Just
outside.
gently get it to the exterior. So just don't
Then
use
the
any
root.
pressure. Just squeeze it out. Even you can cut the arachnoid, just peel the arachnoid. It just will come out into the outside the dura, so that it is very easy. Sometimes
Really,
it's very friable.
in them.
Now
You
you
see?
can see
Can you see it?
outside
Take it.
now.
Take it.
The tumor is outside now.
So this is the most critical step.
So you can see as open the arachnoid and the tumor is also here. You can either do a debulking.
No. We are taking it out and
Or you can remove it and total. So always NMAS is always better. Yeah. You can remove that floaters if you want. The bigger tumor is very small. You can take a biopsy here.
Open. Yeah, it is open because it is friable.
Tumor is very friable and it is opened out. So it's trying to pull the tumor out gently. See the edge. Don't pull any rootlet. So
Yeah,
you can see now.
It is attached. You have a root attached.
Of a rootlet. It
Okay.
always comes from a rootlet.
Okay.
Schwannoma always have a rootlet with it. Yes.
Shall we cut it or you want to stimulate that root?
We will do.
Cut maಡು. Cutter put. Okay. So we just cut off this root. Huh?
So we can coagulate and cut it, or this is a small rootlet. So it's arising from the tumor is arising from the small rootlet. You just disconnect it. Just disconnect it. Release the arachnoid all around. Your tumor is out.
Give me another cutter. Okay, now it is released.
Tumor is released. Now.
You see that whole tumor, we have got it out of the wound. I mean, out of the dural opening.
Yeah.
Right? Because if you remove piecemeal, it is hell of a trouble.
So always,
Stop.
as in microsurgery, always try to remove the tumor as a whole is always better.
So now I
am removing the
bigger grasp. Because if you use smaller grasp, again it will not come out in one
So
piece.
what you see the trick is then you see outside a bit now. So sheath is not going into the space, is outside. Just see now it's coming out. It's entire and see any rootlets are coming out.
I removed it gently. I could feel there was a rootlet attached, but I took it out.
So we use smaller grasper to deliver the tumor out of the dura and then change it to a bigger grasper, because with the smaller grasper you can cannot take it out. You see the whole thing?
Whole thing is that's the entire rootlet which was that's the tumor along with the a small rootlet.
Okay.
Yeah. Focus properly. Madhu, focus.
Okay. Okay. So all this time our Patty is helping us. Can you check the neuromonitoring now?
Can you check the neuro?
Yeah.
So
Yeah.
MEP stimulating and all MEPs are okay.
Okay. We have pushed the residual that root inside.
Yes.
The Patty is there. We just have to take stitch here. Okay.
Mahisha, what is the fear always any surgeon has is that will saline go into the
No, nothing happens. I operated huge tumors for 3 to 4 hours. Nothing happens.
So the fear of saline seeping inside causing some issues is not there because you have kept the fatty there and saline is always coming
So
out.
what is the time now? How much time you
So
take?
till now we have spent 40 minutes.
Okay. That is
So
excellent.
till starting.
So
till
there is
now.
no tumor there.
Yeah.
Okay. So this patty we will keep it there
That's
for
neuromonitoring, so all the waves are intact.
direct stimulation. You see the tumor is completely out.
Yeah.
Okay, we take the stitch now. This is
So
the
you can see now we are using a proline. Dr. Chatananga, you can show the
Can you hold?
needle
So
human Mahisha,
yeah.
needle liquid.
Okay.
Now you can see the neuromonitoring waves are good. So this is the neuromonitoring MEPs are normal as pre-op and just we can stimulate. We are stimulating now. Yeah. So we are stimulating now. All MEPs are okay as pre-op. No difference in the MEPs. All MEPs are preserved. All the roots, including the perianal sphincter, we have taken the anal sphincter also, external anal
So
sphincter.
can you show here?
Now
How I
go
load the
hand image, yeah. So that's
don't push inside.
yeah.
Okay. Go inside. This you go inside.
See the needle how he is holding. This is a 8 mm needle and that's the long needle holder designed by Mahesha. So that's the needle holder. This will be shown, you can see in the
So we go inside because if you keep the needle horizontal, it will not go inside.
Yeah.
Because working channel is only 5.7 millimeters. So we go inside. Okay.
under vision.
Under
See how
vision.
he's doing.
Just gently twist. Okay, I come out. This is outside in, then inside out. So again go inside.
So can we take one by one, Mahesha?
You can take one by one also.
Yeah.
But sometimes it is easier to take both together.
Okay.
So if I'm not able to get together, then I will take one by one.
Okay.
That's why needle.
How many stitches take? One
For
or two?
this I will take 2.
Okay.
Okay, I come out. Then I take the other one. Normally you'll be able to get it together. Needle is 8 millimeters, taper cutting, and 6 mm.
Round body, taper cut, 6O, 8 mm length needle.
Okay.
Yeah.
I come out. Now I have to just push it in bit. So here you require very fine control of your hand. Okay, give me a small grasper. So when you take out the, I can use a grasper to, it has come out a bit. Again, I will push it in. Okay, so this is a little bit of, sometimes this will give you problem. Just hold the scope. I have to go do the steps again.
So this we need to practice. It comes with the practice. You need to have a fine skill and you need to have a good team associate to help
Okay.
you out. Otherwise, you'll. That's what Mahesha was telling initially. If you, so I was asking him to do a
Okay.
bigger durotomy. He was hesitant initially because he didn't want to have a root slits coming out.
Yeah, it is very important because every step is very critical.
Yeah.
Because once you take a wrong step, then you cannot go back. So I go inside. This is easy, and then the second one.
Biggest advantage is the vision. You have such a beautiful vision.
So this needle holder is very important. You see. So now I catch it and I twist it. Okay.
Yeah. Excellent. So now just to show how outside.
So hold it. So,
Yeah.
yeah.
So now what has to be done is outside.
Yeah. Can you hold the scope? Now my assistant will hold because he is experienced with many sutures.
So
I am holding two sutures, whereas my assistant is stabilizing the scope and cannula. You just take a simple knot here. Okay. Just a simple knot. Okay. I've taken a simple knot. Can you see the knot?
Yeah.
Okay.
You have taken
Then
only one knot or two knots?
only one knot.
Okay, only
And
one knot is taken.
then it goes one end goes to the our knot pusher. Sister hold this suture. Okay. She is holding the bid. The one suture is in my hand and my assistant is holding the scope. So now we push the hold it. So push the knot inside. Can you see? Go inside. This is pushing the knot inside. Can you see the knot there? Okay. I go inside and push it.
So both ends are held by one end by assistant, one end
Okay.
by Mahesha, and
Bid it.
scope is held by assistant. So again they do the same.
So same procedure we repeat. Again we take one more stitch.
Just taken one more.
One more knot.
Simple knot.
Sometimes this is a bit messy because of the water. Gets okay. Taken one more knot and we again push it inside. So it is very important to have a good assistant who will stabilize the LED. Sister pull. Yeah. Tangle. So if there is a tangle, just take it out. Sister remove. Release your hand. So what I do is I take the knot again outside. Okay.
So for this simple logic is if you have a shorter scope, shorter cannula, you can't use a bigger, longer scope and longer cannula because the suture will become a difficulty then. You should have a shorter scope here. This is a small change you have to make. So we're using a shorter scope. The length of the scope is, I think,
On 12.5. 12.5 mm.
120
centimeter.
mm, 120 mm scope. That's 12
There is other
centimeter is the
one.
length of the
Then you would
scope.
call. Okay, leave
So
it.
this is same arthroscopic principle we are doing here. Putting a knot outside,
Okay.
using a knot pusher to push the knot.
Okay. I think
I
there is, yeah. Okay, that is the second knot. Bit
Yeah.
loose. Okay, bit.
We have put two knots, at least 3 to 4 knots.
4 knots is minimum.
4 knots is mandatory because proline, the knot holding strength is weak. So 3 knots sometimes it might become loose.
So this is the third one.
The third knot is pushed.
Sometimes these knots, they become jammed.
We can use endo clips here.
Sometimes these knots
Ille
don't slide,
ಹೊರಗಡೆ
so
tight
that is
ಇದೆ.
the problem.
So now we use
See?
endo clips also, pediatric
The knot is not moving
laparoscopic,
inside, so just come out and see what's happening.
pediatric laparoscopic titanium clips, which are very easy.
Double knot again. So
So-
there is a double knot.
Yes,
We just that's okay, don't worry. Just not to show.
So you can use the endo clips also here where used in pediatric laparoscopic surgery. So we can use that also. There is some knot formation there.
Okay. Good, yeah. So we'll take 2 knots outside and push it inside. So this is the 4th knot. Okay. And one more knot will place. So this also you can do. Like. So I have finished all the knots. Okay, see this? So we have put 5 knots. 4 or 5? 5. Take this. So we have put 5 knots. Now we put the scope inside. This, because we had put only 2 knots, it is not secure. Okay. So we will cut that off. Give me grasp. We will cut it off in the end because this will hold a little bit of dura together. Give me cutter. So this extra sutures we will cut it off and take a new knots. Okay. So this extra sutures we take it out. I got it. Okay, we'll take one more knot. This knot is not secure, so we have to take another 2 knots. So dissector. So you can see how the dural suture is even better. Okay.
So now saline is around 40 to 50.
Okay.
So you can increase a bit if you want. And sometimes needle gets blunt after 1 or 2 bites.
Yeah.
That also is there. So you need to.
So Mahisha, you use one suture for one entire needle for one suture.
So with the one suture, you see all the.
You see
rootlets
everything is holding very well.
Yeah.
But we will take some.
You see how he is holding the needle there. He has made the needle little bit straight so that it can go in easily. Now
What is that?
the assistant is holding the other end of the needle,
Okay.
and now he's going in. So this is very important. If you have done a good endoscopic case, you have the control on the scope and instrument. You can see some root is coming in his way. Be very, very careful not to take the arachnoid of the rootlet. So you just manage to protect that root, not take the arachnoid of the rootlet. Trying to take this bite. Once this bite is taken, definitely see that now that root just stop there, will not come out. Just rotated it. Once you put this knot, it will go inside.
Has to be freely mobile. Can you see? When we take the knot outside.
You can see taking a simple knot, simple one knot, and is using a knot pusher. One end the assistant holds, the other end surgeon is holding.
Hold.
One end the assistant holds, the other end surgeon is holding, and is pushing the knot now. Just push the knot. Both hands are still so that knot goes in easily. Gentle pushes, don't force it. Gentle pushes. You see a hand how is gently pushing. See the gentle pushes. Now the endoscopic image bigger. Endoscopic image bigger.
So you have to push gently.
So you can see how he pushed gently, looking all the time. The arachnoid is not coming. The rootlet is not coming. Person has done good arthroscopic. This is the second knot. This knot, they in hand. So you have to learn. And the knot also outside, the assistant should take care not to get entangled. Now they are taking the second knot outside, and again assistant holds one.
Because water is there in your hand. It's slippery.
Because of the water,
Okay.
it lubricates.
Yeah.
Knot is pushing. At the same time,
Same step. But only thing is this. You have to do slowly. Otherwise it gets broken.
nicely now sitting. So this little bit practice. Compared to previous knot, you see the knot nicely sitting there. And again is pushing the third knot now. This is the third knot, right? Fourth one? Yeah, it's the fourth one. So you see the knot now nicely sitting.
Now we take the final knot.
Approximated very well now. So Mahesha wants a 5 knot. So that's the fifth knot. See that knot is nicely sitting now. Excellent, excellent, perfect. So the assistant should not pull the dura too much. Otherwise, sometimes you have not taken adequately. It gives away or it cuts through. So it should be
Cut this off.
And this is a 6 mm proline, very, very thin proline used in cardiac surgeries for vessel repair or vascular surgeons. For you should have a good cutter here, otherwise you will struggle. So
But still we'll take one more suture down.
So for each suture, you have to open one full suture because length will not be adequate. He has hardly done because the entire scope is sitting snugly in the space. It means that he has opened around 6 to 7 mm durotomy. So 6 to 7 mm durotomy, 2 sutures are enough. But he's for the sake of safety, is taking 4 sutures. This is a very, very magnified view. So you should understand we are taking very, very magnified image where we think we are taking the too many sutures. The durotomy is big, very, very small durotomy. That's why your planning should be perfect. Where the tumor is, open the dura.
That's why I did not extend the.
Yeah, we were
Dura
insisting to extend the dura initially, but Mahesha was hesitant. With his experience now, he has done around 8 or 9 cases till now. It's a very good success, and even he has published a paper now. Is accepted and it will come out. in shortly. So here assistant should be very careful not to put the cannula deeper and plunge inside and you cause dural
Yes, that is
compression.
very important. Yes, hold on. So we go inside again.
All the time the neuro monitoring colleague is very active looking at the waves. Any issue he will tell us. So that way neuro monitoring helps here.
You see, one bite I have taken.
Yeah.
It is outside in, inside out. Together one shot. And you just rotate it. Okay. So okay, the lip. So we take again same steps. Suture outside. I mean not outside. And push it in. You can see the 4 knots there. So this is the final picture. Okay, the durotomy is very well.
So excellent. You can see the image. So you can see the all the no rootlet coming out. Dura is opposed. We can stop saline and see a bit.
You can make the head end up and
head end up. Mahesh has stopped the saline. There is no bleeding also. There is no epidural ooze also. So this beauty of endoscopy. Switch on the saline. So there is no bleeding whatsoever. So there is no need to place the drain. No rootlets coming out. A small durotomy of 6 to 7 mm. Because the entire sheath is 9 mm. You can see the durotomy is
about 5
to 6 mm. That's it.
That's why I was against any exposure. I mean extension of.
So this is just like a dural injury when we are operating any stenosis case. A small durotomy which has closed with 4 sutures. Even 2 sutures was
even one will be enough here because
enough. So now we just close the suture
Thank
with
you.
a small subcutaneous facial stick and then we put a final suture. Thank you. Thank you very much.
Thank you. Thank you.
Just imagine a spinal tumor done through 8 mm hole. It's amazing result. And I'll just show you the post-op image. You can see that's a laminotomy and festotomy has done, and the entire tumor is out. There is no much bone loss. That's it. So you can see the entire rootlets now nicely in shape. Dura shape is come back, and that's a laminotomy. So you see the uh, injury we do to the muscle or a tissue when we do a micro surgery for this tumor. I would have done easily the 2 hemilaminectomy L1 and L2 and would have exposed a bit of spinous process. I would have removed and done a if I'd used a microscope. So this is a big advantage of endoscope, and as many more cases to be done, tools to be added, which Mahesh already has added, and people are interested. You can see outside the tools have been kept there. But in coming years, the more and more tools, especially the suturing techniques. The next case we show you how to apply the endoclips also, where we operated 6 centimeter tumor. So my colleague Mukesh Kumar, neurosurgeon from Tanda Medical College, is an associate professor there. He also has been doing tumors for past 1 year, and he is here to share his experience and how to suture. So
Any questions on this case?
yeah.
One advice there or suggestions when major problem is the during opening and suturing, right? We can remove a small tumor, that's not a issue, not a problem. My advice is there when you are opening the dura, right? In the first, just after giving the small nick in the dura, and when you are increasing the dural size, during that time, take a stay sutures, one on this side or two on this side and two on other side. So what will happen during the arachnoid dissection, your rootlet will not come out. In any neurofibroma, there will be one ascending, one descending. So rootlet, you have to cut it because there are some major vessels also. So whenever you take the straight sutures, the rootlet will be inside. There will be light traction over the dura, and the closure will be very simpler. We need not take by again, go again and again and take the suture. So when the stay is there, just you can take it and knot and just push it down. It will be faster.
Yeah, so we tried that. One difficulty with that is because we're doing monoportal. So too many sutures seen, and it will cause because when you are suturing, it becomes a difficulty because we are using a monoportal technique here.
You can take 8 mm A20 or 10-0 also. It's
Yeah.
just a stay. That will be much better. I think one is also sufficient. Take one
No,
this
we
time.
have done that, but this case it was not required. That's why we did not do it.
It can do. That's a good suggestion. Yes, definitely that can be done. Anything else? Yeah.
Hello. Yeah. Sir, in this case, yes, the tumor did come out with very minimal bleeding, but majority of the times in IDMs, there is always some troublesome bleeders. So in such
Yeah,
cases,
if you want to see the bleeding, you watch for the next case. You will
Yeah,
see.
so next case was a very, very highly vascular tumor.
Okay.
So you can see there.
So their RF can be used.
Yes.
The,
Yes.
so you have to change the settings for the RF.
No, no.
The same thing.
Yeah. Yeah. Over to Mukesh. So Mukesh will present his experience of spinal tumors.
Just one last
Has
doubt.
been doing past 1 year. Any questions you can ask further so that we can in the waiting time we can.
So just one doubt, sir.
Yes.
Yeah.
In microsurgery, after dural closure, we give a Valsalva maneuver to check the watertight closure. So how do we achieve that here, sir, in endoscopy?
Here also you can do
We
that.
have done, making the patient head up and, but there is a difference between open surgery and endoscopy because there is no dead space here. Even if there is a leak, it's not an issue. It's not going to
So
give
you
you
should
trouble.
imagine the opening here, the durotomy. You have been operating here with a 10 mm sheath. 10 mm sheath was sitting there. You have done a 10 mm space. In that you have done hardly 6 mm opening. 6 mm. So it's very small. So even sometimes we do a durotomy, we don't close also. Right, in surgeries, in microsurgeries, you just keep a Duragen patch and come out. Yes, yeah, so it's a very small opening. Nothing happens, and I'll show you in the next when you go to the thoracic. One case I just stripped the entire dura, including arachnoid. So nothing happens because the opening is small. The meningocele is very less. Ready? Yeah, connect, sir.
Yeah, we are showing
Yeah, yeah,
in the next
we'll
case.
show in the next case.
Okay,
Yeah.
we could close 5 centimeter dural opening in 4 minutes.
Good afternoon. My topic is spinal tumor excision by full endoscopic monoportal technique. So first report of endoscopic spine surgery that date back to 1990s, and Centruk and Ansel in year 2019 did a case of lumbar interdural meningioma by this technique, and few years later Vincent and Hegel they did a full endoscopic section of interdural schwannoma, and there is no case series so far. So then I will jump to directly to the first case. This is a D8 tumor. So so this is a 60-year-old male patient who presented with low limb weakness, which was 3 by 5 and 4 by 5 in both the lower limb, and proper consent was taken. And as you can see, this is D8 lesion on MRI. And on axial images, tumor is pushed to right side, whereas spinal cord that is pushed to left side. And this is how skin marking is done. Then drilling is started at D8 level and with the help of C-arm. So localization of tumor is very important under C-arm. So if there is any error in localizing the tumor, so there can be, then you can land up in extra bony drilling, and which subsequently can lead to extra large dural incision. So if there is dural incision, large dural incision, that will create problem later on. So now I'm drilling the base of spinous process so that I can go to contralateral side. So to go to contralateral side is important, so that we should have a good wide bony decompression, which is important for endosuturing, so that your needle should not stuck here and there. So we should have a wide corridor. So this is bony decompression, wide enough. So next is dural incision with this specialized instrument, which is quite sharp enough. So I'm extending my incision cranially and caudally. Now, as you can see, tumor is just in front of us. So that means our localization was correct. So this is orientation. So we can use few instruments to mobilize the tumor, like hook or pen-filled dissector. So after initial mobilization of the tumor, I realized that this tumor was quite soft, friable, and this was coming spontaneously out. So I just decided to take few punches of biopsy. So I just ensured biopsy first. Then I did some internal decompression of tumor. As my intra-op impression of tumor was meningioma only. And as we all know, meningioma has its attachment to dura. So this tumor is attached to left-sided dura. So this is how internal decompression done. So as you can see, this is not putting any traction on spinal cord. So my next plan is to detach the tumor from its attachment. So with the help of pen-filled dissector, so I try to detach the tumor from its attachment. After a couple of attempts, I separated tumor nicely. So tumor became almost free. Then with the help of grasper, I took a large chunk of tumor and delivered it out. So this is large chunk of tumor. Then few other large pieces of tumor, they were also mobilized nicely. They were also made free from spinal cord as well as from dura. Then they were also delivered out. Utmost care was taken at this point not to put any pressure over spinal cord. And there was some bleeding, which was controlled with the bipolar radio frequency as well as with the help of Surgicel. So after ensuring hemostasis, this Surgicel was put aside. This was kept to lateral recess. So hemostasis is very important in this case. Then inspection of the cavity is done. So as we know from the MRI, spinal cord was pushed to one side. Now we can see the spinal cord that is totally untouched, that is totally intact. This is covered under dura nicely. whereas tumor cavity, which was on left side. So now we will inspect this tumor cavity. So the tumor cavity is also free of tumor. So thorough inspection was done cranially and caudally, as well as its dura was also free of tumor. Then next part is endosuturing, which is a difficult part. In this case, I tried endosuturing with some different instrument, which I borrowed from urology department. They use this instrument for some laparoscopic procedure, and it has some auto locking and auto unlocking system, which I was not aware of. So because I was using this instrument for the first time, so I had some troubleshooting using this instrument. So secondly, this was taking a little long time. So I decided not to do endosuturing in this case deliberately. So despite of the fact, and secondly, there was one more reason, because I had already done endosuturing in 3 of my cases, and this was my 5th case. So I deliberately decided not to use. And despite of the fact that I passed needle through the dura, which is the most difficult part. So despite of this fact, so I still decided not to use endosuturing in this case. And I took this needle out. This is 6-0-proline. And after taking this suture out, I put Surgicel in the cavity so as to keep it as a inlay material. Then I used Baxter's Hemopatch as a overlay hemostatic as a sealing agent. This is primarily used as a hemostatic agent, but it has got a very good sealing property also. The moment it comes in contact with surface, it makes a covalent bond with blood protein and makes a very good sealing gel pad. So this is a hemopatch. So you can see, so post-operatively, there was no CSF leak, no pseudomeningocele, no meningitis. So patient did well, and there was no deficit. So this is pre and post-op MRI. Second case, G12L1 IDM. So enhancing lesion, and this is G12L1 on right-sided tumor. So initial steps are same. So I will just fast forward it. So this is bony decompression, lower end. This is upper end. So steps are same. Then dural incision with this specialized instrument. So now you can see tumor is again in front of us. So this is a cranial pole of tumor, which I'm releasing or detaching from its adhesions. So I'm using a regular bipolar and annular cutter to release or detach this tumor. So one thing in addition to this, which I wanted to show in this video, how to retract dura, ipsilateral dura to ipsilateral side. So this is the working sheath. I'm using the beveled edge of working sheath to retract dura to ipsilateral side. And one more thing, at this particular level, rootlets are a big problem. They are coming just in front of tumor all the time. So I'm using Mirocell. So this is Mirocell just to just I diluted pause. So I'm using Mirocell to displace the rootlets. So then this is a caudal end of tumor. So I'm detaching caudal end also. Then with the help of a root retractor, I'm just mobilizing the tumor and then delivered this tumor in toto. So this is total excision. So then the second thing which I wanted to show, endosuturing. First I put Surgicel inside, then 6-row needle, then took suture out, and then did extracorporeal knotting, and pushed not inside with this specialized instrument. Then cut it with annular cutter. Similarly, other suture was also taken. So now you can see I'm using, in this case, I'm using the regular disc forceps or regular grasper. The same step, taking needle out and extracorporeal knot and then pushing it inside again. So in this case, I took 3 sutures. Then I added G patch over it. So this is G patch, 1 or 2 layer of G patch. So post-operatively, patient did well. So you can see pre and post of MRI. So there was no residual tumor. These are axial images. Again, a short third case, a short case of D3 calcified meningioma. So which was somewhere 15 into 13 millimeter, which was calcified one, as you can see on CT. Some marking is done in the same way. So initial steps are same. So again, dural incision. So mobilizing the tumor with grasper. So this is tumor, this is dura. So I'm mobilize the tumor. The one thing which I wanted to show in this case, that we can also use stay suture also like this, so that we can detach tumor from its ipsilateral dura. So stay suture is also feasible and possible. So now I will just fast forward it because this is the same step. So then again, extracorporeal knot, first suture, then second suture. So after taking second suture, then I added G patch as overlay. So patient did well, and this is incision. So post-op MRI, there is no residual tumor. So these are my endo instruments, specialized one. So this I use as a knot pusher, which is detachable from its terminal end. So you can attach and detach from this end, and then you can use other instrument. So this is endo knife, which I use in this case. So clinical outcome in all my 5 cases were quite satisfactory. So there was a good improvement of VAS score, and there was good improvement of motor system, motor power from Asia B to C, and power was from 4/5 to 5/5 in a couple of weeks. There was no added motor deficit. So coming to endosuturing and other alternatives, in initial 3 cases, I did endosuturing, as well as I used other alternative also, like Surgicel as inlay and GPS as onlay in 3 cases. Then in last 2 cases, I deliberately did not go for endosuturing. So I used Surgicel as inlay and GPS as onlay in one case. And in last case, I used Surgicel as inlay and Hemopatch as onlay, as you just saw in one of my video. So post-operatively, there was no complication like CSF leak, pseudomeningocele, and meningitis, even after 7-8 months of follow-up. So there are certain challenges also. One is like localization of the tumor, especially in upper dorsal level, where your C-arm is sometimes not very reliable. So your localization is a problem sometimes. Then we don't have a good specialized instrument, or the instrument which we have, they are not up to the mark, or they are not a refined one. So we need good endo knife, good endo needle holder, dissector, knot pusher. And dura retraction is again a problem, again a challenge, especially ipsilateral dura. So either we can take stay suture the way I have shown, or secondly, we can go for bevel. We can use a retractor also, the sheath also, the bevel edge of sheath, so as to give it a bimanual filling. Then suturing is again a problem. I use 6-0 proline, half circle, or sometimes 3/8 circle. And I have also used proline 7-0 and above also. But using higher number is a problem, especially when you are taking extracorporeal knot. So you cannot see suture with naked eye. So visibility is an issue. And sometimes narrow corridor is also a problem. So especially while doing needle maneuvering. So that's why we need a good bony decompression, good corridor. And bleeding is again a problem everywhere, whether this is endodiscectomy or endofusion or anti-tumor surgery. So apart from regular measures, we can go for Surgicel, gel foam, Mirocell. Mirocell, you can put a small piece of Mirocell from the area where the bleeding is coming, and after 2 to 3 minutes, you can take out the Mirocell. And we can also use adrenaline 0.1% in 3 liter of saline bag. There are certain limitation of this technique also. So first one is learning curve. So I personally feel it has got more steeper learning curve than endodiscectomy, endofusion. Secondly, instrument non-availability of good instrument is again a big hurdle, a big limitation. Third limitation is size of tumor. I personally believe 1.5 centimeter or maybe up to 2 centimeter is a reasonable tumor for this technique, although larger tumor can be done in expert hands. Or secondly, if tumor is cystic one, so then that is a different story. And we don't have enough data in the literature which can support the efficacy and the safety of this technique. So we need a larger studies, larger sample, so that we can replicate in future or in our practices. So again, there is no case series. So I'm already in the process of publishing this case series, small series. Hopefully it will be published. Thank you.
Excellent presentation, Mukesh. So, uh, definitely there are limitations, and a beginner should not try it. Second thing, only when you master the lumbar cases and you do cervical, dorsal, extra canal work, only then intradural work should be tried. Or who have the habit of doing tumors microscopically, they can handle better.
Yes.
Person has not done a microscopic surgery, uh, he might have harm more. So definitely he should not try if he had not done microscopic tumor surgery before. That is my suggestion. So long way to go. Mahesh has devised some instruments. We have devised some instruments. Long way to go. Maybe we can refine our instruments and publish data collectively, so
Yes,
that the larger series, the better.
Yes, sir.
So definitely we can collaborate and publish our all data. So I think we have done. I have done 2 cases. Mahesha has done, I think 7 cases. Mahesha, eight cases. You have done 5 cases. So it's a big number. So definitely the long way to go. More learning need to be done. Understand the intricacies of intradural work. So, but definitely there is a scope. So that's what the biggest advantage I see is the exposure. With a small one port, we are able to remove these tumors. The morbidity, because post-op patient doesn't have any morbidity. That's the biggest advantage. As a neurosurgeon, my post-op patient will have a drain. I keep it for 3 to 5 days, hoping that CSF should not leak. If CSF leaks, then I keep the drain for more days, or I put a lumbar drain if I remove the drain. So it's a and patient has a chance of meningitis in between. So these are the problems of a intradural work when you do with microscope. So these challenges are very, very less when you do with endoscope, because your opening is small, and because the skin and the muscles you have just dilated, they oppose, and the chance of, even though there is a leak, it doesn't have a leak outside. And the pseudomeningocele formation is also less, because once the muscle oppose, even there is a CSF leak, the pressure is so high that it stops the leak, and that doesn't form a
pseudomeningocele. So that's a big advantage I see because your opening is small. So the definitely the tumor work, it's a lot of scope. Maybe the next spinoscope, many people will present their
Actually,
tumor
I had
cases.
operated one pregnant lady at 18 weeks of gestation, and she was paraparetic. She could not even walk. She recovered completely immediately after post surgery. Went home in 2 days. Completed her pregnancy at 40 weeks. Absolutely no issues. And another patient at D11, D12 tumor with complete paraplegia, with bowel bladder, no sensations below the hip. I did endoscopic excision. He fully recovered.
It's definitely
100%
the
recovered.
handling and the damage to the nerves is very less. So definitely.
But I see a lot of opposition to this technique by the traditional surgeons.
Yeah,
But we will break these barriers.
it is always there when you are proposing a new technique or it is in development stage. Definitely there are more critics, but we should take that criticism positively and become better. Any other questions so that we can move to next case, the Superman case, 6 centimeter tumor operated.
This is a jumbo tumor.
Jumbo tumor. Largest in the world, yet to be reported. Thank you, Mukesh.
Thank you. Yes. Yeah, I wanted to experiment.
Actually, that level is dorsal, so there is no roots coming out. And also, when the dural incision is small, there is no defect as such. It gets opposed. But in the lumbar spine, I think it is always better to avoid arachnoiditis. So, because if you leave the dura open, it can cause arachnoiditis.
After opening the dura, is it safe to use adrenaline, sir?
Safe to use?
Adrenaline.
Yes. No
Even
problem.
after
Yes,
opening
so
it.
no, nothing happens. Because you are using very low dose of adrenaline. Nothing happens.
Flows out before it acts.
Sir?
So it flows out before it acts, so you don't need not worry. Saline is always getting irrigated and coming out.
1 ampoule in 3 liters. Yes.
0.1%, 1 ml in 3 liter.
So I don't use it, but Mahesha is using since very long time with good results. Okay, then we'll thank you, Mukesh. Thank you very much. So we'll move to the next case. This is a big tumor. You can see. I will just go through the radiology. Voice petali. Voice petali.
Okay, sir. Ready?
Voice out. Okay, right. Got it.
Okay.
So you can see here this sagittal images. This patient came to us with paraparesis, young patient for I think a 40-year-old male patient came with paraparesis. You can see the sagittal image. It's a huge intradural tumor arising from the conus epiconus area. So when a tumor is so big, it is difficult to ascertain whether it is intramedullary or extramedullary. It is difficult. And you can see it's a solid cystic tumor and the location typically looks like it's a myxopapillary ependymoma or a cystic schwannoma. So until unless we operate, we don't know. But this patient, we offered him both endoscopy and microscopy. So he chose endoscopy, and we told him that there is high chance that we might convert and do microscopy if we are not able to deliver it out. So T2 weighted, what you should see, T1 and T2 is that what is the intensity of the solid part here. The more hyper intense, it means that a tumor will be more suckable or friable. If it is less intense, then it means that it is more firm, fibrous. So you might require an instrument like CUSA. And also T1 weighted again, the cystic part you can see, it is not looking like a cyst. So we had a, and you see here, it is pushed the cord anteriorly. So probably it is, initially we thought it's a extra medullary. Can see there the cyst pushing the cord anteriorly, spanning almost two levels, D11 and D12. So the here you should plan how much lamina you want to remove. So plan was to do a two-level hemilaminectomy. So I can just fast forward it here because for the lack of time. I'll just fast forward it. The axial to. So coming to axial now, so you can see the axial images. Tumor is pushing the cord to one side. That's a cystic part, and you see the cord crescent shape and see the fluid level here. I want you to notice the fluid level here. Marker is the pointer. So this is very important. Radiology should be read very important. There is a fluid level here. If you see this fluid level, you should understand there might be a previous hematoma. You see a fluid level. This MRI is done lying down, right? Once a patient is lying down, this is a cyst and there is a fluid level. It means that probably it is a old hematoma with a solid hemosiderin deposits causing a fluid level here. This is a cyst and this is a thecal sac, crescent shaped thecal sac pushed to one side. Maisha, was telling
Yeah,
something.
that is a cord which is pushed to the side.
Yeah. So the cord is very thinned out here. Now, at this point of time, it is difficult to tell whether it's extramedullary or intramedullary, but this shape denotes that the cord shape probably it is extramedullary. So that's what it shows. But whatever we can, the entire cyst, fluid level, cyst, and the tumor is pushed to one side. So then the solid part of the tumor is entirely occupied, entirely occupying the whole canal. So that's the end of the solid part, so cystic part. This is a solid part now. So you can see the solid part entirely occupying the canal with the cord pushed to one side. So this is the advantage here because endoscopically when you go and do laminectomy, you only see the tumor. You don't see anything else than tumor. That's a big advantage. So then the surgical planning, how many levels we need to drill, that is very, very important. The extent of as Mahesha was emphasizing and Mukesh showed that if you don't drill properly and you are not on the tumor, then you start struggling and you start drilling more and more. So this is very important. The drilling is very important. For that, you should have a proper plan on the MRI. And here it's not a chronic lesion. The bone is not thinned out. So it just shows that it is not a chronic lesion. Then you see the contrast MRI now. So this is very important. So the contrast MRI, this is what you can see here now. Intensely enhancing. If you see this enhancement, someone will think it might be hemangiopericystoma. So it's very common enhancing like this. Cystic solid, it can be a cystic solid hemangiopericystoma. So good that endoscopy helps because of the saline irrigation, we can coagulate better. Myself.
Yeah, it was a highly we expected vascularity, but when we went inside, it was too much vascular. It was bleeding everywhere. There were multiple blood vessels which were feeding the tumor, and with endoscope, it is much easier to control bleeding lesion than other techniques. So here the planning, you see, the tumor is quite big. So if you err your incision even few millimeters, then it will give you a lot of trouble in getting this tumor out with one incision. So in that case, you may end up with putting two incisions to access it cranially and caudally. But here, we managed to get it through just one incision.
You can see the axial image. So intensely enhancing tumor. Cystic part is not that enhancing, but the solid part is intensely enhancing. So you can see the tumor. That's a cystic part. That's a solid part. So we'll, then again, the plan is to we did with this neuromonitoring. The scope length in tumor surgery, the scope length should be smaller
So
because
here we took the
we
incision
want
at
to
the
do
lower
a
border of
suturing here.
L1
The
pedicle.
longer scope
So
will
that
have
the plan was to drill the entire hemilamina of L1. Entire hemilamina of L1 was removed on one side, plus the flavum till the upper lamina and till the lower lamina, so that we have enough access for this tumor.
push the knot down, you will face difficulties. So when you have a longer scope. So scope should be shorter when you are doing a tumor surgery.
So this is the opposite side. So this is probably the midline.
Yeah. That's the midline where you see the pinkish discoloration. So he is trying to drill the opposite laminospinous area so that we'll have a good vision. And the suturing is also easy. Stenosis exposure when you have exposed the opposite dura also. Professor Martin Knight showed how to do a bilateral.
Later it becomes very difficult to drill.
The same yes.
So you have to create
Done here. So I'll just fast forward it lack of time. So this is a neuromonitoring which showing here the bulbo cavernous and SCCPs were also taken. Bulbo cavernous is very important because when you're doing a tumor
conus
near the conus and cauda, so best is to have a bulbo cavernous waves also.
If it is a long-standing tumor, then you expect some changes in the bone. Here, the bones are absolutely normal. So that means it is a very fast-growing tumor.
And sir, in open surgery, our exposure is usually one level above and one level below the tumor. So here you expose one lamina above and below, or exactly?
No, only one lamina, one level only.
See, one level complete and one level partial. So that was enough to expose the tumor entirely. Because of the angle of the scope, you can just see peep in. It's very easy.
You can go above and below with the one level laminotomy, hemilaminectomy.
So the open what is it?
So here the dura is open now.
Wait, I'll just yeah. So just before opening the dura, this is a dural exposure now. The dural exposure, as you saw in the MRI, there is a lot of vascularity.
Even the surface of the dura is vascular. You can see the cystic component below from this top. So 9 o'clock is cranial, 3 o'clock is caudal. Even the dura was vascular and it was adherent to the tumor, and there was no demarcation between the tumor and the dura.
Yes. The same thing what he did in the previous case. The knife was used, then we use scissors.
So you cannot make out whether the dura is opened or not because it is merging with the tumor. So what you see deep is the tumor. You see the hook is used to separate the dura and the tumor. You can see the vascularity inside.
And in any tumor, until unless you debulk and 2/3 of the tumor is removed, you can't get a good vascular control. Always, the faster you remove the tumor, any tumor in brain and spine, more tumor you remove, the lesser the bleeding. So his dura was thinned out. So this was someone was asking about the bleeding. You can easily coagulate. So you can see there he's using the, that's all intratumoral vessels. You can see the big intratumoral vessels and the very friable tumor. The moment we were touching the tumor, it was bleeding.
So here we have gone from the left side because the cord is pushed to the right side. So it is much safer to go on the left side. Extremely vascular. You see, minute you remove some tumor, it starts bleeding. And it's friable also. So whatever bite you take, that only you will get. You will not get anything else.
So all the time in between, you just ask your electrophysiologist to see the check for the waves.
In this case, the neuromonitoring person was extremely efficient. He used to warn us before any events.
Yeah. So the Nishant from Chennai, Dr. Nishant from Chennai helped us. Neuromonitoring, excellent neurophysiologist.
You see the bleeding? You can see the bleeding vessel also.
As I said, until unless you debulk the tumor, these bleeders will not stop. So you have to debulk the tumor faster. And he entirely is in the tumor. So this is a big advantage of endoscopy where you just imagine you are working with microscope, how much bleeding it will have. So people who operate with microscope will know the pain of operating such cases. Lot of bleeding, use lot of suction. We use lot of cottonoids, bipolar. So we can selectively coagulate here. And a small announcement before we start lunch, we'll have a group photograph, which is important. So we'll have a quick photograph before lunch when this case is over. So initially, this was bleeding a lot. Then
the intratumoral, he was trying to, lot of vessels were there, so which we anticipated because of the contrast MRI.
ಒಂಚೂರು ಕೂಡ this is a fine common. We have still not reached the normal tissues. At least now you can see the edge of the dura and some normal anatomy is seen.
Moment.
Fast forward. Yeah. Okay.
Looks as if
Correct.
correct.
Correct. So this is the lower end. So once we remove some tumor, then you will start seeing some roots.
He could not deliver it out because it was vascular. One second thing, there was a confusion between intramedullary or extramedullary tumor. So till we were sure of the planes, don't remove it as a one mass. So try to do debulk as much as possible.
This was attached to the corner, so
Yes.
in the end we could find it out. So we are working at the caudal end here. You can see one big piece has come out now. But again, minute you remove some tumor, it starts bleeding. So you require a lot of patience here. You can see the vessels inside. Can you see some roots now, caudally?
You can see the roots there. So slowly now the thecal sac started visible now. You can see the opposite side neural elements.
So this time patient had some changes in the left side because the left side root was pushed to the right side. So they started coming to the field.
So as tumor is debulked, the bleeding started becoming better. So it's much less. Can
So
see
the
that.
lower end of the tumor was cleared. Lateral, central, and superior part is still remaining. You can see the anterior rootlets.
So he's using a 15-degree scope here. So when we change it to a 20-degree scope, so to see the crevices.
And also in this case, we are retracting the cannula for retraction.
Yeah.
We are not using anything else. The dura is retracted with the cannula itself.
So in this case, key components to be shown are the bigger tumor can also be operated. Bigger durotomy can also be sutured, or I will show the endoclips, how useful they are. What Mukesh showed the case, in such cases, especially the dorsal case, if you had endoclips, you would have applied 4 clips, which would have been more
It is
easier.
very fast.
Very fast.
Within a minute, you can finish the dural closure.
So the fear of dural leak also is not there. So definitely it is evolving. I think a lot of future for this. Till now, any doubts, please keep asking so we can simultaneously discuss. Yes.
So I could have not planned preoperative tumor embolization, should have made your job very
Yes, sir. So patient came with acute deterioration, so we have to operate immediately. Yes, definitely yes. That was one good option when it is so highly vascular and hemangiopericytoma thought is there. I just want to just take 1 minute here to answer your question. I just want to go back to show what did he do. One point you should not miss here. I'll just take it backward. Yeah. So I just, you see here what he has done. He's going cranially. He's at the cranial tip. So he's just trying to pull that. You see the yellowish fluid came out. Yellowish fluid that was, and that's a hematoma. You see the old clotted blood there. So that was the one which was giving us fluid level. So you can see the clotted blood and the fluid leaked out. So that was a cyst. You can see yellowish fluid coming out. That was a cystic fluid. So it has entered the cyst also now.
So that gave us the cranial extent, so that we were sure that we don't have to go more proximal.
So now he's just trying to peel it off. So to answer to your question, sir, yes, definitely as a tumor surgeon, angioembolization is always carry a bigger role. So we should explore the options. You see there, that's a big cystic tumor. That's the one which is coming out. You see that That's a big solid part which had come out. One solid part has come out. And again, you see now the bleeding is better now. The bleeding is better. So that's one more the part, the cranial part.
Here it was attached to the conus.
Yes. So one more solid part came out. You should learn. That's why I was telling the endoscopic hemostasis technique should be learned. Only then you can. So here, what we did is Mahesha took a small break, 5 minutes break. So I chipped in. I put a 20-degree scope, the residual scope, so that that crevices was seen better, and I did some hemostasis before Mahesha came. Then Mahesha did the final magic. So see the crevices, the tumor which is below the facet, that subarticular part was better removed. You see now the subarticular part is removed.
And all the bleeders were on the side.
So I just coagulated them. Now you see they're better.
And this is a curved curate which he's going under the dura.
So I'm just going under the dura here. See that?
And mobilizing.
Mobilize that to make Mahesha's job easy. So I just mobilized it, and then Mahesha chipped in. So that's the entire capsule of the tumor. So just coagulated it. That's a tumor edge.
Still you can see the vessels there.
Yeah.
It was highly vascular. You know, it was most vascular.
So the angle scope helped us to do this. Once this was done, you see that that's a tumor I'm separating from the neural structures. I just separated the tumor. See that? That's the entire tumor I'm separating here. Then Mahesha chipped in and removed the entire tumor. So the angle scope definitely helps here as we do cranial surgeries. The cranial surgeries as we do in skull-based surgeries, the same thing. We use even a 70-degree scope in skull base. The same thing, if we can use a more angled scope here, we can remove the crevices. We avoid more laminectomy or laminotomy. So with a small dural opening, we can do this magic. Because Mahesha wanted to dural suturing, we wanted a smaller scope. So that's why again scope was changed. I'm just using my punch as a dissector. Did a hemostasis. That's a bleeder there. So that's the remaining part of the upper tumor. So caudality is entirely is over. Cranial part is remaining. So Mahesha chips in here now. So these angle instruments are very handy. The dural edge can be retracted with the sheath. So that's the opposite tumor, remaining opposite tumor.
Even now you see how much bleeding is there. Minute you poke something, it bleeds.
The big advantage is you are under saline irrigation. So the bleeding is seen and you can stop it. So that's the opposite side of the capsule. Just I'm removing. So that's the opposite side removed. So only thing left is the cranial part. So
That is the capsule.
So now there are only the cranial part is left. So till now the waves are better. You can see that's the final part. Mahisha is pulling out now. That's the final part. So just pull it out. The entire capsule, remaining capsule and tumor caved out. You can see that. So that's a big fish. It came out entirely now. So you can see that. So you can just see how much. You see the more than 4 centimeter tumor.
This piece itself is 4 centimeters.
4 centimeter, yeah. So once this is done, we did hemostasis and tumor almost was out.
So the neuromonitoring was fine, though there were some changes when we removed the last part, but then it settled down. That is the conus which you can see deep with its vessels. Some residual tumor there.
Now you can see the entire thecal sac. So now the main part, as we saw in the previous case. So first what Mahesha did was take a suture here. First is Mahesha took a suture, then I put a endoclips later. So the purpose of showing this case is one is the tumor can be removed, larger durotomy can be done, and uh, when your dural defect is bigger, so instead of suturing, put a one suture to start with, then you can put a clip which is much faster.
Here the dural edges were far apart, so there was no way we could put clips in the beginning itself.
Yes.
So even the suture, we could not take it with a single bite. We had to take it in two separate bites, then approximate the dura and then put a knot here.
So now you see this. This is a endo
This
clip.
is the next magic.
Yeah. So this is a endo clip, titanium clips.
These are pediatric Liga clips called LT100.
So this is very thin profile. Very thin profile. You can see there. It's a very small profile clip. It just goes and sits, and you can just approximate. Very small profile. It is the bite which you take for a suture lesser than this. So that's a handle. That's a handle. Just go in. Just go in. You can see there. The biggest advantage is you can use the scope angle. You see there. So I'll just take the next one. So this clip costs 90 rupees per clip. So it's very cheap, economical, easily available. You can see there, just approximate it. That's it. So just oppose it for few seconds and remove it. So this can be done very small dural leaks. It's very handy, and your dural closure becomes very fast.
And you don't require assistant also.
So
You yourself can do everything.
even you do not put a knot, initially you can just take a suture and just ask your assistant to lift and just put a clips above and below. It took us almost 10
4
minutes.
minutes for 4 minutes only
4 minutes
for this
Yes,
5 centimeter dural opening.
So this is a pediatric clip applicator. It's 30 centimeter length with a 5 mm shaft.
Otherwise, this would have taken minimum 45 minutes to 1 hour with the best of the luck.
Yeah. So now we have put 3 clips above and just put a 3 clips below. And your dural closure, even if you have some CSF leaks when you're doing stenosis surgeries or some other surgeries where you don't intend to do open the dura and you would inadvertently open the dura, you can use these clips, just one clip for the dural opening. I think it's enough.
And these holders are freely available because laparoscopic surgeons use these holders. You can buy it from market very easily.
The adult version is a little bit bigger. So there's a pediatric version is small. It's very small clip profile. You can see there, just going in, just approximate. That's it. It's a beautiful, you can see there. I'll show you the post-op MRI. So it's less than a suture what we take. Opposition, someone might think the dura might get shortened. No, in endoscopy it looks bigger, but
because the length of the clips when it is approximated, it is 4 millimeters.
Yes.
So you may take about 2 millimeter in the dura.
Yeah.
So that's all is the
So
compromise.
this is the last clip I am applying. You can just see there, just go there and just oppose it for a few seconds and come out. I
We
just
have put
applied.
one more up
Yeah, I
above.
think one more we have put.
Because this was a fairly big dural opening. I think almost 5 centimeter we had opened.
So now you see that we have put 6 clips easily and we cut the suture and so there was one, this one left and we put last one also. I was not convinced, I convinced Mahesha to put one more clip. So this beauty here, so you can just see there, the whole entire clips has been applied. So bigger durotomy also can be tackled today. The simple techniques. It's cheap also. It's easily available, cheaper, and it's titanium clip. So no need to worry about post-op MRI also. So you can just see that we are applying one more. Just touch it little bit and press and oppose. So that's it. So dural closure is done in few minutes and you can just come out and keep a dural patch. I use a Integra dural patch, Duragen Plus. Then you come out. So we just switched off the saline. It's fine. Keep the Duragen Plus and come out. Any doubts can ask. Next speaker, Karunakaran, has a flight to catch. Just have a
Karunakaran is here. Probably has left. So that's the endo clip I'm showing there. So you can rotate it all the degrees. So Naresh, you can ask everyone to just assemble at the podium so that we can have a photograph before lunch. So you see there, it's a small incision. Any doubts, please?
This is the post-op MRI. You can see the clips also there. As the CT scan, you can see the clips again.
That's a tumor. And we were anticipating probably it is something else, but it came as schwannoma, the post-op, and you see the durotomy, sorry, the laminotomy here. So one level bilateral hemilaminotomy, and here partial laminotomy. So this is what we have done and did, and you see the entire tumor, and you can see the clips here very nicely opposed. The entire tumor is gone. Oh, any doubts? So before we break, we'll have a quick lunch because this is a patient walking. He came with paraparesis. This is next day. This is next day. He's very happy patient. Thank you. Yeah, Karunakaran is here. Quickly. Yeah, we can keep talking about the questions. We can take the questions at before Professor Karunakaran.
Karunakaran won't mind missing his next flight also.
Yeah, so he has come all the way from Chennai to join us, and he missed his flight, but he took the pains to come here by road. He also traveled by road. 12 hours he traveled by road. And he's ready.
I think everyone who has come has his own
So
story to tell.
I thank and myself and Mahesha and Naresh, we thank everyone for being here, taking the pains to attend a Spinoscope and make it a successful event. I thank everyone. And please wait for the photograph. So we'll take it in 10 minutes. So we'll have a group photograph.
So any questions?
Ready? Yeah. So Professor Karunakaran will be giving a lecture on how to do a standard classical disc surgery. So he was supposed to give a lecture on yesterday, day one. But thank you, Professor. And,
Yeah. At the outset, I must thank each one of you who are here in this auditorium. And special thanks to Dr. Sukumar and Mahesha and his entire team for this wonderful effort in spite of so much of crisis. It's like doing something in the midst of some heavy storm. It's that sort of an impact. But my situation is, we have flown very high. Like we are now talking about intradural tumors and OPA, ossified yellow ligament, fusion, everything is being spoken. Now I have to touch base. I think it's more of a desert session now for you. Basically, whatever said and done, you have to stick to the basics. Or it's all this from which everything starts. This is a 37-year-old gentleman with severe pain, who is incapacitating pain, not able to do his daily routine. It's a day in, day out scenario. And he had presented with all conservative modalities were tried, but his pain seems to have persisted, affecting his daily routine. His business is shut down, and his neurology was EHL 2/5, but the rest of the power was normal. The ankle jerk normal. So we diagnosed as L4, L5 disc prolapse with sciatica. The first question was whether the interlaminar space is adequate. So this sort of yes, no situation. What we need to be prepared is we must have a burring tool. Without the burring tool, if we are held up in between, we may not be able to proceed. So we need to have a burring tool, which is handy. And the MRI showed a significant large extruded disc fragment central towards the left paracentral, which is matching to its clinical findings. So it's more towards the midline. And we proceeded with the CT scan to know whether there is any calcified portion, which is my routine to find out whether there is any calcified portion so that I'll be prepared whether I should use any bone milling tool or a burr. And we started with identifying the widest interlaminar space, and we put the dilator the conventional way between the interlaminar space, knowing that it's quite adequate for this sort of a situation. So we didn't have the need to use the burr here. And the lateral, we confirmed that it is in level with that L4 L5 segment. And what we did was once we remove the muscle, the most important thing in this surgery is controlling of bleeding. And the next step is you have to see the tip of the instrument always. And as it is always told that the tip is so finely designed, which has got a small chisel-like finish, right? You can slightly hook the tissues, and then once you hook the tissues, we have to slightly lift it off every time so that any underlying structure you don't grab inadvertently. So every time you have to step by step cut the ligamentum flavum, thin out the ligamentum flavum, try to tease out the ligamentum flavum by that sort of a gentle rocking movement. When you start slowly holding the fragments, I also try to rotate the scope and see whether we are catching underneath so that we were doubly sure that we don't catch anything. And from medial to lateral, keep walking. And as I earlier, what I did was I went to identify the lateral facet joint and then again came back from the midline. So I know how much of ligamentum flavum, what minimal limit of ligamentum flavum is required so that I don't take off too much of medial ligamentum flavum, just the optimum required ligamentum flavum. See whatever is bleeding there, control the bleeding, don't rush towards getting to the target. Step by step, use the RF to cut the tissues, coagulate the tissues. Now, this sort of a jerky movement you can avoid. What you need to understand is you have to catch little, and the curved type of the annular cutter is very useful. I try to go to the tip or the facet joint so that I can go to the shoulder, identify the shoulder portion, well define the shoulder portion so that instead of using a dissector, I prefer to use an RF probe because the RF probe is more flexible, so you don't have to use too much of force. There's some amount of residual ligamentum flavum is still cut off from the tip so that I can exactly what my aim is to go from the shoulder to the pedicule. I can make sure that the entire structure is decompressed. So now here I use an RF. The reason of using an RF here is, as I said, it is more the dexterity. You can know what type of rigidity we are able to feel, and you can also try it when you are trying to mobilize. When the bleeder comes, we can coagulate so that you have go much better field. And I keep running my. Sometimes I find it difficult whether this is the neural structure or sometimes fat. So I take some time. Sometimes I try to give small currents to see if there is any twitch. Identify the lateral border. Now the disc fragment is well defined. And once this fragment is defined, I try to see whether I'm able to go to the inferior part of the bone so that the inferior part of the bone has got no fragment there. Feel for it and slowly try to tease out the structure with still the RF. Once I have defined it, I control to the retraction with half of the sleeve which is just holding the neural structures, and now with the disc punch, also I keep the opening of the jaw towards my side, towards the lateral side, and slightly gently rotate so that I don't have to use my sleeve to rotate it. I try to tease it out. I can see that from the annular end, the disc fragment is coming out there. Slowly tease out the disc fragment, and if it comes in a large chunk, it's fine. If it doesn't come, do not waste time to trying to pull it out as a large chunk. As it comes, make sure you are able to see in some part of the frame the neural structure so that you don't have any additions which are sticking there. So make it very very clear. And if in case it's not coming, don't use your scope rigid there. We can move the scope with a disc fragment when it is not coming. Sometimes it is so big that you might need to have the sleeve also removed. But here in this case, we just have some of the fragments removed in piecemeal. And as I keep removing the disc, the neural structure is still in a vision, which I usually don't prefer to keep my neural structures retracted because I have that fear that I'm going to retract it for a longer duration, but that's been my habit. But though I see many of my teachers and my colleagues totally retracting it. And based on the size of the fragment also, if it is a very small, it's okay to retract. But there's a large fragment already occupying so much of space, I don't want to further compromise by retracting it. So I generally have the neural structures under vision and keep the jaw open towards myself so that I can use the disc punch as the retractor. So this large fragment is now coming out. So it didn't come out with the sleeve there. I loosened up the sleeve a little bit and I moved with the scope, and I could see that the large fragment is coming out now. And once I remove the large fragment, I anticipate lots of bleeding. Once I go back in, there's going to be bleeding. So a little bit of saline pressure I increase and keep the field clear. And once it is clear, I can see the annular rent. And once we see the annular rent, I try to explore whether there is any posterior third fragment there in the disc. I now try to clear it. I can see that there is some small fragment there in the posterior part of the annulus. I will just take some time to, the margins sometimes bleed, so I try to use the RF probe to control the bleeding. Identify the disc fragment, pull out the disc fragment. My habit is to explore the posterior third of the disc fragment, and also take a CM image when I do the posterior part of the disc fragment, so as a documentation to put it in the file that I have gone into the disc space to at that correct level, and also try to prepare the annulus, whatever the thin fragments which is floating, I just control and remove it. And also see now it's the annular rent is at the cephalad end, and I can see that there is some more fragment coming out which I didn't expect from the MRI images. So what my habit is to go above the disc, below the disc, and also into the axilla, and also check on the lateral aspect before I come out if there is no fragment, which is residual fragments are left behind. So that the take home I would recommend is make sure that when you use a scope, go above the disc level, that is above the facet tip level, and also to the below the disc level up to the pedicle. And if there is a good fat tissue, I don't want to remove the fat tissue. I try to probe into the axilla, so look at the feel for the floor, and if everything is okay, then I would conclude the procedure is done. And this is the end of the procedure. And you can see that there is the 8 mm cannula showing a small rent, and it's now the procedure is done. That's the end of the procedure. Approximate volume is around 1.5 cc. That large fragment which I have to remove the cannula, that was the one. And that's the annular rent and the axillary images, final picture. And important is every step control the bleeding. See the tip of the instrument always. Look for a distant look. Do not put the scope directly on the tissue. Keep it at a distance. See what you want to catch. Move. Your left hand has to keep moving. So that is the one which moves towards the target. Move it towards the target. Focus it in the center. Then grab the tissue. That makes the job simpler. So what is the structure which is offending or restricting the movement? Like sometimes you try to keep on moving, you will not be able to move your scope. You have to understand what is that which structure which is controlling or restricting the movement. Try to remove the cannula and see if you're able to go, if you're able to go towards the target. If that's also not happening, try to move the scope and get into the target. Understand the instrument design so that, see, if you could understand how these instruments work, let us say the RF probe which is so ergonomically designed, if you can rotate it, how much of flexion, what is the thickness, how much is jaw opening, all these things, when you try to have an understanding, then you can, for example, you want to know how much is the annular rent, you just put the disc punch inside, it will be around 5 mm sort of rent. You can understand if it's going to have recurrence, how bad is the tear, all these things will be pretty useful if you try to understand the instruments and the design. So if you have an eccentrically placed scope, what is the idea of the eccentrically placed viewing endoscope? So you have to make sure you get closer to the target. It will be like a 0-degree scope, and you stay away. It really effectively functions as a 25-degree scope. So all these things, when you ask if the cannula, where is it positioned? If you have the total orientation, your job becomes more simple. Instead of just mechanically keep working on it, try to see what is possible through the scope, through the window, what is you're able to see. Once you do that, your job becomes more simple. Don't keep your left hand quiet. That left hand has to be even more dynamic, because that's where the hand which takes you to the target. That's the pre-op and post-op images, pre-op, post-op MRI, and that's the end of the next day wound dressing. The wound is clean and dry. And that's the pre-op suffering and post-op back in action the next day. Thank you very much for the patient listening.
Thank you, Dr. Karunakaran. I have one question for you.
Yeah.
Many of our patients have end plate osteophytes. What do you do?
Sorry?
End plate osteophytes.
Yeah, it's not. I will always go behind that end plate osteophytes because if it's an acute symptom for which I have operated, that residual osteophytes I don't remove. But if I feel that this osteophyte is also a significant part, like if the CT shows it is in flow with that sort of the disc, I try to mill it off.
Okay. Okay. So same questions to Professor Martin. Two questions. One, what is your philosophy of discectomy? Are you aggressive person to remove the disc which has extruded and peep into the disc space and remove more disc? I saw your video, you trimming the edges of the disc hump. So you do it always, or as Mahesh asked, when there is a osteophyte also you trim it. So what is your philosophy on that?
Well, we always say whenever we can enter the disc space with our smallest instrument, which is 2.5 millimeters, we try to enter the disc space and remove as much loose material as possible. Of course, sometimes you have those pharma-graded fragments to cranial caudal where you have the ligament just lying like a curtain over the defect. So in those cases, we just remove the fragment. But especially when you have a combination in degenerative cases, not that fractionation, but long-term complaints, and you have additional osteophytes there, we try to do it to do a complete resection of the interior part. That means also that you create a bigger defect in the disc or in the annulus, and therefore you need to take your time to clean the individual space very sufficiently. We do it not only mechanically, we do it also with the radio frequency with high energy.
Okay, so you think making a little bit bigger, trimming the osteophyte increases a bit of chance of recurrence there?
Well, I'm not really sure. The problem is, of course, most of the recurrences, at least those who are not occurring during weeks after the first operation, which is not that big problem because you can just take them out again. Problem is the recurrence that comes after a year or two because you have all the scar tissue whenever you have some of that, but some patients have scar tissue. But you know, the main problem of recurrences, late recurrences, is the ongoing degenerative process of the end plates, and you cannot avoid that. You can do a fusion, of course, but that's not the solution for the patient with leg pain. So you cannot avoid the ongoing degeneration, and therefore we just try to keep the disc space as clean as possible. We are not doing a curettage. We are not removing the end plates. But on the other hand, we don't have until now a good solution for an annular closure because everything is not really working. So that's a fact you always have to tell the patient because the patient is, of course, thinking, I'm going to I'm having an operation and afterwards my problem is over. You just took away the symptom, but the main degenerative disease is still there.
So that is very, very important point. We always should tell the patient that you have been relieved of pain now. So you are not treated the degeneration. So degeneration is going to happen. So such patients you always tell of the recurrence or fusion later date. So otherwise they think that the moment you do surgery, it is end of the procedure and like appendicectomy is done, there is no more appendix problems. It's not like that. So you have done just a part of it. You only removed the tip of the appendix. So you will have problems in future. So we need to warn the patient. They will have some wrong philosophy that the moment you have done surgery, it is end of disc problems. No. So it's a continuous issue. So we'll just quickly have a group photograph and then we'll break for lunch. And I
Dr.
request
Sukumath,
everyone to come back.
one quick question.
Yes.
If there is recurrence.
Okay. To me or to professor?
The professor comp
Yes.
also. If there's a recurrence, how would be your decision protocol? Would you go for a fusion or you will go for an endoscopic procedure?
No, that depends on the symptoms of the patient. Normally, when the patient has a recurrence and he was pain-free before, and he normally get leg pain again. And leg pain is for me an indication for decompression. That means endoscopic revision.
Another recurrence,
Yeah.
leg pain. Third recurrence, leg pain.
Yeah.
Next.
Yeah, it's the same. Sometimes we have patients that are operated 5 times until this problem is over.
Oh.
But even there, you know, a fusion is of course maybe a solution for the problem of recurrence, but it is not a solution for the pain of the patient, because we know, especially in degenerative cases, not talking about spondylolysis or something like that, because I think that's a good indication for a fusion to solve the mechanical problem. But in cases of degeneration and pain, more and more we are out of the thinking that fusion is really a good solution for the patient. So we are doing much more decompressions nowadays than in former times, and we are doing less fusions nowadays. And I think this is a tendency that is, at least in parts of the world, already growing. Of course, you know, there are a lot of political things to think about, because putting implants, rods and screws in patients is not only a question of treatment, it is also a question of investment. And when I only do decompression, there's no big business or big investment. So it's not so easy.
Yes, thanks. Wonderful answer. I love that answer. So the reason is it's people keep asking. There's lots of education required from the patient side as well, because recurrence next episode is fusion, and
Well, that is
endoscopy is there.
part
I
of
got radiating pain.
part of the problem is all the youngsters are taught that any recurrence has to be fused. They
Correct.
don't know how to decompress it again.
Yeah. So thanks for that message. Thank you very much. Can I take some time before that for setting up one more question for Mr. Dirk? For RF probe, whenever we use on the fat tissues when during the process, it doesn't take away any, it doesn't have any impact on the fat tissue. I put the setting around 30, 40, it doesn't have any impact actually on the fat tissues. I actually physically have to take the fat tissues and the epidural fat tissues by using a disc punch. That is what it is meant for. Like, it doesn't do anything on the fat tissues.
Yeah, usually you should have effects on the fat tissue, because fat tissue has a lot of water content. And if you use a biportal technique, then you should have an ablation effect as well. Probably you have to increase a little bit the power, towards 40, 50 or something like that.
Okay. Is somebody have a similar experience, or only I'm having this experience?
Compared to the other tissues, fat has, because of the oil content, so definitely the coagulation is mode doesn't work properly. You should use ablative mode.
Okay.
And power should be more. But why you want to? You can physically remove it.
Yeah,
and
that's what
whichever
I try to do is, when I put the instrument, instead of removing the instrument, try to manage with that first instrument. So that's
better
why.
is to remove it physically.
Okay.
Thank you, Professor. Thank you very much for the time. So we'll just quickly, please, all the faculty assemble here, and two rows we can stand behind, one row below and one row up on the top. So, in the center.
I think it's finished. There's no center.
Come, Mahesh. Suresh. राकेश बैठो बैठो मैं चिपकाई तभी चिपक जाऊंगा एवरीवन प्लीज अरे यार क्या बन रहे हो चलो यार तुम लोग लंच नहीं खाना है क्या you know everyone say group photo for everyone so can two rows make two rows the bigger below and feel very happy that everyone has chipped into different difficult times so thank you very much for all the pains you have taken.
That you've been following. Actually, we should thank you that you've been following continuously. Where are you? What are you doing? Where are you? Whole night you are doing it. I mean, that's something commendable.
ఎవరైనా ఉంటే బయట కాదురా ఫోటోకి ఎవరైనా ఉంటే రమ్మని లోపలికి నా దాంట్లోకి ఫోటో తీయాలి నాకు రావద్దు నా ఫోన్ లో తీయండి రా
పెట్టి అది పెట్టి మ్యూజిక్ ఆఫీస్ అది ఇది పెట్టి ఇది పెద్ద స్క్రీన్
దీంట్లో ఉందా?
అక్కడ స్క్రీన్ మీద ఇచ్చేసారు సార్ అది మహేష్ సార్ స్క్రీన్ మీద ఇచ్చేసారు నెక్స్ట్
కనపడదు
సార్
కనపడదు అట్లా.
ల్యాప్టాప్ ఇస్తాను పెన్ డ్రైవ్ ఈ ల్యాప్టాప్ తీసుకెళ్ళి ఇచ్చేది
5 నిమిషాలు కదరా.
సార్ ఒక్క నిమిషం దీనిలో వచ్చింది
తగిలేదు.
అది ఎక్స్టెండెడ్ వీడియో ఎక్స్టెండెడ్ చాలా అదే ఓకే ఓకే వచ్చింది సార్ వీడియో
వాళ్ళకి ఏది కావాలో నువ్వు తీసుకో అంతే. జస్ట్ welcome back. Just 5 minutes, we'll just go through the role of teriparatide in the management of osteoporosis. So just, I know this is not a related topic, but I thought we just present this. Everyone know what is teriparatide? It's a PTH analog. So it's a biologic where we use for osteoporosis patients, either pre-op, post-op patients, where increase the anabolic activity of parathormone. So it's been there for a very long time, teriparatide. So it's almost now a lot of literature is available on teriparatide. So we commonly use two drugs, teriparatide and denosumab, for our osteoporotic patients. So how many years you need to use it? What is the long-term effect? So just to go through this data, where at least for 24 months treatment is required to have a good effect on the osteoporosis correction. And these are the results. So you can just see the patients who were reduce the risk of fractures. So it's almost 12 to 18-month follow-up. They showed that 47% decrease in the the fracture risk patients. And again, the clinical vertebral fractures, where you just compared with the normal individuals, definitely there was significant
reduction in the vertebral fracture risk. And again, non-vertebral fractures like hip and radius, again, it was very good. The back pain, again, the teriparatide had shown because of this anabolic activity, the back pain also was better in these chronic osteoporotic patients. Definitely, it increases the quality of life. Uh, I kept it short because the dose and all we know, we use 20 microgram subcutaneous per day for minimum of 9 to 12 months and continue till 24 months after serial BMDs. And most of the clinicians I see, they practice doing 6 months of teriparatide and giving denosumab a shot, and then again uh, increasing it to 6 months again. Do a BMD. If BMD is not corrected, then you continue teriparatide. So definitely the teriparatide shows that the vertebral fracture rates is definitely less, and when you stop it, the 18 months later, you stop it, definitely the reduction of fracture risk. This just to show the clinical studies here in non-vertebral fractures here. So these are some clinical studies. So teriparatide 20 microgram and placebo. So definitely the remodeling was better. The fracture healing was better. This is all non-vertebral fractures. So definitely it made a significant difference. And again, you can do a combination therapy, as I said before. With some exercises, definitely it improves better. So you see the control and group and the teriparatide group. So in females, definitely the radius fractures and the healing was much better than non-teriparatide group. So definitely the anabolic effects of teriparatide is proven thing. Fracture risk is less, especially the susceptible fractures. So compared to short-term treatment, definitely long-term treatment is always better. So again, adverse effect, this one thing I need to see, you might have noticed some patients who with the teriparatide injection, they complain of itching. The moment you say, they say, I have burning paresthesias and itching, some patients have noticed that we attribute it to something else. When you take the history of their drugs, what they are taking, so the moment the patient itself themselves say that once you stop teriparatide, they become better. So you need to understand about these side effects also. And again, comparative study with denosumab and teriparatide. So it was found that teriparatide has little bit better and less complication compared to denosumab, which is little bit more having complex complications. So definitely teriparatide, say of all the drugs we have today, it's a best anabolic drug, less complications, and definitely we can have a sandwich therapy where you can use denosumab and teriparatide and other osteoporotic management. Thank you. So we'll start with Professor Martin Komp's talk. Here, the idea is yesterday talk was supposed to be in the morning, but because of the surgeries and Professor talk, we can do it. So he will be talking on thoracic pathologies, monoportal endoscopic management of thoracic pathologies. Over to you, Professor.
Perfect. Okay. So talking about the thoracic spine means what kind of indication do we have for an endoscopic procedure? First of all kind of narrow situation, either caused by spinal stenosis. In Europe, we mainly have thoracic spondylosis. In Asia, mainly OFL and OPLL. But also we know when we're talking about disc herniations that we have those giant thoracic disc herniations, mostly calcified and yeah, problematic to operate. We know from open surgery that we have various surgical approaches, and the choice of approach, anterior or non-anterior, is always based on the anatomical location and consistency of the pathology. The most important thing is to avoid the manipulation of the myelin. Also in thoracic spine, there is a tendency towards more minimal invasive technique in the last decades. And we have three different approaches to the thoracic spine: interlaminar, extraframinal, and transthoracic. But first of all, when we have a pathology at the thoracic spine, we have to define our working area. Where's the pathology located? What kind of consistency do we have? What do we expect? And then we have to define the approach, and the most important goal is to avoid the manipulation of the myelin. So let's first have a closer look to the interlaminar approach. Interlaminar means it's nearly the same what we are using at the lumbar spine and at the cervical spine, due to the situation that we can resect bone. We can have an individual range from posterior to a little bit more posterolateral. This is an example. High thoracic, always have that in your mind when you have patients with problems in their little hand muscles and fingers. Look at this area, C7, TH1 and TH1, TH2, because normally you don't have transversal slides coming from a radiologist. And the technical steps are very near to that, what we know from lumbar spine and cervical spine. That means opening the flavum ligament as medial as possible, going to the lateral aspect until we find here the medial margin of the ascending facet. Then resection of the fat tissue and identification of the neurostructures. So here's the lateral margin here of the dura, then taking out the herniated material. So this is nothing complex. It is just transferring the situation of the lumbar and cervical spine to the thoracic spine. But of course, you have to resect bone sufficiently, so you have to be used to that. Interlaminar for contralateral over the top decompression is always possible, of course. Here, for example, in a case of an OFL, sometimes it can be a challenge to find the entry point. We always search as medial as possible, because mostly in those cases you find your approach somewhere here. That's the same what we are doing right now. So we're starting from the left side, ipsilateral approach. Everywhere we find bone, and then just in the midline we find soft tissue, and that's the way to enter the spinal canal. See here the soft tissue, and here that's also already the opposite side. And here we start with bone resection, then to cranial, caudal, and lateral. And then we open the spinal canal, start with our ipsilateral decompression. So again, here the technical steps are not that new. That was our ipsilateral decompressed side. You see the calcified flavum ligament here, very localized in this patient. And then you take away the soft tissue around the calcified material. That's the calcified flavum ligament here. You see the process from the dorsal aspect. That's the situation of the resection over the top. But of course, you have other pathologies like cysts that can compress the thoracic myelin. Extraframal approach, also here we have an individual range. We are coming, starting from the neuroforamen. Due to the ribs here, we are limited to the lateral aspect, but we can switch by resection of bone here from the facet, the whole system, to the medial aspect. What we also can do with this technique is this box-shaped osteotomy, especially when we have intraspinal pathology and we have hard adhesions between the pathology and the ventral surface of the dura. You often need a first indirect decompression, and then everything comes down, and then everything becomes more visible, and you can release the adhesions at the anterior surface of the dura. Extraframal thoracic, we are just starting with a small lateral placed pathology. So we're operating the left side. That means left side is cranial, right side is caudal. That was the thoracic nerve on the left side. Then we're starting from lateral to medial by resecting bone. Then we resect the medial margin of the bone here of the ascending facet. So we see epidural fat here. We see the disc space and the pathology. The dura is just in front of us, taking out the material, and as you know, in most of the cases, you find additional calcification. So this is quite easy, accessible without much resection of bone. Yeah, you don't have to take care for the thoracic myelin because the pathology is lying quite far lateral. See the nerve here, the dura here, and the nerve is on the left side here. Another example, a little bit more medial. Again, the same situation, operating on the left side. That means we are starting here at the nerve, resecting from lateral to medial the bone until we enter the spinal canal. See the lateral margin here of the dura. See the herniated material. See those little adhesions here. And then we start to resect that. Here's a little piece which comes out, but even that is not really fresh. And again, the situation here, you see the disc space, you see the decompressed dural sac here, you see the released adhesions at the ventral surface of the dural sac. Going more to the medial aspects, just to show you with the extraframal approach, you can nearly reach every pathology. On the right side, that means right thoracic nerve. Again, the same situation, starting from lateral to medial. And as more medial the herniation is, as more you have to combine the access work from lateral. That means also decompression from lateral. To gain more mobility, you need this box-shaped osteotomy to get more access to the anterior surface and especially to the opposite side. And therefore, this deflectable burr is very helpful because you can work to the opposite side without touching first the anterior surface of the dura, and then afterwards, when you release pressure far enough to the cranial and caudal aspect, of course, then everything comes down, and then you can start to resect and release the structures. And also here, the sign for a decompression is always the free-floating structures. So when you are not seeing free-floating structures, you have to look for more material. Giant disc herniation are also accessible with this approach. You see it here in the preoperative CT scan. So after doing our bone work, we see the herniation, which is lying directly in front of us. You see here the herniated material pressing the neurostructure to the dorsal aspect. So again, same situation, starting with indirect decompression, and then we are facing the structures. So now we are going in with a deflectable burr, resecting the last anterior compression bony structures to the medial aspect, and that's the situation after we resected everything. So again, box shape osteotomy and anterior decompression. So transthoracic approach means we are coming from the lateral aspect, preferentially a retropleural approach. You can do this transpleurally, but I cannot advise that because then your irrigation is lost in the pleural cavity. Whenever you do that, do a warming of the irrigation. We learned that very fast because otherwise you may have cardiac problems or cardiac arrest due to cold irrigation. Preparation and technique is very near to that what we know from open surgery. That means, first of all, we have to identify the head of the rib, resect the head of the rib, resect the pedicle and parts of the posterior vertebral bodies like a box-shaped osteotomy, and then you do the decompression. Example for that, first of all, we see at 1 o'clock, we see the rib. We're doing a blunt dissection of the structures, a retropleural approach, and until we are in the position where we find the head of the rib. Next anatomical structure is the disc space, and that's the head of the rib here, segmental vessel, and then the disc space, and then we start to work. Let's see this space here. Then we start with bone resection. The first things what you do resect first is the head of the rib. So just in this area, you resect the head of the rib, and then the next structure which appears, you see here the rest of the rib is the pedicle. So the pedicle is resected. It's the caudal pedicle of the affected level. You resect the pedicle layer by layer until the last tissue layer is left. So that's the last tissue layer here, and this is resected with a punch, and then you have an open gate to the spinal canal. So again, step by step, resection here. You see already the structures appearing in the spinal canal. And then when you resected the bony structures, you have quite a lot of space here to work with a burr to do first an indirect decompression and then further on the direct decompression with flexible burrs or with straight burrs, depending on your situation, and that's the situation when we did the decompression. So what are the indications for endoscopic procedure for all posterior pathologies like OFL, Z-joint SUS, or posterior sequestered soft disconation? We can use the interlaminar approach. For all intraforaminal pathologies, soft or calcified, or anterior pathologies, medial lateral to medial, we can use the extraforaminal approach, and it is the most frequent approach for us using to be used at the thoracic spine. And as more anterior pathology, as more calcified, as more medial, you have to consider if you have to use a transthoracic approach. So we have a range of approaches, and again, the most important thing is to avoid the manipulation of the myelin. So for these thoracic disconations and pathologies, an individual planning and choice of the surgical technique is mandatory, and there are really no standards. Every case has to be considered very well. The key determinants for approach selection is the anatomic localization, the consistency of the pathology, of course, general health of a patient, and the experience of the surgeon. We have to avoid manipulation of the myelin, and each technique has its own outlined risks. But we can achieve with this full endoscopic operation sufficient decompression. Tactical advantages, of course, due to the irrigation and visualization. We have a reduced traumatization. and it is combinable with fusion if you want to do that. But when you see we are doing about 2,500 endoscopic cases a year, lumbar and cervical, but only about 15 thoracic cases a year. That means even we have limited experiences in this field because the pathology is so rare. But at the end, I always have to emphasize that we need the conventional techniques to deal with all pathologies there. And yeah, it is good to have a range of tailored techniques to face all pathologies that may occur in our patients. Thank you very much.
Excellent, Professor. So I've been doing thoracic spine for past 4 years now. Definitely, it's more challenging compared to cervical and lumbar. The anatomy and the structures, most of the time, they are hard. So definitely, a beginner need to understand the 3D anatomy before venturing into thoracic spine. And today, I do almost most of the thoracic pathologies either to foraminal or posterior approaches. So it's mostly the thought block that we cannot do it. But definitely, this shows a broader perspective that most of the 90% of the thoracic pathologies can be done endoscopically. Thank you very much for your talk. So Mahesh's flight is he has to catch up the flight. So we'll start OLIF OLLIF. How does Mahesha does it? So just we'll అది కనెక్ట్ చేస్తావా? I think it will not call. ಇಲ್ಲಿಗೆ ಬಂದ್ಬಿಡಲ್ಲ. Yeah, surgery. It is better, no? The voice లేదు. 2025. Today we are demonstrating a case of degenerative listhesis and scoliotic changes in a patient, elderly lady of age 65 years. So this lady had come with severe low backache with claudication symptoms. In X-ray, you can see the X-ray. You can see there is a degen scoli here, and on lateral image there is a listhesis at 4, 5, and 3, 4. When you see the flexion image, definitely there is a instability at 4, 5, and 3, 4, and there is some mobility at 3, 4. So when you come to MRI, you see the MRI here. There is a multi-level degen disc disease, but this is more at 3, 4, and 4, 5. There is a listhesis and disc disease, degen disease. But when you come to axial image, the planning becomes more evident. So here you can see 3, 4 from the left side. There is a lot of stenosis, facet subluxation, more on the left side. So the stenosis is bilateral. It's almost canal is closed here. You can see here the 4 cuts of L3-4. You can see a severe stenosis. If you come down 4, 5 also, there is stenosis. 5S1 is okay and 2, 3 is okay. So the plan today would be we can have many plans. The plan would be doing a fusion at 3, 4, 4, 5 with adequate decompression. That's the key. So we can have a option 1, the endoscopic options are today one option where you can do entirely transcambian approach, go transcambian, put a cage, decompress the foramen and lateral recess from one side. That is one option. So entire fusion and decompression is done through transcambian approach. But
difficult with transcript means opposite side decompression, direct decompression cannot be done. Though there are so many debate and discussions that indirect decompression also can help, and restoring the listhesis can help opening up the spaces. But if you want to do direct decompression transforaminally, opposite side is difficult. Second approach is completely posterior approach, where we go from posterior, do what we do regularly, the en bloc resection of facet, decompression of the canal, bilateral, recess, foramen, and put a cage from the posterior approach. So this is entire posterior fusion, where you go from posterior. Third option is a hybrid approach, where you don't want to avoid too much damage the facet, but still have a good decompression and fusion. Put a cage transforaminally, which is very faster, then do a decompression from posterior. So the bone work, the bleeding is less, as a result of which you are still preserving some facet, and you can do all the decompression you want easily. So today, in this case, we are demonstrating uh, decompression and putting a cage transforaminally. So
Mahesha is showing OLLIF. So for this case, already screws have been placed. So Mahesha will demonstrate how to put a.
So we have put the needle, 18 gauge needle, into the center of the disc space in AP and lateral views, and the needle has to hit the SAP and then go inside. So this step is very, very, very important to avoid exiting route. And other thing is it has to be towards the lower end plate. Shoot. So now we have replaced the needle with the guide wire. Then we put the dilator. This is a 7.
So this is important. You see the needle now is in the anterior 1/3, the guide wire. In AP, it should be somewhere in the midline.
Millimeter dilator, which goes in. So I hit the facet, then I dip in. I am on the annulus. Shoot. Okay. So by the feel, I can tell where it is. Now we take out the wire and go inside. I'm just lowering the angle so that it is little more horizontal. Shoot. Okay. Now we go inside. Shoot. So go all the way in. Shoot. Okay, AP. We just take one AP just to be sure that we are not crossed the other side. Okay. So that is absolutely fine.
You see now the image we want to show is in AP it is just cross midline, and in lateral it's anterior third.
Have some space in, we have touched the medial pedicle line on the opposite side, and in the lateral view we are in the anterior part of the, so we are just entering the disc. Okay, rotate the cannula so that the bevel faces up. Shoot. So this is a solid curette which we are going to use now. This is curved, so go inside. So I'm on the disc. I can feel the end plate. Shoot. This is the upper end plate. Shoot. So I fix it here. This is my protection sleeve, so I will not cross more than that. This is upper end plate. You turn 180 degree or on the lower end plate. Shoot. Okay. So then rotate 360 degrees so that whatever disc is there, it comes out. Turn the bevel. You can use the bevel to your advantage. Okay. This disc is coming out. Give me the other curate. So the important thing is, you may think we are getting too much of radiation because it is done blind. But actually we are not getting so much radiation because the generator is away from us. It is not on the surgeon. It is away from me. And if you see, anytime when I take a CM picture, I am nowhere near the field. I am at least 1 meter away from the field. So this way I avoid radiation. So this is the ring curate which we are going to use now. And also all these instruments have protections markers, so that once you take one picture and fix the marker, then after that you don't have to take CM, because your protection will prevent you from going laterally or anteriorly. Yeah.
hope this was inside. Okay, shoot sticker here. So if you don't have the so you can use a tape, sticking tape, so that clean this,
This is
so that you
articulating
can
articulating
don't have to
keloid.
take too much C-arm.
Yes, this is the most
So just
important
prepare and
instrument
clean.
which will do bulk of your
See
discectomy.
see the
You see,
amount of disc it is
it
getting out.
scrapes the
So
disc
you
and
see that I am
catches
not
it and
taking
gets
any
it out.
C-arm shot, and I have the guide how much I am inside. Yeah, give the suction, suction, and put a guide wire here and pack bone
So
graft.
you can
Okay.
finish the discectomy in 5 to 10 minutes. That's all it takes.
So we are
Eight-
going to put a ಗ್ರಾಫ್ ಪಂಚ್ ಇದೆ ಉಳ್ದದ ಹಾಕಿಬಿಡಿ ಸೊಲ್ಯೂಷನ್ ಇದೆಯಾ ಮಿಕ್ಸ್ ವಿತ್ ಬೋನ್ ಮ್ಯಾರೋ
So this is
split into two
allograft
5
which we
cc
are using. So we don't take any graft from the patient. We use allograft from bone bank, which is quite economical, freely available, because there are many medical colleges in India where they have bone banks. So these are basically the bone grafts which we harvest during orthopedic procedures, sterilized and dried, and it can be kept in room temperature for 3 to 5 years without any issues.
for upper
So
and
we
lower
take
level.
marrow
we
from
pack
the
here
patient
now.
and mix it and pack it inside.
Okay. Give
So
the graft
till
punch.
now he has not put the scope, so is entirely
Okay.
non-endoscopic.
So punch, hammer, get it here. We have packed some more. Mallet. Shoot. So this is a normal guide wire which we use for screws. Take out the
So
so
once
this is
you
a 11 into 30 millimeter cage. We have to loosen the nut so that there is some space.
You can see this cage, which is like a bullet cage.
Something so that the nut loose will get. Okay, this.
So there are two cages. One is a solid cage and other is a expandable cage.
So this is a 11 into 30 millimeter cage. We have to loosen the nut.
You can see that that's a bullet-shaped static cage. He has devised one more bullet-shaped expandable cage, which we'll show you in the video. You can bring that.
Jayan has
Yeah,
these expandable
we'll
cages.
show it in the video next case. When you're using, we'll show that, Maisha. Yeah. So
So that there is some space for the cage to go. Just loosen. Okay. Okay, so we go in. So you see that the serrated edge is facing the end plate. Yeah. Okay. That plastic should not come. Okay, we are in the foramen. Shoot. So once the disc is, the cage engages the disc. Now it is engaged. I take out the wire. Now I have to go very fast. I can't waste time here. Okay. Shoot. Okay. So within shoot. Okay. Can you show AP? Yeah. Okay. Lateral. We have space, so we'll go lateral. Okay.
So the cage has crossed the foramen. Now you have time
Okay,
to
AP.
hammer it to inside.
Yeah, it's fine. No problem.
So the ideal position of the cage is it should be in the center
Give me
in the AP
dilated
view,
cannula.
and laterally it should be as anterior as possible.
Shoot. Okay. Wash. Suction.
So the advantage is there is no bone resection. It is the fastest way you can do a fusion compared to any other technique.
Okay. Give me steroid.
So in this case, we went posteriorly to decompress. The case yesterday, what you saw, the decompression was of the same case. So put a cage transcambion, then go posteriorly and do a decompression. In that way, you are still preserving some facet, and cage placement is very fast.
Yeah. we have a device which will measure the cage actually. This was 11 mm. Give me the long instruments. Shoot. Generally 10, 11, 12 is the size, but you can put up to 14, 15 also. Plus we have expandable gauges which will expand from 8 mm, 10 mm, 12 mm to up to 17 mm. So we have finished 4, 5. We'll go for 3, 4 now. So again same marking. Shoot.
So this is one method of doing it. The other method is the expandable cage that we will show you. He has done.
We have one more case which is done with the expandable.
Mahesha is demonstrating this case where a new cage has been devised. Expandable cage has been designed by Dr. Mahesha. So he is showing this case where we are going a transcambian approach and insert expandable cage. So that's what he is trying to show here. So now you will see the radiology T2 weighted sagittal image. There is a L5 S1 listhesis with a chronic disc bulge here. What has made patient symptomatic is the listhesis has caused the foramen stenosis, causing compression of the bilateral exiting routes. So today we'll go there transforaminally, jack up the disc space, and already my colleague Dr. Abhinandan has reduced on one side and put a screws also on the ipsilateral side, but a rod on the opposite side. Now Mahesha is standing on the right side here, left side here, because patient is symptomatic on the left side. Over to Mahesha, just tell us the landmarks, what you have planned and how you went inside.
Okay.
Now you can.
This patient has a slightly higher iliac crest, so that's why we had to manage this needle above the iliac crest. So we have the target point is center of the disc in AP, center of the disc in lateral view. So we have put a needle now, 18 gauge needle into the center of the disc. Can you see both the views, AP and lateral? And it is very important that your needle goes very, very close to the lower end plate.
So you can see here screws have been put. Mahesha has gone from the midline. How many centimeters?
11 centimeters.
Huh?
11.
11 centimeters from the midline. So he is using a cannula of how
8
many?
millimeters. 8 millimeters.
8 millimeters.
Sure. Okay. Hammer. You take a lateral now. So I am in the foramen now. So if lateral is all right, we just hammer the cannula inside. Okay. So we change the needle to guide wire, then we put a dilator, a 7 millimeter dilator, which is going inside. So now we can see I am at the edge of the annulus. We take out the wire and hammer this inside. Don't change the direction. Sure. I am in the anterior part of the disc now, and in the AP I have to be somewhere close to the opposite medial pedicle line. Okay. Then I am safe.
Because in lateral, I was almost coming anterior third. You can see here AP is in the opposite.
This is very important. Everyone should understand in endofusion. The placement of the cannula or dilator, Mahesha was telling midline. So AP, it should cross. It has crossed little bit midline, and lateral, it's in the anterior 1/3. This placement should be understood. Otherwise, you will have problems.
Because your final position, mostly it will depend on your initial needle entry. So if you do the initial needle entry correctly, rest of the steps are very simple. Anybody can do it.
Medial pedicular line.
This
So
is
this
quite
will
all right. So now we put the crest is coming in the way. So we are somehow cheating the crest. Can you do something to remove this? Okay. So we have gone with the cannula side. Okay, sure. Okay. So cannula is in the disc. We take the curate. This is the first curate. You see, this is
just
one more important point. When we are using these cannulas, it has to be 8 millimeter or less. You cannot put a 10 millimeter cannula and keep it for 10 minutes in the foramen because it will cause post-operative neurologic symptoms. This is very, very important because when we started this transcam infusion, we used to use big cannulas like 9 mm and 10 mm, and all of our patients used to have post-operative symptoms. But once we switch to 8 mm cannula, we don't have post-operative problems.
That's an angled curate.
Okay.
It's a bigger size curate.
So
which
we
is
go inside and scrape the end plate. Shoot. Okay. So this is the upper end plate. Just scrape the upper end plate. Can you hear the noise?
Yes.
And you rotate 180 degree. You scrape the lower end plate. And you rotate and take it out. You see the disc coming out. Okay. And give me the other curate. So this is the ring curate. So this is the most important instrument in this transcam infusion.
You see here,
So
it's like articulating curate. So keep the hand and show me. Keep the hand.
okay. So it moves like this 90 degrees.
To show the ring, you can see the ring, a very sturdy curate. This does a lot of work for you. What is the dimension of this curate, Mahesha?
This is the tip is about 7 millimeters.
Yeah.
The length is about 10 millimeters.
Okay. So
So you can do 360 degree preparation just with one instrument. You do it like this. You prepare the posterior part. You turn it. You prepare the anterior part. You turn it to the side. You prepare the lower end plate. Turn it upside. You prepare the upper.
So one caution
And
here is,
beauty is it will take out the disc along with this.
Yeah.
You don't have to use another instrument. We take a lateral now. We have seen the AP view now.
Yeah.
Lateral. And it has a protection sleeve.
What he has done is he has gone deeper. That will
So I
be
should
the
not cross
end
this
of the
Lakshman
work.
Rekha.
That will be the end of.
Okay. So I have enough space in both the AP and lateral. I can go some more inside. Okay. So I can go some more inside. You see I've gone inside. Shoot. Okay. So that's the anterior part. Now I start scraping.
Whenever you come out, Mahesha, how effective this tool is. Just
You
show
see-
the,
you
just
see-
show
you
it.
see that this-
Wait a minute, Mahesha. Yeah. So just see the material coming out. That's the beauty of this. When you're operating a degenerative case, collapse disc, you need not too much waste time, and you need not use too much radiation.
Shoot. You see, it is becoming white.
So now you can see the space is becoming empty, becoming white.
If you want to prepare the front part, what I do is I go inside, shoot. Okay. Can
Yeah.
you see? It is in the anterior part of the disc. So if you want to prepare the anterior most, you rotate it, rotate the handle towards the ceiling, and then prepare.
Just
so
show
this is
that.
expandable
And
sizer come reamer.
yeah.
So it opens up to 15 millimeters. It has markings here. So it will show the exact. So this is 6 mm, 8 mm, 10 mm, 12 mm, 15 mm.
Yeah.
So you can get the size of the cage. Shoot. So it also has a protection sleeve. Now I expand. Okay. So now it is tight. So it is coming around 11 millimeters. Shoot.
Mahesha, here at the end of surgery, you want to put a scope or no?
No, we will not put a scope here.
Yeah. So Mahesha doesn't want to put a scope here
I
because
put scope before and found that it is good. You don't have to do any more preparation. So this is the full expansion, you see, and it is showing 12 millimeters for me.
So 12 millimeters.
So this is the size of the cage. So we have a expandable 13 mm cage, so which we will expand fully. Okay, grasper. So now it is out. There is any more disc, you can take it out. Okay, give on the needle coding. Okay, give me a knife and a needle. So we use allograft mixed with bone marrow for packing the space. So the space is fully ready now. So give me knife. I'll take some bone marrow. Okay. Again the needle, syringe. Okay. Hammer. So go inside.
Give me the syringe.
You can see he's taking the bone marrow. He will mix it with the allograft. So already his colleague has prepared. That's allograft. You can see the allograft has been prepared. So he will mix around 3 to 5 cc.
So once we mix, it is like a normal autograft only because it has enough biologics.
And it
for
is
treatment.
economical also.
Yeah, it is much
Way
cheaper and
economical
much
than
better.
the.
Okay, we pack the graft now. Go. So we need to, if you pack too much, then it gets stuck here. Mid. Shoot. Okay. Shoot. You see, it is packed now. Okay. So we have packed now. So now we put the wire inside. Shoot. Okay. The wire is inside and take this out. Shoot. Just to have a direction. So this is a cage. There is a new
So
design.
this is a new
It is a
design
granulated cage, and it is exactly like our standard endo cage. You have serrations only posteriorly. The front part is very smooth. You see here, the front part is very smooth. Only the posterior part has serrations, and this expands from 8 millimeter to 13 millimeter. So each turn, one turn, it will expand half mm.
Okay.
So when you turn it 10 times, it expands to 13
Fine.
millimeters.
Okay.
Okay. This is a 10 times.
Yes.
Okay. So we go inside. Okay. So this is my
The
direction.
same as
It will
bullet
I have
case,
to
but
go like
there
this
is a
for
expansion
broad
here.
of- And it goes over the guide wire. The wire is already out.
So Mahesha will
rest is
show you
coming
the
inside little bit.
instrument here we have with us. Once his cage is inside, we'll
So
show
give me
you.
hammer. Shoot. So already it is inside. You see. Shoot. 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 Okay. So it is inside. So I can take out the wire and go inside. Shoot. ಹೋಗ್ತಾ ಇದೆಯಲ್ಲ shoot. So I have to go as far as possible. Shoot. Okay, now we take an AP. So it looks too much anterior. When you expand, no, it comes back.
Yeah. So the expandable cages, whenever you are expanding, it comes back almost 1 to 2 mm. It comes posteriorly.
Okay. So now we start expanding. Okay.
Shoot.
Shoot. Okay. We start expanding. 3, 4, 5. Shoot. It's already expanding. 6. Shoot. I think it is already tight.
Right. Yeah.
Because it is.
Yeah.
The one advantage is you can redo it again if required.
So what Mahesha is doing is just loosen the screw the opposite side.
So it expands still further. Shoot. Okay. I think it's good enough. Shoot. Okay, it has expanded well. We'll take one AP. So it is quite anterior.
Yeah.
And more on the other side. So I think it should be good enough. Okay. Shoot. Okay. Center
Perfect.
of the
It's perfect.
Okay.
In the center of the disc and it's in lateral. You can see it's well expanded. Good
Give me a guide
lordosis
wire.
has achieved.
We'll take out this and we put the dilator cannula once. We take a CM shot again. Good calling. So the handle is no problem. No problem. Give me the dilator. Okay. Shoot. Okay. So that's the final position. We take a lateral view. This is the center of the
Yeah.
disc in AP, and we take one lateral also.
Why did you put the guide wire, Mahesha?
For putting steroid. Shoot.
Steroid
Shoot.
ready?
Okay, are you
Yeah.
happy?
Yes.
It is perfect. Well expanded.
Yeah.
Dilator. I give a wash, then put steroid. Okay. Okay, CM can go out. We don't require CM. Dilate cannula. Cannula. Then wash and process. So how much time you taken? Time.
In
Suction. CM out. How much time did we take?
25 minutes.
Okay. It's for demo purpose. Otherwise, you can do it even faster. Okay.
Mahesha, you can show that cage here.
So any excess loose graft, it will be sucked out here.
So we'll stop here. Mahesha will show the expandable cage. So how it looks like and what is his design.
So I think
He has designed it.
expanded up to 12 millimeters, not fully.
I'll just close it.
Yeah, this is manufactured by Giant Implants. So they have designed this cage. This basically comes in 3 sizes: 8 mm expanding up to 13, then 10 mm expanding up to 15, and 12 mm up expanding up to 17 mm. So this will cover almost all the requirements which we encounter in our practice. And this is, as we have explained before, this is bullet shaped. So this will avoid any root issues when you put this cage. You can see the tip is tapered, and the front half of the cage is very smooth, and we have serrations only backside. And this is cannulated, so we put it over the guide wire. You don't require any special sleeves for putting it. And I will just expand it once and show it. And this expansion, you can reverse it. So each one turn, it will expand half millimeters.
Very simple. You can see.
See, this is the full expansion. And you can undo it. Okay. And this has been tested extensively in the biomechanical testing, and it has been very, very good.
Okay, so Mahesha, does it has a lordotic?
No, this because it's a transcabin cage, there is no lordosis. Lordosis, we get it through the screws.
Yeah. Okay. Thank you, Mahesha.
Yeah.
So.
And we thank Jayan for helping us for this event and also for this cage. And I hope they will keep the price economical so that all of us can use. Okay, there is no money for me or anybody else. Thank you.
So thank you, Jayan, for so coming up with new things every year. So they help us giving the best outcome to the patients with all the innovations. So we'll just go to the next talk. So
You can. No, I normally do them under spinal anesthesia, but this patient was under GA. I normally do my fusions under spinal anesthesia. Neuromonitoring is not required. As long as you have put the needle properly, you will not hit the root, because the root will not come anywhere close to the facet pedicle junction. Root is always away, and root is there, but it will be pushed by this cage away.
The X-ray, the laptop connection. So just show the post-op X-ray. Meanwhile, our friend, dear friend Suresh Ramaswamy from Malaysia is a senior spine surgeon, has done many cases, and he's the most important endoscopic surgeon in Malaysia now. And he does everything. So he will be his latest addition is OLIF, OLLIF. So he will also show how he does it. And this is a post-op X-ray what Mahesha just did. See the nice lordotic expansion. The lordosis has been attained. Good apposition of the end plates by the cage, and disc height has been restored. You can see this. So this advantage is the shape. You can go through transcambin foramen easily without too much damaging the exiting route. So thank you, Mahisha.
Yeah.
You can connect Suresh now. So Suresh will be talking on OLLIF.
Think we should appreciate Suresh. Every conference here he comes.
Yes, and
yes, I don't remember him missing one conference.
Yeah, Hyderabad is his second home.
Because you are my mentor, Dr. Sukumar.
The connection. So any doubts? Meanwhile, you can ask because now after Hamid Abbasi has popularized this technique. So, but one caution to the beginners: exiting route injuries are very devastating. So, patient will never forgive you. So, try to be very careful, not to injure the exiting now. Follow the principles, and if read the foramen properly on MRI, and if you think that any exiting route is in your way, don't hesitate to go posteriorly and fuse it rather than going transcambial. So this is very, very important out of curiosity, and don't do transcambian approaches if you don't know the anatomy well. And speed is also important. If you stay there for a long time, as Mahesha said, the cannula will irritate the exiting route and cause lot of paresthesias.
ಮಂಜಾನ ಯೂಸ್ ಇದ್ದಾರೆ ಯಾರೋ
అది డూప్లికేట్ అవ్వట్లేదు సార్ డిస్ప్లే సెట్టింగ్స్
Any questions you can ask meanwhile.
పెన్ డ్రైవ్ లో తీసుకురా.
Yeah. 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 So I got your question. See, for each transcambin cage, it takes 20 minutes. And for stenosis, decompression, one level you can finish in 30 minutes. Yeah. The screws were put by Amin and he's also very fast. So he finished 45 minutes for the screws and 25 minutes for the cage. Finished.
So total surgery was around 3 hours. But because we were recording,
Recording will take time.
We have to be slow and show step by step. If we are not recording, then definitely less than 3 hours we can do 2-level fusion easily with the stenosis decompression.
See, 2-level fusions I do under spinal anesthesia. So you can imagine the time. And under spinal anesthesia, single shot of spinal anesthesia with no addition for prolongation. Normal spinal anesthesia, 4 cc of sensor cane. Yeah, it will last for 2 hours. 2 hours I will finish the procedure. Yeah, all fusions we put steroids so that patient, because you cannot put it again. So you put steroids, nothing happens, provided you take it in aseptic way. Usually it is Canacol. Yeah.
అదంతా పెట్టు పాప అది పెట్టు ఇంకొకటి పెట్టు
వచ్చే వరకు Yeah, I know. I have to leave now. I know. That message did not. Okay. Okay. Going to Dubai. Okay. Okay.
Sir, in grade 1 listhesis,
Yeah.
with preserved disc height,
Yeah.
do you feel that cage is compulsory, sir, and bone graft will be sufficient?
So,
No, it is better to put a cage
so
because
right side.
if you put only graft,
And
the
you
risk
see,
of failure is higher. Because when the cage, when the graft unites, it unites by collapse. Whereas the purpose of the cage is to prevent collapse. Fusion will happen anyway. When I was doing open procedure, open fusions, I have done many cases where I have put only bone graft. They have united, but some cases there were failure of screws, but they have united, no issues. It will you can achieve union, but for patient he will feel that it is a failure because the screw has broken.
Sir, but probably the exiting route complications, paresthesias will be very less if you don't insert the cage.
Not really. Not so. If you stick to the principles, it will not. If you are worried about exiting route symptoms, you put expandable cage.
Which is
Going? Okay. 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 Okay.
Thank
Good evening, everyone. And basically, Dr. Maisha has shown how to olive surgery done, and my technique is exactly 99% same as what is shown earlier. So I cut short all these, and I'm using expandable cage, and today I will share about my first 20 cases. All right. So my inclusion criteria is symptomatic lumbar spinal stenosis, clinical indication for fusion, failed conservative management. My exclusion criteria is high-grade spondylolisthesis, active infection, severe osteoporosis, congenital stenosis, gross facetal arthrosis, gross reduction in disc height. So my surgical technique, as I said, exactly follows what Dr. Maisha has shown. So I put in pedicular screws first. Following that, a transcambient access to the disc and plate preparation, cage insertion, and here I try to achieve indirect physiological decompression by using a expandable cage, which increases the disc height restoration, foraminal expansion, and also neural decompression. So skin markings. First I put in the pedicular screws as shown. Putting in the pedicular screws. And after that, guide wire placement both in AP and lateral at the center of the disc. After that, placing the dilatum, following that is the cannula, and I have the same disc prep instruments which I bought it from, same, the one design, I just got it, and I have these instruments with me, with a shaver, and after that, is the bone graft insertion. Here I use cancellous bone chip mixed with bone marrow and also DBM.
What is the cost of DBM there?
It's about 500 ringgit, comes to about 3,000 rupees. So here you can see I put in the cage. Expanding it. When you expand it, you can see it opens up the foraminal height as well as the disc height. So this is the cage that I use. It's a bit different from what Dr. Mahesh has shown just now. And this cage has a 0 degree, 5 degree, and 15 degree lordosis correction. And this cage is not, it's designed for interlaminar approach, but I use it for transforaminal.
So you do it on the K wire, guide wire?
Yeah, it's a cannulated cage, goes through the K wire.
Okay.
So this is the post-op X-ray for that patient. And I just share my few cases. So this is a 60-year-old male had a wide laminectomy done L3 to L5 for bilateral lower limb radicular pain in April 2025. It was done in elsewhere. Post-op back pain worsened and leg pain remained the same. Was not walking after the operation. So this is the pre-op MRI before the laminectomy was done. And this is the post-op MRI. So the patient came to me with this MRI. And for him, I did 2-level OLIF. So this is the immediate post-op and 3 months post-op. So we can see here the first operation scar, which is the midline scar, and after the OLIF. This is another case, 58-year-old female, lower back pain with bilateral lower limb radicular pain, did L4-5 OLIF. This is the pre-op X-ray and MRI. So this is the post-op X-ray. So here we can see clearly how with expandable cage we can open up the disc height and also the foramen. So there's a 3 months post-op X-ray. This is another case, 68 male, lower back pain with left leg pain for more than 2 years. So L4-5 OLIF. So on the left is post-op and on the right side is 6 months post-op X-ray. Here's another patient, 68 years old, L4-5, pre and after 4 months post-op. This is another 58-year-old female, L4-5. This is after 1 year. This is my first case that I did with the expandable cage, which has got 1 year follow-up. And is the last one is a 60-year-old female, 2-level L3-4 and L4-5. So with good lordosis correction as well as the disc height and foraminal preservation. So those are my cases that I would like to share. And thank you.
So, do you do any post-op MRI to follow up?
Immediate post-op MRI I haven't done.
No, the follow-up MRI so that to
Follow-up I
see
will
the
do.
canal diameter has increased because of the indirect decompression.
So most of my cases is just between 3 to 6 months now. So I'll first post-op MRI I will do at 6 months.
Yeah, okay. So just to understand what is our principle when we follow the indirect decompression, we are restoring the height that we know by radiology, X-ray. But are we increasing the canal space that we'll know by the
Post-op,
MRI? Yeah. But patients are all asymptomatic.
So
That
far,
is
all the patients are
that is good.
asymptomatic,
That
yeah.
is good, sir.
Mm. So far, no. So sorry, my selection is I don't do for more than grade 2 listhesis. And also in case of there's a severe stenosis, then I will compensate, add on with direct decompression.
Thank you, Suresh. So we'll quickly go on to the next case, the eagerly awaited thoracic OLLIF, thoracic OLF, where it is done posteriorly, monoportal with en bloc resection.
T12 ossified yellow ligament causing significant canal stenosis leading to paraparesis in a elderly individual. This patient recently underwent bilateral total knee replacement. Post total knee replacement, his paraparesis deteriorated even before he had some element of walking difficulty, which was attributed to the knee symptoms. But post surgery, he neurologically deteriorated, and on examination, he had a spastic paraparesis with power of 3/5 with bladder symptoms. So options were discussed. This patient also underwent spine surgery, L3 to L5 fixation a few years back. So also had multiple surgeries for the leg fracture, the ankle area fractures. So comorbid patient. So the discussion was whether to do a open decompression or endoscopic decompression. So patient wanted less minimal damage, so he agreed for the endoscopic decompression. So when you see the MRI here, what is troubling is paraparesis. So you see here what is happened is there is a D1112 ligamentum flavum hypertrophy and also the chronic disc disease in both 1011 and 1112, and also there is adjacent diseases also. But when you see the axial image, so when you see the axial image of dorsal spine coming to D1112, there is a significant stenosis. There is significant stenosis here. You can see the significant stenosis. T1011 is okay. Cord is seen well and CSFS space is seen all around. But when you see D1112, so D1112 is significantly narrowed. And a few points we need to understand is you can see on the right side there is a facet ossified. The ossification has led to a spur formation here, poking into the thecal sac on the right side. And you see a nerve is inflamed on the right side, the exiting nerve. So these are the findings which clinically correlated, and we saw the L3-4 here, L3-4 adjacent disease 3 and 4. It's still okay, not that severe, significantly compressed. What patient is symptomatic now with the paraparesis. It is more significantly at the dorsal spine. For lumbar L1, L2, and L2, 3, still there is some CSF space seen here. So clinically, the symptoms correlated to D11-12, and being a morbid patient, we didn't want to too much do for him, so we'll only do D11-12. So the plan is do a D11-12 monoportal decompression, en bloc resection of the ossified yellow ligament. That will be showing how it is done, how we enter the area, how it is marked. So today we'll show you patient under GA prone. And again, the commonly asked question is, will you do under monitoring? It is up to the surgeon confidence, always better to do under neuro monitoring. Today we are not doing under neuro monitoring, we are directly doing without any monitoring here. So patient under GA prone, our assistant as my colleague has marked the level, and again dorsal commonly it is missed. The level is missed, so you should be very careful. So my assistant has already marked, and then we'll just go through the CT scan of this patient. CT scan of this patient, especially axial images, are the crucial images for surgical planning. And you see the D10-11 here. So what happens usually we miss here is you can see the calcification here. The facet and ossification, there is a gap here. So it means that there will be some space and ossification overtakes only the deeper layer of the ligamentum flavum gets ossified. So that is it here. So there is a canal stenosis. So we need to significantly decompress. We'll go from the right side and decompress ipsilateral side first and go over the top. So idea is remove this end block, remove this end block. So that is our idea. We'll just go and start doing the surgery. Thank you. So this is the position we initially patient already draped, so I couldn't show you the position. So this is the position patient, the normal spine, dorsal spine position, comfortable position. Thank you. So today we will see how a dorsal canal stenosis because of ossified yellow ligament can be dealt with monoportal technique endoscopically and removing the entire ligamentum flavum and ossified ligamentum flavum as en bloc. So we'll just see the basic steps, how to drill, how to reach the extent, and how to remove it. So we saw in MRI, it's always better to remove a bone or the structure posteriorly from pedicle to pedicle. So you remove structures from pedicle to pedicle, you are always safe that you have decompressed adequately. And we go over the top. In floating technique, what we do is we just drill the base of spinous process and detach the base of spinous process, and we keep the interspinous structure intact. So that's the crux of the technique here. When you want to go over the top, you need some space and you need some mobility for the monoportal to go to the opposite side. And we are using a stenoscope here. So we need some space to go to the opposite side. So for that purpose, we detach the spinous process from the lamina and we make it float so that we can go to the opposite side very easily. So that technique we will show you here today. And now patient is prone or GA catheterized, and we are position the patient as any spine surgery, and now we'll mark it. My colleague has already marked. This dorsal spine surgery marking is very important, and here he has already marked at D11, D12 space, and patient has 12th rib here. It becomes more easy. So you need to tell your team beforehand to establish that whether 12th rib is there or not, so that counting is easy. If there is a confusion or it has not been ascertained, you can count from below, from L5 S1 up, so that it takes time, but you will be more safe. So now we have marked the D11, D12 area. So I'll just now go to the space, shoot. So you need to understand the midline and lateral to the midline. I am going shoot at the D11, D12 space. So I'll mark. Hello. So here I'm just same thing as we land in dorsal lumbar spine. You land on the lamina spinous junction. The idea here is what I was telling is when after docking, uh, the idea is to detach the spinous process base from the lamina. So I have developed this technique. I use this in for cervical decompression also, where I float the spinous process so that I can go over the top. I thin out the bone, bone bilaterally, and then do the laminectomy so that I can remove en bloc calcium or ossified ligamentum flavum. So I'll just fast forward it for the sake of time. So I'll just go. These are the basic steps. Everyone will just. I'll fast forward it so that I keep the C-arm in lateral so that now and then we can see. And you can see here the foramen. The foramen definitely it is narrowed here. So and there is a ossification. So ossification of yellow ligament is a ventral pathology. It's a ventral to the facet capsule. So that gets ossified first and it extends into the laterally and the ligamentum flavum in the lateral canal also gets ossified. So it's basically a facet ventral calcification or ossification which comes medially. So this need to be understood. So once we go there, it's just exposing the, removing the soft tissue. Removing the soft tissue, I'm using a stenoscope here. Exposing the lamina completely above and below, that is very important. For the sake of time, I'm just fast forwarding this, which is a routine thing what we have been seeing for past 2 days. So I just use RF and soft tissue. So that's a tissue you see because here I'm operating from the right side. Right side of our screen is cranial. I'm operating from the right side. So idea is to identify the bone first. Once you identify the bone, once you identify the bone, you see the bone, now you see the bone there. Once you identify the bone, then you just take monopolar, which will be very faster. String these floaters. So once you see some bone, then follow the bone medially and laterally. So I just use a monopolar, which is faster. So then you find out the lower border of the lamina, upper border of the lamina, then the facet laterally. So once you do that, Sash Mahesha showed in the morning dorsal the tumor where he did one entire hemilaminectomy. The same thing we do here. So don't open the canal here. The canal should be opened in the last because it's calcified, ossified ligamentum flavum. It should be careful. Where dorsal spine already it's a compromised cord, thin cord. Patient will have devastating post-op myelopathy symptoms if you don't take care. So the shrinkage of the soft tissue is best what we are using for past almost 2 years now. That's a midline. That's the spinous process area. So that's the spinolaminar junction. So I just expose the spinolaminar junction So I have the habit of removing the soft tissue on the bone. So yesterday, Kalyan was asking, so same question, if we drill, there will be some particles in the soft tissue. This happens when we leave the soft tissue and start drilling using the drill. This happens. So always try to clear the area. So that's lower part of the lamina. So once you expose this when we start drilling, so then again I just take a shoot here where I am, and again when you drill here, you see there that's a upper limit, so the lower limit of your drilling. So that's the lower part of the lamina. That's the lower part of the lamina. So just I'm doing that periosteal removal so that drilling is better. So that's the upper part of the lamina. I'm delineating the upper part of the lamina. Then I'm just removing some tissue on the facet so that we can have a good delineation of the facet also. So that's the facet. These tissues will not come in your field when you're drilling. Why? So better is to clear this. So that's a facet area. So you've demonstrated the upper border of the lamina, lower border of the lamina, and the facet capsule here. So that's a facet joint area. And the easy way of drilling for any beginner, especially in thoracic OLF, is to start at one place, create a crater, and just try to be inside the crater and widen the crater and thin out the bone. So we'll start drilling at one place. You can use a cutting burr or diamond burr, whichever way is the surgeon is comfortable. But I use a diamond burr. So here is you just create a crater first, go deeper, create a crater. So this is always safe. So once you create a crater, keep just expanding the crater. So that's way you are safe, easy to do it, no issue. So you just increase the crater, go deep till you thin out the bone, then just keep seeing your limits all the time. Just increase the crater. This is a very simple and easy way. Now I have taken a cutting burr for the sake of time, and so it cuts better. So bone is tough, you can take the cutting burr. You see how I am doing. I am not using the pressure to go inside. Just I am cutting the cortical bone and carefully deepening it. So this way it's safe. All the time I'm seeing the deeper layer, the inner layer. You can change whenever there's a bleeding bone edges to diamond drill. So this way the removing the ossified ligamentum flavum is easy bilaterally without much handling the thecal sac or putting a upcut inside the kerison inside, damaging the thecal sac. So the thoracic spine, the drilling will be little bit more compared to lumbar. You can do it faster. Thoracic, because of the ossification, it takes time. So the drilling time is more of all the levels. Thoracic, cervical, lumbar. Thoracic is more. So now I am drilling the spinolumbar junction. That's the base of spine. Here is what I was talking about, the detaching the spinous process from the junction here. I'll show you. You remove the floating particles, so you will just, it is easy for you to drill better. I'm just removing some part of the ligament attached to the spinous process so that it is easy. Once you do this again, I start drilling. This tough tissue only monopolar can cut. So no other thermal energy can cut that. So that's such tough tissue. I'm trying to drill the base of spinous process, lamina junction. So what I do is I go to the virgin area cranially, virgin area caudally, and detach the ossified ligament. That's how I do it. There are various ways of doing it. This is one of the method, safe method, which I found out. I've done around 20 OLF till now, and around 7 to 8 cases of N block. So this is very easy when you remove N block than removing piecemeal. Till now I have not opened the canal. So that's end of your spinous process there. You can see the muscle there. So ipsilaterally, what you have done is you just uh, drilled the spinous process base from the lamina, ipsilateral lamina. So you can, that's the end of that's the end of it. You can see there. So if I continue the drilling, the spinous process gets detached so that I get a corridor to crawl to the opposite lamina. So opposite lamina is important for me here. So I just, so this is very important. So same thing I do with the cervical spine decompression also, where I can detach, I detach the spinous process. So with one opening, I do 3-level decompression in cervical. This technique helps to do a good opposite side work. So you can see here, I am completely detached the spinous process now. That's the spinous process moving now. So with this, you can see that's opposite side. I made my scope craniocaudal direction 90 degrees. I rotated, and I'm just working. That's the midline summit of two laminae. That's opposite lamina. See, that's a spinous process. I have pushed on one side, and that's the opposite lamina. This is ipsilateral lamina. Once you drill the summit, you go to the opposite side lamina. So that's the advantage. So I drill like this and increase the corridor to the opposite side. So now that's the opposite side. So opposite side I can drill easily, thin out the lamina easily like this. That's the opposite side. So once this is, see, that's the opposite lamina, that's the ipsilateral lamina and the opposite lamina. That's the inferior, what is the cranial edge of the spinous process. So that's the opposite side. That's the opposite side. That's the ipsilateral, that's the midline. So that's ipsilateral lamina. That's a lower edge. That's the lower edge of the lamina. So just to delineate, that's the lamina and that's the facet. You can see that facet joint. So just drill that area. So you can sacrifice a facet here. More than 50% is okay. So no problem. And especially in this case, you need to do more because it's, so I'm just drilling the descending facet there. That's a lamina ridge. The facet. See how tough is the ligament here. It has become very tough. I'm just trying to define the bony edges. So that's a bony edge. So this helps you to understand the limits of drilling. So that's the lower end of the lamina facet area. This ipsilateral side. So ipsilateral, you see, I went deeper and there is a yellow ligament which is, so every now and then you can check with the dissector whether you have reached the depth or not. Oh, just check. Here is just to do a safe way to do it. So that's a lower space. So lower part of the lamina and interlaminar space. So that's the entire laminar span, which the spinous process. Just drilling there. So here we are always safe because we have tried to preserve the ligamentum flavum and just trying to drill the edge. So that's entire. So further thinning out the lamina, you can see the ligamentum flavum. In CT we saw there is a calcification and there is a soft tissue in between the calcification. So that's the midline. That's upper limit. So here, this way we are safe. So we are not damaging any structure. Till now we have not used any kerosene. So I always do en bloc rather than doing piecemeal with kerosene. So I feel it's little bit dangerous every time we put a kerosene inside. Just eggshell it out. That's the cranial limit, and foramen. That's so till the virgin area cranially, virgin area caudally, you drill it and can see there. So just color changes there. So it means that the epidural space might be coming there. So you can see the pinkish color changes as the bone thins out. That's just using dissector to see whether the bone. You can see now that's epidural space seen now. So that's the rent. You can see the fat there. So I got a plane now where how depth it is, so I can drill there. I can just detach that small bridge. So that's after drilling the ipsilateral, that's a superior articular facet. That's a superior articular facet. So inferior articular facet has been thinned out. So I just removed a bit of remaining descending facet. So what you are seeing is a superior articular facet deeper and along with the ossification. So every time I'm outside, I'm not using inside the canal. I just remove this ligament. Now you see that even after removing the ligament, you see a bone there. See, I removed removed the ligament, and you see the bone there. So this is what I was talking about. There will be some soft tissue, and then you will get a ossification. So that's in this case, peculiarity was the ligamentum flavum was ossified inferiorly, and the inferior attachment to the lamina was completely bone. So inferior attachment was bone. So this is important step here. Madhu, voice పెడతావా?
Joint cartilage, you see. That's a joint cartilage, you see. This is all ossification.
That's a foramen area. That's a tip of SAP area. I'm doing little bit of cranial work I thought I'll do caudal work before, but just changed my mind to do a cranial work. You can see here, it's a junction. I have to disconnect up. So eggshelling out helps us a lot. See, you're just thinning out the bone. So going to virgin area is always better. So if your limits are defined. Now we have not disturbed the thecal sac, just outside doing the work more laterally. So this is a bone which we need to remove once. You see, that's a SAP. I'm just removing a bit of SAP medial edge. So just to have drill. So I'll drill. I just show you the anatomy here. So this is the superior articular facet. This is the medial border of the superior articular facet. This is ossification. This is ossified ligamentum flavum, which has gone ventral to the ascending facet. And this is a lower lamina. This ligamentum flavum has fused to the lower lamina. So that is what we need to disconnect. Normally, this doesn't fuse here. It is only here and goes medially. So, but in this case, it was fusing to the lower lamina. Bit of SAP. So I'm detaching from the, just detaching it from the medial border of the SAP. So the ossification, I'm detaching it here once. So I just made an island here. Slowly I am disconnecting it from inferior. So I'm just drilling a partial SAP here so that I can disconnect it from the ossification of that. Better understand I have not removed that bone so that once I do the SAP work, you can understand the ossification, how it has happened. See, all the time I am lateral here. All the time I am lateral. You can see the beyond SAP again, this is the ossification which has happened, and medially which is it has happened here. So first this is end block. I'll remove it. Later we can remove the remaining part. So, but I want to keep it till I come here to the lower part punch. I'm just drilling the lower lamina SAP edge to make you understand the anatomy. I can just remove the bone, but I just want you to understand the anatomy. I'm just removing this. You see now the lower part of the ligamentum flavum is attached, fused. So now all you need to do, remove this bone. We have disconnected a significant amount of bone here, made it island. The lower lamina here. You can see that it is fused. The ligamentum flavum has ossified at the lower level also, where it inserts into the lower lamina. You see that there is continuous bone here. You don't see a, so yeah, so it's a ligamentum flavum ossification inferiorly. So we'll just drill and disconnect it. So inferior limits are over. So I use a drill more rather than in lumbar spine. Sometimes in severe stenosis, we do see such situation. There you can use a chisel easily. Chisel, just use a chisel, nicely chisel it out. But here you can't do that because of the fear of injuring the thecal sac. So just thin it out Fuse number 1 Kerrison easily we can disconnect it. All you need patience. So if you had gone from the midline, you could have too much pressure on the thecal sac every time you go in. So you have not gone to the canal at all till now. You have to disconnect here. So we'll go slowly and disconnect inferior.
So this is the inferior aspect
So we
of
can
the.
take a shoot here, how inferior we are shoot. Okay. So we have come to the
Can see there.
beyond pedicle level.
I just disconnect it there.
Okay.
Now it got
Broken
disconnected.
here.
So that's
Pulling it away. That's the entire a piece of bone has come out. This is one piece. There's a remaining piece there. I'll show you. Now you have a good thecal sac exposure. This is the lower part of the ossification which has come out. Still the main part is still there. Ipsilateral main part. I just want to show you separately. This is a upper lamina remaining edge. First cut. I'll just show you. I'll remove the upper laminas remaining edge, floating edge. Then we'll come to the calcium proper. So this is you should be very careful what you are cutting. So just pulling it away from the thecal sac.
Here there were severe dural additions, so which I have to. I'll show you how it is done. So people always tell there is no plane. There will be always a plane which we have to carefully remove. This is a very important step I am doing. There were dural additions, usually ossified ligamentum flavum.
If you are not careful, you can cause dural injury. If it can cause. I just have to remove this floating so that my vision is better.
There it is, dura is adhered. See the dura is adhered there.
There is a dural addition. Can you see that? That's a dural addition. So don't pull it. We can easily. Someone is asking, and all my friends and colleagues and the beginners who have started thoracic endoscopy, they ask how to remove the addition. There is always addition. Should we float it? Do a floating technique as we do in open surgery, or remove it. So most of the time, 90% of the time, according to me, there is a plane. We need to understand the plane and remove it. So there will be a plane. That's what I always say.
So there is addition here. You can see the addition there. So I use a
So I'm
curate.
just lifting it up gently.
Can see that's
Go
the addition.
deeper.
Can see that's the dural
That's
addition.
addition. That's addition. I'm trying to go to the plane. That is floaters. I'll remove the floater. And so this is the time you need to be more composed, calm in the element. Even you leave intact arachnoid, it is still okay, no problem. You can see that that's the addition. I'm just trying to create a plane. Taking care not to put the pressure on the thecal sac.
So the
And
outer layer of the dura is adhered.
Gently.
So this is impossible to do in open surgery. We invariably, under microscope, we damage it. So we open. So I can see I can creating the
Instruments are
plane.
key.
So I'll come from the other side now. So I'll just pull it up. Again, create a plane here from below.
See there. So
Ah,
just lifting it out.
all we are doing ipsilateral and pulling it outwards, not pressing anything on the thecal sac. Be very gentle here.
Steroid is given for this case, sir.
Yeah, already our team might have given the methylprednisolone at this point of time.
You can see that's
So this we can disconnect easily because it has a good plane. Then we'll come to the upper, the remaining part, upper number 1. So I'll just disconnect this. Smaller. I'm using the
now
small
you see that
cutter here, annular
the
cutter.
additions are there. I'm using a small cutter, a cervical cutter I use here because it's very small profile. It's a cervical endoscopy cutter, which is very small. So the fibrous addition, I'm just picking it up.
ఇది పట్టుకోను ఫైన్ థింగ్స్ క్యూరేట్. So if you leave these floaters, it is okay for some time. Again, they might develop additions and form a bone again. So that's why better is to remove them.
See there, that's the addition. The osteophyte had bored into the dural sac here. Once I remove this, I'll
So
show
that
you
was a depression.
that's the depression on the, can see there.
And that's the root there.
That's what it had caused on the thecal sac.
That was a compression there. That's a root going into the foramen root area. Or you can see the depression here. That was a depression. We removed it. Now we'll just have to focus on the main one. Just will also just a small last bit of it is there. We'll just go and remove it. Midline dura is very thin, so that's why I always go from lateral. I'm not at all using any force, just staying on the bone and trying to use my curate as a dissector. So I've made it as a floating thing now. So just separating it from the midline. That's a midline attachment. See there, that's a midline attachment there.
So now again I use the cutter.
Just going deeper, stay on the bone. Your cut should be on the bone side. Okay. So that's the entire remaining block of the bone. So we have removed it now. So
that's an end block removal.
So this was a depression here. See, the depression was here.
You see the swollen ganglion there. That's a ganglion. That's a root. That's axilla.
We don't know what is this, probably synovial cyst or a ganglion. Okay, it's a part of the nerve. See, root only, yes. The ruxic root and the ganglion. So maybe because of the chronic compression, it has deformed. So now it's the root and the ganglion. That's a junction of thecal sac and the exiting root. This is a traversing root. That's a pedicle. Okay, that's a pedicle. That's a traversing root going down here. So ipsilaterally, we have done. We have not violated the dura. You can see there's a depression here. The depression was because of the bone, and it has pushed the thecal sac medially. So now we have removed it. We have not injured the dura. So now going to the opposite side now. So where is the bone here? So bone is here. This is the bone. So just I curate this and remove the ligament to make you understand how does the ossification look like. You need to delineate between the normal bone and the ossification punch, so that we can do a en bloc resection on the opposite side also without damaging the thecal sac.
So this opposite side I am doing
I am
now.
using just I could have just started removing the bone and done it, but here, because I want to demonstrate the ossification, I just want to go slow and show you how does the ossification on the opposite side. Here, though, the opposite side is no much ossification. So first is I remove this bone upcut. The remaining opposite side spinous process base along with the lamina is the opposite side. I'm just removing it. The base of spinous process which we have already drilled. So this is opposite lamino facetal area. Now because we got a good space, we can remove it easily. This is the opposite lamina. I'm just removing it. And so that the opposite calcium is defined, opposite ossification is defined. So this is the advantage of drilling the midline, separating the midline, so that when you are going towards the opposite side, you don't have a vision hindrance, and you can see the tissues limits of the opposite ossification also easily. So I'm just lifting the
That's the lower
opposite
lamina.
and see here.
Lower lamina. That's the ossification. See there, the entire thing is
That's ossification. So that's opposite this
Ossification.
one. So first I drill this, drill
We'll
the
detach the
opposite
lower lamina.
superficial
Yeah.
area so that I can show you the deeper layer easily. I am drilling the opposite lamina facet area in the facet area. So this is the opposite facet I am drilling, but I can disconnect this entire bone. Again, our saline pressure is not hitting the thecal sac. We are away from the thecal sac. So this method is always safe. So you are not going towards the thecal sac, the initial part of your dissection. So you are always safe, and results are better if you stay outside and remove end block. At the end, you can just remove the adhesions part. So the handling of the thecal sac is much less this way.
This is the lower lamina
And also your
ossification.
clearance is wide. So this upper area, lateral area, and the lower area. The facet tip, just disconnecting that, because I can see there are additions on the opposite side also. So we need to address them once. So always try to understand the bone limits or bone edges. Otherwise, you blindly do, you might either underdo or overdo things. So this is opposite facet, lamina facet area, that's the superior facet, the opposite calcification, lower part, where which we need to decompress.
So here I use the chisel.
So that's the IAP tip we have removed. So this is the calcified part, opposite part, opposite inferior. So we'll just take some.
So here I'll show you the anatomy. This is the IAP tip. This is a SAP, and this entire thing is a calcification, ossification, along with the superior articular facet. We have disconnected caudally. So now I can remove entire thing as one piece.
Time drill. Now I'm going to the opposite side. This is the opposite side again, opposite inferior ligamentum flavum ossification punch. So it has fused with the lower lamina and it has ossified. So there we have to disconnect. So this is the area of ossification which we saw ipsilaterally. So we are doing the same thing on the other side. See, that's the ossification drill. So I just drill the lower lamina a bit, in out. I'm just going as lateral as it is ossified. You can see I'm just entirely outside here. I'm entirely outside, describing the joint and going beyond the calcification. You can see just I'm coming cranially. So if you had not done the midline work before, it would have been difficult now. So now we are able to come to the midline easily. The same work what we did ipsilaterally, I am doing on the opposite side. So I'm just this is the opposite remnant lamina. A bit I just removed it. So opposite work is better because of the angle we work and the vision we get. Always opposite side is better. Drill. So now I'm reaching the entire extent of the opposite ossification. So this is a big advantage of en bloc resection, where you need not remove piecemeal and struggle, worry about the thecal sac handling. This is opposite foramen area, upper foramen area. I am working. I just cleaned it out. Okay. Just broken the bone, small piece of bone with a. I use a number 1 kerosene here. So just use a number 1 kerosene. Just remove the small spike of normal bone. Then I'll go to the ossified bone.
So all the time I've been
I'll
removing the
show you
lamina
how does the ossified
and a bit
bone.
of facet.
So how does it causes compression? I'll just show you. So we think the bone which we are seeing is causing compression. No, that doesn't cause compression. The deeper part, ventral to the facet, that causes compression. So to just show you the anatomy, I'll just surgical anatomy or pathoanatomy. Just remove this ligament.
So the pathology is ventral. So
I want
that
to
we need
show
to
when
understand.
there is a ossification, how does that compresses the thecal sac? Where is that compression? Just remove this ligament, then show you the compression.
So don't be happy if you see the thecal sac. The compression
Here
is
it should
lateral.
be careful because dura will be adhered. So I'm just removing the ligament so that we can understand the bony pathology that has caused the compression. The apex of the ligamentum flavor, the SAP. So now I have just exposed the opposite entire ossified area. I'll show you. You think you have done a good job already? No. So I'll show you where is the ossification. Now you see here, one curate. This is a compression area, how it compresses. So don't get happy. You remove a bone in the midline. Don't get happy. So it is below the SAP, that is subarticular stenosis. You can see here, this is the area of compression. This is the area of compression.
So this is the actual pathology. See, that's a pathology
So you
there.
need to remove, see here, you need to remove this bone to relieve the compression. So what I do is now I use a chisel. So I am just directed to the opposite side. So my assistant, my colleague is just gentle tap.
Is breaking it.
Here also you can use a drill further if you want.
Bas.
I'm just marking it.
Thank you.
So this is an important step I wanted to
You can
show.
see this. It's a lateral edge. I'm just removing the. So all the time I'm lateral. I'm not on the thecal sac. Bone max radius. That's a thecal sac. its adhesions being separated. Now the entire bone is separated. Okay. So we can just grab it and pull it out. You can see here the entire bone must almost 2 centimeter or more than that. Okay. So 2 centimeter of ossification has been removed en bloc. We can see the dorsal surface. So dorsal surface and the ventral surface. So it's one wing of butterfly. You can say. So the bilateral we have removed, ipsilaterally though it became pieces, but still we could able to remove in blocks. Now just we'll do some hemostasis on the opposite side, bone bleed, stop, and any further.
See the advantage.
That's the lateral edge of the root. That's a pedicle.
Pedicle you can see nicely.
That's a disc.
That's the opposite side. So you can.
And here because foramen is okay, we don't want to disturb the foramen. Okay. So this is the entire touch on the opposite side. And see that's a pedicle. Beyond the pedicle. So that's a pedicle medial border. As a pedicle medial border, and root is going exiting at the lower pedicle. So that's the disc on the opposite side, and that's the upper foramen area, RF, where we don't want to touch it. And just keeping the bone wax, you can see there I'm using an instrument here which I can easily.
That's the back side of the dissector.
You can see now the bleeding has stopped. Now you can see here what I just have done. I'll just demonstrate the final. So here we are at D11, D12, D11, D12 area. Going monoportal, we went posteriorly, landed on the D11 lamina, demonstrated it, the entire lamina span and interlaminar space and the lower lamina. Then we started drilling the D11 lamina, came laterally, then inferiorly and cranially, and delineated the edges and removed the part of inferior facet, delineated the superior facet, that is ascending facet, drilled the ascending facet, defined the foramen and the edges. So we found that the bone here was ossified and fused to the lower lamina. So we disconnected the lower part, yellow ligament which was ossified ventral to the facet, then disconnected from the lateral part, that is from the superior facet, disconnected from the cranial part from the where the ligamentum flavum ended, then removed the entire ossification. Then we went opposite side. I drilled a bit of opposite inferior lamina and facet, cranial lamina and facet. Then once we delineated the lower border of the ossification, we disconnected here, then laterally and cranially, and removed the entire block as one block. As a result of it, you can see this medial wall of the pedicle. This is a disc on the opposite side, and this is the upper foramen area. So, upper foramen area, disc, pedicle, and the lower foraminal area, and ipsilaterally, this is the lateral edge of the root, lateral edge of the thecal sac, traversing root. This is the exiting root area, the ganglion, and the foramen. So, upper foramen area, ganglion, that's the thecal sac, and that's the pedicle where the root is going beyond the pedicle. This is the pedicle area. So, ipsilateral decompression, contralateral decompression without handling the thecal sac has been done. And there was a lot of fibrous additions ipsilaterally on the right side here. And we released these additions, kept the dura intact. You can see the dural layer is kept intact without any injury. So now we are coming out after a good decompression bilaterally. Then I'll show you the upper and lower ends of our decompression. So this is our upper end of decompression. Shoot, you can see this is upper pedicle. This is
See
upper
the
pedicle.
foramen has become bigger. Upper
Now I'll
pedicle.
go to the lower end of our work. Shoot, this is the lower pedicle. So upper and lower
Beyond lower
pedicle
pedicle.
work has been done very easily. And also you see the C-arm image, the foramen has become bigger. You see the foramen, this foramen has become bigger. There was a complete ossification there, which has become bigger. See now, the right side of your screen is pre-op, the left side of your screen is post-op. You can see the window we have created here. The big window of interlaminar. You can see the window here. Interpedicular window. Okay. So that's what endoscopy can achieve better than open surgery. Without damaging, we have preserved the interspinous posterior band, not disturbed too much of facet. Bilaterally, we have preserved a bit of facets, removed ipsilateral almost 50% and opposite 1/3. So still we have managed to do a bilateral root to root, pedicle to pedicle decompression. Thank you.
Thank you. So this is a post-op. You can see the post-op here. This is a post-op. What we have done, the post-op, you see pre-op there was thecal sac was not to be seen, and this is a post-op canal diameter. This is immediate post-op. Facets are still preserved, and you can see the canal diameter we have attained. So pre-op we saw there was nothing. We started with that. The disc is calcified, and post-op we have attained a good decompression. So patient is fully such a comorbid patient. We can just treat with a small monoportal is easy. It can be done. Just imagine if we had done a open surgery for this. So definitely we could have fused this patient and leading to the morbidity. And we would have ended in fixing a lot of spine here because there is adjacent disease here. So we would have ended up fixing way up down till the S1 here. So we have avoided that morbidity, and next we'll see. So any doubts here you can ask.
Sukumar, usually in open surgery, we routinely always, particularly in OYL and OPLL, one normal level above and below also you decompress.
Yes.
We say that when we decompress at the exact level, there may be paradoxical herniation.
Paradoxical?
Like a focal herniation, spinal cord and thecal sac at that level.
Okay.
So that is known to cause deterioration even when the decompression was good.
So you saw the post-op MRI, then you should not have that fear. It doesn't happen. So because the cord doesn't fall here so much because you're not disturbed the midline structures. In open surgery, you entirely disturb the midline structures, tending leaving cord to fall back. Here there is nothing to fall back because you have kept all the midline structures intact.
When you do for cervical spine, the leftover spinous process, do you think they will never cause any compression when you keep the patient supine?
No, because it's a posterior band is intact. They're not as if that you have just left a individual bone on the top of the cord. It is held with the interspinous and supraspinatus ligaments and the muscle.
Back.
Yes.
Yeah, see, this patient didn't had any much back pain. He just came with he underwent a knee replacement. He deteriorated and developed paraparesis in within 15 days post knee replacement. So it was acute deterioration. Probably the falls before it was attributed to knee symptoms. Probably he had a myelopathy even to start with before itself. And that myelopathy deteriorated post surgery because of the spinal anesthesia. He was given spinal anesthesia that time. So they attempted spinal anesthesia. So maybe because of that flexion, acute flexion during spinal anesthesia, he deteriorated further. So he didn't had any back pain per se. So nature has protected him with some ossification there. But if he had back pain, that's definitely use. He's a 70-year individual, so use a corset. You can.
For how long you recommend it?
See, if patient doesn't have back pain, no need for, you have done only dorsal and you have preserved the joints also. So there's nothing worry about your surgery. If at all you want to worry about the previous surgery, which
That's why the treatment we have to think in that way also, because
the
the
patient was asymptomatic for that for very long time. See, so many years back he was operated, open spine surgery was done. He was managing with that. So he didn't. He doesn't even today doesn't have symptom of adjacent segment disease. That's what I'm telling. So when he doesn't have any symptoms, why you want to protect it?
No, because patient has recently got knee replacement and he must be walking now.
Yes.
So the chances of getting
Yeah, see,
symptomatic.
it's up to the symptoms. If he is developing back pain often, yes, definitely
So
long term.
prophylactically we should not.
Yes,
You are
yes.
not planning anything.
No, no. But
sir.
I know two surgeons from Indonesia, very senior surgeons. For any degen surgery, degen decompression, degen patients, he uses a corset, lumbar corset for 1 year without fusion. What is your take on that, Dr. Com? Do you use a lumbar corset for longer time? No. Okay.
Sir, excuse me.
Yeah.
How many milligram of this dexamethasone you are give in this case while during surgery?
So though there is no scientific data, I use 1 gram of methylprednisolone during surgery, and that's it. So post-op, I use a dexamethasone 4 mg thrice daily and a taper dose.
1 milligram of
1 gram of
1 gram
methylprednisolone
IV.
IV intraoperatively
Mhm.
as a loading dose. But other post-operatively, I use dexamethasone. There is no scientific. A lot of people use differently. Dexamethasone 8 mg intraop he uses.
Dexamethasone intraop.
Intraop. I use methylprednisolone intraop.
The second question regarding thoracic spine and cervical spine endoscopic spine surgery. Is the time consider risk factor of complication if we, for example, if we doing surgery for 3 hours in cervical spine or thoracic spine, does pressure by saline consider risk factor for more complication? We are limited by time.
Yes. So as morning Dirk was talking about the which system you are using. You are using a circular sheath with a circular scope, then you have more fear of pressure transmitting to the spinal cord. If you are using a circular sheath with a oval scope, the chance is less because I use even in cervical spine decompression, sometimes I use 100. Thoracic spine, all the time when I was bleeding something, I increased the pressure to 120. So nothing happens if you are using a system where it's circular and oval scope. But if you are using both circular, definitely yes, you should be more cautious. As he showed, when your instrument is inside, you are working 5 working channel and 5 instrument is inside, there is a pressure created inside. Even for a momentary period, that pressure will damage the cord.
If you are using a circular in circular, we still have an outflow channel. So which we keep it open. The excess pressure will be taken out by the extra channel. Number two, we never use more than 50 millimeters. pressure. 50 if they are using pump. And I normally don't use any pump at all. No pump. I use only gravity, which is 3 feet above the patient. So with this technique, I never face problems because of pressure, even with long surgeries, even with intradural work, where the fluid is going inside the dura.
So it all depends upon how much time you are spending there. So whether you are preserving the ligamentum flavum, removing it at the last. So the transmission of saline pressure onto the cord, if you open the ligamentum flavum in the initial part of your surgery or already exposed the dura, then definitely the pressure transmitted is there. If you are removing the ligamentum flavum, removing it at the last, then definitely it is less dangerous. So that's why in cervical spine, if you are okay for 45 minutes, we can show the cervical laminectomy, also en bloc bilateral, where I will show you how you should keep the ligamentum flavum intact and remove it at the last, so that it is always safe. Yes, sir.
Very nice surgery. I want to ask, you have done almost 20 cases, more than 20 cases. How many cases you face any dural tear operatively or post-operative problems?
Yeah, I'll just show you one example, sir. That's what I wanted to show you. So one case, a very bad interlap OLF. I completely removed the dura, including the arachnoid, because everything was ossified. So there I just kept a Duragen plus, and nothing happened. So nothing happened. So because you saw morning the tumor was shown only. The I just show you the post-op in a minute. పెట్టేసి వస్తుందా? Just show you the I can show you the what happens and okay na? ఎక్కడ? You can see there. Okay. So this case, I'll just show you the main part. This was a case. You see the case completely ossified. Midline ossification was also there. This was a case I operated. This was a CT. You can see there the entire dura was also ossified here. There was no dura. Some more alarm. So this we did I did posterior under neuro monitoring. This was a post-op clearance I gave. So this is a post-op clearance. I just show you the post-op MRI. Yeah. This is a post-op MRI you see here. This case I just stripped the entire ossification. You see here. This is what you can patient fully preserved, no symptoms. Patient came with paraparesis. Now 3 months patient fully recovered. This is 3 months follow-up MRI. So there is some CSF there, but there is no, because posterior elements are intact. Huh? That's a CSF collection. That's a CSF collection, but it has not come out of the subcutaneous space. So it is there within the spinal canal. So there is no, you see here, it has not come out of the bony limits. This is a 3 months post-op. So this is what can be attained. Nothing happens. I just wanted to show this. And this is just a 3 months post-op follow-up. So just imagine you doing it with open surgery or microsurgery. It's very, very difficult. So just if you have patience for 40 minutes, we can go through the cervical laminectomy also, where single opening we can do two level laminectomy bilateral and en bloc resection of the ligamentum flavum. I'll just go through it fast. The C4-5 has two components. One is the chronic disc towards the left, and also the canal is narrow, canal is stenosed. So this patient has only giving a nick to the fascia also. I've given nick to the fascia, and I'm using the dilator now. So putting the dilator. Here I'm doing 4-5 stenosis decompression. So just landed there. Idea is to first identify the bone. Some bone need to be identified. As I said before, once you identify the bone, then delineate medial, lateral. So just cut the small muscle. So that's the bone. So once you see the bone, that's a bone you are seeing. Use monopolar. That's a bone you are seeing. So here, as I said, you have to go to the opposite side, drill the spinous process base and disconnect it. So just see here, I'm just, that's the C4 lamina. That's the C4 lamina. So I'm just going medially now. So just going medially. That's lateral. So that's a joint. You can see the joint there. That's a joint. So that's a C4-5 lamina has been now exposed. So once this is done, then upper and lower limits of my drilling need to be ascertained. So that's a upper lamina. So that's C4. Just go cranially using monopolar subperiosteal delineation. So entire lamina. So one opening I do 3 laminectomies. So just I'm going cranially. So that's a cranial end. You can see that cranial end, nice fat. The internal yellow ligament is seen. So I just come laterally now till the pars. So that's a pars area. So then I'll just expose the joint here further. So that's a joint, just exposing a bit. Then I go to the lower lamina. So I'm just going to the lower lamina now till the lower lamina ridge. Our idea here is to do 2-level laminectomy. So I'll just go to the lower lamina. There will be some bleeders here which troubles you. So as a beginner, you might face little bit trouble uh, coagulating these vessels because they retract and they come below. Always try to keep the field clean. So that's a I'll show you. That's a lower end of the. Then coming medially, that's just. So then I have to expose the ipsilateral tubercle of the spinous process of C4. So that's I'm trying to do it there. That's the ipsilateral tubercle. That's the ipsilateral tubercle. I'm just delineating the ipsilateral tubercle. So doing this bone work and defining your bony landmarks helps you. That's the ipsilateral tubercle of the cervical spine. To go to the opposite side without opening the canal, this is an easy way I found. So you see now, that's a midline. That's a midline. That's a midline. That's a midline. So just separate these tissues. So now what I have defined is upper lamina complete, lower lamina complete, ipsilateral tubercle of the C4. So how I can start drilling? So that's a midline. That's a midline. That's a laminar summit. C5 laminar summit. There. That's a C5 laminar summit. So you, because of your scope is angled scope, you can see the summit nicely here. So that's a C5 lamina lower part. So to go to the opposite side, this part need to be drilled, this tubercle need to be drilled, so that my sheath moves better. So that if I remove this, my sheath moves better. So I just drill this. I am drilling the ipsilateral tubercle of the spinous process, ipsilateral half. Once I do that, I can get the opposite corridor well. I can see the opposite corridor very well. You can see there. That's opposite. That's the midline. So once we remove this, detach this, I can go to the opposite side much better. So I just drill further little bit so that I will get the corridor. I can walk on the opposite lamina much better. So this is a now ipsilateral lamina midline. So if I remove this tissue, that's the opposite side. See, that's how my corridor to the opposite side got open now. So that's the opposite side. All I need to delineate the opposite lamina and the opposite facet. So that's the opposite side. I rotate the scope and just, this is a part I want to disconnect so that I can, this part. Now you see here, that's the opposite side. I just open this further so that my opposite side vision increases. So entirely I'm outside, extra ligamentous drilling. So I'm not going entering the canal at all. So here you keep the saline pressure more, no problem. You keep 100, 120, no problem because you are outside. You can see now slowly I'm entering through the opposite side now. So that's the opposite corridor. So I just that's the opposite lamina and so that's the opposite corridor. Opposite corridor. If I drill this, I get more idea. So that is the opposite lamina now. So that's opposite lamina. I can walk on that opposite lamina. So see, that's opposite lamina. That's opposite lamina. This is what I was telling about disconnecting the spinous process. This opposite spinous process, I disconnect here. So I just drill that so that I get more space. I can. So that's what I am disconnecting now. I'm disconnecting this. Yeah. So here I disconnect this spinous process on the opposite side. So that see that I use upcut so that I get that summit of two laminae easy. So I just disconnected the spinous process. It's a floating spinous process now. So I can just walk on the opposite lamina now. So that's the lamina. That's the lamina. I can walk on the lamina now. That entire thing is opposite lamina. I can just walk on the opposite lamina. And you identify the facet joint also so that your lateral limit on the opposite side you can understand better. So see now I get a space to drill on the opposite side. Drilling the opposite side is always easy. So that's the opposite lamina. That's the opposite lamina. I'm drilling on the opposite lamina now. See there, that's the opposite lamina. It's easy to drill the opposite lamina. That's a thinning of opposite lamina. So I'm doing contralateral work because it's easy. I can see that's the opposite lamina going laterally till the facet joint. I need to see the facet joint. I need to see the facet joint so that the commonest mistake done is the opposite work is not adequate. So we need to see the facet joint, define the facet joint. So I'm just doing the opposite work here. All the time I'm just, that's the opposite facet area. I'll just delineate the opposite facet. Because of the spinous process detachment, this work I am able to do it because I got space. So just delineate. That's the opposite joint. Can you see that? That's the opposite joint. That's the opposite joint. See that? That's the opposite joint. That's the opposite joint. So now coming to ipsilateral now, I'm come to ipsilateral now. So that's a lamina, upper and lower, and the interlaminar space. So what we need to do is done the opposite work. That's a joint. That's a facet. You can see that's a facet joint on the opposite side. So that's delineating that. It's always handy. That's a joint there on the opposite side. So you have done a opposite side delineation again. Yeah, that's opposite joint. Opposite joint. That's inferior lamina on the opposite side. So just wanted to show the inferior lamina also, but drilling can be done later. So that's opposite inferior lamina. So now you have demonstrated ipsilateral. So I'll just remove that summit of inferior lamina also, inferior laminae also, so that we can get a good corridor to see to the opposite side also. So I just, so this way I find it easy. So just 1 hour we can do 1.5 hour, 2 laminectomies easily, both sides. So that's the opposite lamina. So just That's opposite lamina. So I'm just drilling the opposite lamina inferior. So that's opposite lamina summit and inferior lamina summit. So I'm just drilling the opposite lamina now. You can see that's the opposite lamina. Why drilling is important? Because later you can just use a number 1 kerrison and remove it easily. Otherwise, once you open the canal, drilling the opposite side becomes a little bit difficult. So I've done opposite lamina drilling, inferior, superior lamina drilling has been done now. C5 and C4 and C5 drilling has been done. That's end of our drilling. Then I'll come to the ipsilateral side. So doing this helps. That's the opposite side. Opposite side drilling is easy. Yes. So then we'll come to the ipsilateral side. That's a joint. So you want to drill some joint, you can drill the joint some opposite side. So that's the opposite joint I'm drilling. That's the opposite joint I'm drilling. This all is possible. This excellent opposite work is possible only because I removed the spinous process, detached the spinous process. Only that because of that I am able to go to the opposite side. So once this is done, then we'll come to the ipsilateral side. So I've done the opposite C4 and opposite C5 lamina drilling. Then we'll come to the ipsilateral side. So this good decompression drilling the opposite side is important to have a good decompression. You can see. Then I come to the ipsilateral side. This is ipsilateral side now. And again, ipsilateral, I have my own device, own my technique where I don't start from the edge. I start on the facet. I'll show you how I do it. I start on the facet first. Then stay within the bone. Stay within the bone as we did in thoracic spine. Then just deepen the crater and eggshell the bone. Just eggshell the bone. Don't so you just eggshell the bone. So I'm not coming from the edge all the time. I'm using diamond. You can see here. So I'm just doing a C4 drilling now. C4 drilling. I'm not coming from the edge. I'm within the bone, just drilling the outer cortex. So this becomes easy for a beginner. He is not having a fear of plunging. So that's opposite side. So I'm just coming from the midline. So I'm just thinning out the bone so that I can take out the bone with just a number 1 kerrison later. So I'm just thinning out the bone as we did in thoracic spine. So this way your saline pressure is not hitting the thecal sac anytime. So you are safe. You can see that's the upper border of the bone. Advantage of this technique is it is faster. There is no bleeding. Epidural space, saline seeping is less. So now I am coming to the lower lamina, that's C5. So that's the lower edge. So you need, because you need to do a complete laminectomy here. So you need to go till the lower border. So you should have that marking before you start drilling so that it is easy. See, that's the lower border. So if you have a lower border marking before itself, it's easy for you. So all the time I am protecting the canal, not entering the canal, not opening the canal. I'm just drilling it. Just drilling it. So all the time I'm so I've done the lower border. Now I'm just doing the towards the interlaminar space. So just once this thinning out is done, ipsilateral, contralateral is done already. So just take a kerrison and start doing the. You can see it's eggshelled out now. Eggshelled out. So just drill the summit of inferior laminae. That's the summit of inferior laminae. So this thinning out is important because it's easy to remove with the kerrison, no pressure on the thecal sac. So I'm just thinning out the C5 laminae now. So you can see all around I've thinned out till the cranial edge. That's a cranial, sorry, that's a caudal edge. So that's a caudal edge, the lower border of the C5. So this upper border of the C4. So this lateral, that's a contralateral. So now I'll just start using the. I'll just show you the limits here. That's a C5 lower border. That's a midline. That's a C4 outer upper C4 upper lamina. C4 joint, C4-5 joint on the opposite side. That's C5 lamina on the opposite side. So I'll just remove that now with using a number 1 kerrison. So because I've eggshelled it out, I need not worry. So that's a cranial. That's a caudal. So that's a cranial caudal limits. I have can see there. It's a. Now I'll just remove these 2 lamina. Water in. Just because we have done a eggshelling of the bone, it's very easy to remove. do the laminectomy here. I'm just doing a midline work. That's a midline. That's a midline raphe, you see. That's a midline. Now the first time we are seeing the epidural space. Till now, almost majority of our work was the epidural space was not opened up. Now we have opened up the epidural space. I'm just disconnecting cranially. That's C4, cranial work, cranial end. So just disconnect this. So that's C4. That's C4. Detachment cranially. So this is very safe. We are not putting any pressure on the fecal sac. Easy to remove the bone. The saline pressure is less. So what I did is I detached the yellow ligament completely from C4 lamina. So I have detached it and I have left that flimsy layer still. I have not disturbed the flimsy layer of the epidural space. I just disconnect it laterally. So entire lamina, ipsilateral, hemilamina is removed of C4 is removed. So that epidural, that flimsy layer is still kept so that still your bleeding is less. Saline pressure doesn't damage your fecal sac, and good lateral recess decompression is done here. So entire C4 lamina is removed now on the ipsilateral side. So now we'll come to C5 ipsilateral. So that's C5 ipsilateral. So just because we have thinned it out, you can just remove. So you can see I'm just removing it, the paper thin lamina here. So any doubts you can ask here. So this is how I do it. This I found it very easy. I've kept the ligamentum flavum intact. Kept the ligamentum flavum intact. This is C5 lamina. C5 lamina completely till the inferior edge removed. That's a pedicle there. That's a pedicle there. So I'm just disconnecting.
So one side hemilaminectomies has been done now, and foraminotomy always also been done. So once this is done, one trouble beginner might face is, so you can see that's opposite side I'm going, I'm just stripping from the opposite side. One trouble beginner might face is, because the sheath is mobile, he should not plunge the sheath into the canal. In lumbar it's okay, dura can take the pressure, but in cervical it is very, very dangerous because cord is bulky. You cannot sit on the thecal sac. So here it's opposite side. I am removing opposite laminectomy of C4. So this is opposite laminectomy of C4. I am going to the joint now. That's a joint. That's a joint. That's a foramen area. So because we have already drilled the opposite, you can see that lateral edge of the thecal sac is nicely seen. If we had not drilled the facet, we could have not seen this and we could have struggled to do the opposite side. See, opposite side nicely the lateral edge of the thecal sac is seen, which usually doesn't happen if you have not drilled this. So just because the facet looks end on and becomes difficult to use a kerrison if you have not drilled it. So here, because of the drilling, it's easy, and you can see that's the lateral edge of the root. So this opposite C4 is over. Then I am going to the C5 level now. So I am just, that's a ligamentum flavum attachment. I am detaching from the lateral capsule. Lateral attachment of the capsule, facet joint capsule. So I just don't want to remove that ligamentum flavum right away. Now I detach the inferior lamina summit. So I'm just going from inferior ipsilateral side now, detaching the lamina summit. So that will be easy for me to go to the opposite side. So that's a inferior opposite side I'm going now. So that's epidural congested vessels. So that's the inferior level going to the opposite side. So now the saline pressure need to be moderated if you want. I used here around 60 because I'm using a Revo-spine scope. I need not worry about the pressure here. It's a Stenoscope I am using with 5.5 working channel. So that's the opposite inferior lamina facet junction. So now I've just kept all the time, I've kept the ligamentum flavum intact. So that I'll remove it at the last. So this way I have epidural bleeding, coagulation, everything I've used very, very less. See that I've detached everything now. Then I remove this entirely as one piece. So this ligamentum flavum, I remove it as one piece.
So entire ipsilateral and contralateral. So there's some attachment here, the fibrous attachment I release ipsilaterally. Yeah. So that's a foraminal area, root area. I just detach it. So no thecal sac handling till now. So now I remove the entire ligamentum phaeum as one piece. So you see here, that's a butterfly. So butterfly in cervical spine, we removed bilateral, dorsal and ventral has been removed. So the advantage is that you have not put a pressure on thecal sac, no too much of RF usage. Once you done this, you just do a hemostasis. You have done your, just try to see the small bleeders. I am using the power as 20, coagulation, ablation 20. So I'll just remove this fibrous tissue, lateral edge of the thecal sac. So that's the lateral edge of the thecal sac. That's the root. Some small bleeders there. Then see any further bone to be removed, you can remove. So big advantage because of the central clearance, you can have a good space here. So that's a small bone, the SAP on the opposite side, opposite inferior. I just do it so till the pedicle edge. So that's decompression. So that's the inferior epidural space. So that's a lateral edge. You can see that's a lateral edge. That's a disc. That's a pedicle. That's a pedicle on the opposite side. Opposite pedicle, opposite lateral. That's inferior ipsilateral. Ipsilateral. That's a pedicle. That's a pedicle. Ipsilateral pedicle. Root. That's a root. So that's a ipsilateral work. So just trying to remove that fibrous band on the root. It's okay, you leave it, no problem. But for the sake of completion, I'm just, that's the root. You can see the root now. So that's the root. That's the root. So you've done a good ipsilateral root decompression, contralateral. That's a pedicle there. That's a pedicle. That's a root. That's a disc. That's a disc there. Patient had some disc hump, so it was a chronic hump, so I didn't remove it. So that's a disc level, so I didn't disturb it. So I just left it. Initially, I thought I will do some later. I didn't do it. So trimming of the hump, I thought I will do it, but there is no need. It was a smooth hump, chronic hump. I just left it. I tried a bit to just enter there and see if I can manage a hump, but later I thought we'll just leave it. So that's a chronic hump which was bony hard. So I just left it. That's a chronic bony hard hump. I just left it. So that's a upper and lower part of the root. So now we have done a good decompression. That's a lower. That's a hump. You can see that's a bony hump. So I just left it. So that's a decompression we have done. So just a small bit of tissue, ipsilateral inferior. I just remove it. So this way, I can do one more level laminectomy also easily. C6 also can be done easily. Suresh, we were discussing once in our forum that opposite side decompression is very important. So opposite side, you need to see the pedicle on the opposite side to have a good decompression. So that's it. I'll just show you how cranial caudal we have come. That's the uppermost level. You can see we have come till C3 pedicle there. C3 pedicle, and here almost till now C6 pedicle. So that's and just will come out. I'm just coming out. You can see that I'm just coming out. Just you see that things are falling apart. I always coagulate when I'm coming out. A small bleeders. This will intramuscular hematoma sometimes causes pain to the patient, which is neck muscles are very sensitive. I just coagulate and come out. So there is no bleed coming out. I just stop the saline, checked, and that's a subcutaneous space. Thank you. So any doubts, you can just, any doubts? Sir, Professor, what are your thoughts on cervical outcomes like the decompressions, ideal cases we choose ideally, correctly? There is no neck pain. So what is your take on your institute policy? Institute policy, and how do you see this as a future technique we can adapt?
Well, first of all, I think whenever you see an indication for a pure decompression, you can do this with an endoscope. Of course, you may get in trouble with, yeah, maybe old-fashioned but very established principles of biomechanics. For example, when you see the spine here, I don't know if it was just through the because of the positioning, because it was in kyphosis.
Yeah.
So when you ask other people, they would say, I have to restore the kyphosis to a low doses, and then maybe my decompression only from posterior is not the solution.
Yeah.
But of course, I totally agree. We always have to think not only in principles. I think we have to judge and draw our attention to each different case and see what is really the problem of the patient. And if I have a possibility to solve the problem of the patient with an endoscopic decompression or procedure, I think there's nothing better than that you can do to a patient.
Okay, thank you. Any questions? And thank you very much. Yeah.
Will it cause instability? When I'm drilling the IAP and coming laterally to expose the nerve root, in 1 or 2 cases, the IAP tip came out.
So, Professor, I think you can answer it better. The question is, when we are doing lumbar decompressions for stenosis, inadvertently you drill too much of facet, so entire descending facet sometimes chips off. So, does this cause problems? So, that's the question.
That's also a question of, I would say, philosophy. Of course, we always say when you resect more than 1/3 or half of the facet, your risk to get an instability is high. Mostly when patients appear to us with stenotic problems, especially in the higher lumbar levels, mostly these patients are elderly patients. And when you have a patient 70 or 75 plus and he has a radicular pain or leg pain problem, I wouldn't care, especially in higher lumbar levels, because of course the shape of the facet is different to lower lumbar levels. And of course, if you're resecting bone and you have to do that to do a sufficient decompression, it can happen that the facet is not existing anymore. But for me, this is more acceptable than to think about fusion to prevent maybe an instability in the future. But I've never seen a patient back after a decompression, at least in our hospital. Maybe they are going somewhere else, who had had a demand for fusion later on, especially these elderly patients. And so I think we have to change our mind a little bit, coming back or coming from this situation, resecting more than 1/3 of the facet demands and fusion. I think this is absolutely okay to do this in elderly patients, to resect more to achieve a sufficient decompression.
So we have to balance, and as you said, it's okay. Need not too much worry about it as long as they don't have back pain. And we initial part of our endoscopic career that happens, then later you try to use your angles better and try to preserve as much as pars and facet as possible, same time achieving the good decompression. Bone, yeah.
Yesterday you told that based on the MRI you will decide how much the facet has to be removed. And first thing is, can you please show that how to do that? And the
Yeah,
second thing is, and if we are going to do in that way, will that help in preventing instability?
No, see, preventing instability is a different thing, but to decompress a root, if you are contemplating endoscopic stenosis decompression, the root traversing root has to be decompressed. If you are not able to decompress whether 1/3 facet or 2/3 facet, it is immaterial. If you have done a 50% of drilling, still you have not decompressed the root. So there is no philosophy in thinking, as Professor just told. Just to protect the facet joint, you are underdoing your work and your outcome is not good. You want to decompress the root, you have to decompress the root, you have to remove the bone there. So there is no logic behind that. Will I leave 1/3 or half or 2/3 facet? So you read on the MRI, you just think that how much SAP is inclined medially, then how much superior facet, that's a ascending facet, I need to drill. So to see the ascending facet, you need to drill the descending facet first. So then you drill the. So one more way is, as a beginner, first you can thin out the bone. To thin out superior, that is the ascending facet first. Then once you open the thecal sac, open the spinal canal, as you come laterally, you can remove the bone how much ever you want. Don't remove the entire bone at one go. So that way you can initially your thought process, get used to this, that I have come lateral to the root. Then you thin out the bone, just bit by bit remove it laterally and see whether you have reached the lateral edge of the root. Once you reach the lateral edge of the root, then you can go cranially. So that way you are always safe. So better is MRI calculation, gives you a rough estimate that how much I need to drill, and also the facet orientation. If facet orientation is more sagittal, then you end up in drilling more bone there. So don't think, keep in mind that 1/3, 2/3, you just leave that concept. Don't worry about it. So as we come to close, I thank everyone making this Spinoscope successful. I thank all the delegates, tough times, who have come from far and also from the local Hyderabad city to attend this 2 days conference. And second thing is, I want to thank all the the industry partners without whom we could have not done this, especially the Intas Pharma, then Avana, Richard Wolf partnership has been there with us for very long time. This is since 2018 we are associated with them. So where it's mutual and this the success major part goes to them also. The credit goes to them. Intas Pharma has always been their backbone of our conferences. Sun Pharma and Cellogenics Pharma, Jeon. Again, Jeon implants always there with us for very long time. Drake Meditech, Abacus Meditech, Mactronic, and MP Medical and Care Ortho. All these, and if I have forgotten few, so all these people without whom support definitely would have not been done. And the hotel, it has been our lucky charm. This is the 6th conference we are doing here. So we thank all the hotel staff for making this conference very successful. No complaints whatsoever. They allow us to complain. So food, stay, hospitality. Thank you very much. And all the team, Asian Spine, the Spinoscope organizing team, Asian Spine Hospital staff who relentlessly been working for last 1.5 months. I thank each one and of the staff and my colleagues, Dr. Padma, Dr. Abhinandan Reddy, and all the team members, my fellows who have been there taking my bashings for last 1 month, editing the videos. So thank you very much. Thank you one and all. And the last and the best part is Madhu. So Madhu Audiovisual has been there with us for almost since 2018. So he's always a go-to person where without whom this conference would have been never successful. Thank you, Madhu, for all the support. He never asks money. So that's the best part of him. So he never asks money. So he's my good friend. So he never asks money. So that's the best part. Thank you, Madhu. Thank you for all the support. And thank you, Professor Martin Comp, for taking pains all the way coming from Germany, accepting our invitation. And I know you had a tough travel, having the first-hand experience of Indian roads and Indian speed. I know I've been there in Germany, so we can't match your speed. But still, I use a German car. But sometime we try to match your speed. Thank you, Professor, for all the time you spent. And I know you are sitting there since morning. Thanks for your wisdom, sharing your wisdom. Thank you once again. So we'll meet again. And my brother Naresh is the idea behind this spinoscope. So he is always the soul of spinoscope is Naresh. Thanks to you, Naresh, for all the support and taking the pains to conduct these conferences again and again. Hope next time it would be better. 3.